इसके में ले
यूट्यूब का तो लिंक भी है लाइव का।
हाँ आप हो गए, आप इस पर चल जाइए, आप यूट्यूब में खोलिए,
हमको लिंक दे दीजिए,
हमको लिंक भेजिए। हाँ
हम अगेन आपको हाई कर देते हैं, बहुत
हाँ।
जरूरी हाई किए।
हाई कर दीजिए। आप खाली देखिएगा तो खाली मोदी सर को और आपको भी दे दे। एक बार अपना नंबर बताइए। हो गया, नंबर बताइए। 947 है ना? हो गया, दे दिए। अभिषेक सर को दे दे ना। हो गया सर, सर वहां आ गया सर।
मिडटर्म कौन सा टाइप कर दो। हमको लगता है हम लोग कन्वीनियंट सब जगह आप उधर पे अप्रूव किए उसका बंदा ही गायब हो गया। छोटा प्रीमियम दे देंगे ऑफिस में।
ठीक है, आप लोग आप देंगे, दीजिए, उसके बाद पीछे पहले आगे दीजिए। हैं मैनेजमेंट में ये पहला सिखाया जाता है। चाय चाय कॉफी ले लीजिए सर, ले लेना। हाँ अभी पहले उधर करेंगे, उधर पब्लिक अवेयरनेस वाला पहले फॉर्म उधर हो जाएगा सर। हाँ पहले आफ्टर 10 बाकी का साइन होगा, उधर 2 घंटा का है। हाँ हम ऑफ कर लेंगे। हम लॉग आउट कर दें।
इसमें लगाई, ये वाला जहाँ था वहां लगाई, कौन तार में था? नहीं नहीं, वो हमको दिए ना वो वाला। हाँ पकड़िए आप, बात करते हैं, पहले जूम वाला देख रहे हैं, ये पकड़ लेते हैं।
इस तरह हार्ट को 24 घंटा ऑक्सीजन की जरूरत है, वो उसकी धमनियों के द्वारा, आर्टरीज के द्वारा हार्ट को जाता है। हाँ सर, नाश्ता कर लिया जैसे हम लोग चालू कर दिए हैं, आप जितना जल्दी आ जाएंगे हम लोग का सौभाग्य है। वहां से 5 मिनट लगेगा सर। हाँ सर, ये हमारे इस कॉन्फ्रेंस के ग्रुप के जो फाउंडर प्रेसिडेंट है, मतलब सबसे बड़े डॉक्टर A.N. राय, जो गया से हैं, ये उनका फोन था। वो भी इसमें सम्मिलित होने के लिए अगले 15 मिनट में आ जाएंगे। वो होटल पहुंच चुके हैं, तैयार हो रहे हैं और 15 मिनट में यहाँ शिरकत करेंगे। तो हम लोग बात कर रहे थे इस्केमिक हार्ट डिजीज की, कि उसको 3 नलियां हैं, वो खून सप्लाई करेगी, उसके जरिए ऑक्सीजन देगा। तो ये होता क्या है, आप सुने होंगे आपके घर में या आस पड़ोस में या कोई आपके जानकारी में होगा कि बहुत सारे लोगों को चलने से छाती में दर्द होता है। चलने से छाती में दर्द होता है, जो कि बाएं हाथ में भी जा सकता है। जब वो रुक जाते हैं तो दर्द खत्म हो जाता है। अर्थात जब मैं बैठा हुआ हूं तो मेरे हार्ट की धमनियां हमको ऑक्सीजन ब्लड के मार्फत देने के लिए पर्याप्त है, लेकिन जब मैं चलने लगा तो हार्ट को ऑक्सीजन ज्यादा चाहिए, खून ज्यादा चाहिए उन धमनियों से, जो कि वो हार्ट की बीमारी वालों को मिल नहीं पाता है। उससे हार्ट में दर्द होता है, जो छाती में होता है, खास करके बीच में होता है, और चलने से वो रुक जाता है, रुकने से वो चला जाता है, क्योंकि तो उसके बाद उसको ज्यादा ऑक्सीजन नहीं चाहिए। इसको सरल भाषा में हम लोग एंजाइना भी कहते हैं। हमको पता नहीं इसका कोई हिंदी वर्ड हो तो, लेकिन हम लोग इसको एंजाइना कहते हैं। दूसरा ग्रुप है, ग्रुप बहुत सारे हैं, लेकिन मैं उसको थोड़ा स्पष्ट करने के लिए, सीधा करने के लिए बोल रहा हूँ, हार्ट अटैक। हार्ट अटैक सुनने से ही हम लोगों को बहुत सारी चीजों का अनुभव होने लगता है कि ये क्या बोला। हार्ट अटैक में मरीज बैठा हुआ ही है और एकाएक उसको छाती में काफी जोर से दर्द होने लगा, धड़कन होने लगी या दम फूलने लगा, पसीना आने लगा, चक्कर आने लगे, उसको हार्ट अटैक कहते हैं। ये तो हुआ क्लासिकल, मतलब कि ज्यादातर लोगों में। लेकिन बहुत सारे लोगों में बिना दर्द के भी हार्ट अटैक हो जाता है। एकाएक दम फूलने लगता है, एकाएक धड़कन होने लगती है, उसको हम लोग पेनलेस हार्ट अटैक कहते हैं। और वो डायबिटीज के मरीज को खासकर होता है। तो पहले ग्रुप में ऑक्सीजन कम मिलती थी, किसी एक या दो या तीनों धमनियों में। हार्ट अटैक में किसी एक या दो या तीनों धमनियों में खून साफ बंद हो जाता है और उसको हार्ट अटैक कहते हैं। उसमें हार्ट को डैमेज होता है और दुर्भाग्यवश ये कुछ लोगों में तुरंत या अगले चंद घंटों में मरीज मृत्यु को प्राप्त करता है। लेकिन बाकी लोगों में 2 से 4 रोज अगर निकल जाए तो समझिए वो बच गया। तो ये तो रहा इस्केमिक हार्ट डिजीज। डॉक्टर साहब ने तो बता दिया कि ऐसे होता है, तो हम करें क्या इसके लिए? तो ये एक तरह की बीमारी दूसरी आपको अच्छी समाचार दूं कि अगर कोई सिगरेट बीड़ी पीता है बहुत ही ज्यादा, वो छोड़ दिया, तो उसको चांसेस हार्ट अटैक की धीरे धीरे घटने लगती है। इसलिए गाड़ी लेट नहीं है। अगर कोई स्मोकर है तो स्मोकिंग बंद कर दे तो संभावना घटने लगती। साथ ही स्मोकिंग से और भी बहुत बीमारियां होती है। उसके बारे में मैं नहीं बात। दूसरा है ब्लड प्रेशर। पहले ऐसा कहा गया कि पढ़े लिखे लोग, धनवान लोग, शहर में रहने वाले लोग, एग्जीक्यूटिव, डॉक्टर, इंजीनियर, ऑफिसर, नेता, इनको ही ब्लड प्रेशर है। ये भ्रांति है। अब गांव घर में रोज काम करने वाला जन मजदूर, किसान, उसको भी ब्लड प्रेशर पाया जा रहा है। संभव है पहले ग्रुप से कम। तो अगर ब्लड प्रेशर की बीमारी है तो आपको अन्य बहुत सारी बीमारियां हो सकती हैं, लेकिन उसमें हार्ट अटैक एक। तो सिगरेट, ब्लड प्रेशर, अगर आपको ब्लड प्रेशर है उसको कंट्रोल में रखिए, नमक कम खाइए। तो ब्लड प्रेशर हमें है क्या नहीं, ये कैसे जानकारी है? तो अगर आपके परिवार में किसी को हार्ट की बीमारी हुई हो, ब्लड प्रेशर की बीमारी हुई हो, तो आपको कम से कम 30 बरस की उम्र के बाद यदा कदा एक बार ब्लड प्रेशर अवश्य कराना चाहिए। दुर्भाग्य ये है कि ब्लड प्रेशर ज्यादा होने के बावजूद भी 50% मरीज को कोई सिम्टम नहीं होता है, न सर में दर्द, न छाती में दर्द, न और कुछ। जब हम लोगों के क्लिनिक में आया और ब्लड प्रेशर जब देखा गया तो मालूम पड़ा इसका ब्लड प्रेशर तो काफी है। इसलिए आजकल जो फैशन चल गया है जंक फूड खाने का, रेस्टोरेंट में जाने का, उसी तरह आपको एक बार चेकअप भी यदा कदा 30 वर्ष के बाद अवश्य करना चाहिए। इससे आपके पैसे की और समय की हानि नहीं। और अगर ब्लड प्रेशर पाया गया तो उसके बारे में हम लोग भी। तीसरा फैक्टर है मोटापा। जितना ज्यादा मोटापा उतनी सारी बीमारी। हम ठेवने के दर्द की बात नहीं कर रहे हैं, हम बात कर रहे हैं हार्ट की बीमारी। अगर किसी का वेट ज्यादा है तो उसको कंट्रोल करना चाहिए। चौथा फैक्टर है खून में चर्बी। आप सुने होंगे इसका कोलेस्ट्रॉल बढ़ गया, तो उसका भी चेक यदा कदा करना चाहिए। जैसे हर दिवाली में आप और माताजी और बहन जी घर में झाड़ू पोछा सफाई करवाते हैं, जाला का सफाई कराते हैं, रूम का सफाई कराते हैं, कपड़े गंदे धुलवाते हैं, बेड का चादर धुलवाते हैं। शायद ये उससे भी ज्यादा जरूरी है कि हम यदा कदा इस चीज को करावें, खासकर अगर आपके परिवार में किसी को हार्ट की बीमारी, ब्लड प्रेशर की बीमारी इत्यादि हो तो। हमारे बीच इस एसोसिएशन के बिहार राज्य अध्यक्ष डॉक्टर उमेश खान जी आ गए हैं। हम इनका हार्दिक स्वागत करते हैं। तो हम लोग, हमारे अध्यक्ष महोदय को मैं सूचित कर लूं कि अभी हम लोग हार्ट डिजीज, इस्केमिक हार्ट डिजीज के बारे में बात कर रहे हैं पिछले 10 मिनट से, और वो क्या लक्षण होता है तथा वो किस लोगों को ज्यादा होने की संभावना है, उसके बारे में हम लोग बात कर रहे थे। और बहुत सारे और फैक्टर हैं, उसमें एक फैक्टर है डायबिटीज, चीनी की बीमारी। आपको जान के आश्चर्य और दुख होगा कि हिंदुस्तान में डायबिटीज की संख्या इतनी बढ़ रही है कि शायद आपके घर में, आपके पड़ोस, आपके रिलेशन, शायद ही कोई ऐसा परिवार होगा जिसको डायबिटीज नहीं हो। और डायबिटीज की वर्ल्ड कैपिटल बन गया है अपना हिंदुस्तान। अर्थात हिंदुस्तान में सबसे ज्यादा डायबिटीज की बीमारियां हो रही है। क्यों, कैसे, शायद हम उसमें नहीं जाएंगे, लेकिन डायबिटीज अगर आप मोटापा हो, अगर आपके परिवार में किसी को हो, तो इसका नियमित चेक अवश्य करवाना चाहिए। तो हम लोगों ने 5 चीजों के बारे में जानकारी दी है। अब इसका इलाज क्या है दवाइयों के अलावा? हर बीमारी सिर्फ हार्ट की नहीं, उस सब में आजकल डॉक्टरों को पढ़ाया जाता है। जो जनता को भी जानना चाहिए वह है लाइफ स्टाइल मॉडिफिकेशन। आज हम नियमित खाना नहीं खाते, या तो हम बहुत व्यस्त हैं, इसमें हमारे डॉक्टर भी पीछे नहीं है, इसमें हमारे डॉक्टर लोग भी पीछे नहीं है। और इस पॉइंट को मैं हर कॉन्फ्रेंस में जानबूझ करके बोलता हूँ ताकि हमको थोड़ी मिर्च लगे और हम डॉक्टर लोग भी इसके बारे में सोचें। सुबह 10 बजे क्लिनिक में बैठे नाश्ता करके, अब 5 बजे तक हमको खाना खाने का फुर्सत नहीं। हम आपकी सेवा में लगे हुए, लेकिन सेवा वो तभी तक सेवा कहलाएगी जब आप अपनी सेवा करते नहीं। अगर आप अपनी सेवा नहीं करते हैं तो भगवान की आपकी सेवा नहीं। इसलिए नियमित खाने से मतलब है उसका एक लगभग टाइम टेबल होना चाहिए। दूसरा, हमारे यहाँ ठूस के खाने की प्रवृत्ति। पत्नी जी 1 रोटी और ले लीजिए, 2 चम्मच चावल और ले लीजिए, आज जरा खीर बना है ले लीजिए, कहाँ फेंकेंगे, खराब हो जाएगा क्या है? तो ये जानना जरूरी है सबसे अच्छा खाना है फ्रूट, कोई भी फ्रूट। सबसे अच्छा खाना है सलाद, कोई भी सलाद, चाहे वो खीरा हो, मूली हो, टमाटर हो, गाजर हो, सब्जी, हर तरह की सब्जी, लाल हरा पीला ब्लू, कोई भी सब्जी अगर आप ये खाते हो तो आपको ये जितनी भी बीमारी बोले हैं, चाहे वो डायबिटीज हो, हार्ट हो, ब्लड प्रेशर हो, किडनी हो, चर्बी की बीमारी हो, सबों से आपको चांसेस बीमारी के घटे। मैं आपको बता दूं एक बहुत ही अच्छी जानकारी, मेरी उम्र आज 74 वर्ष, मुझे लगभग 12 साल से डायबिटीज, मैं अपनी बात कर रहा हूं, मैं इंसुलिन 50 यूनिट से ज्यादा लेता था, प्लस डायबिटीज की 3 तरह की गोलियां खाता। आज तक मैंने हजारों और शायद लाखों डायबिटीज ब्लड प्रेशर के मरीजों को का इलाज किया होगा, लेकिन हमारे जहन में, हमारे जेन्युइन दिमाग में, कान में नहीं, सुनाई पड़ा लास्ट। और ये जितना अभी आपको मैं बताया हूं, सलाद, सब्जी, फ्रूट, अगर आप ये कम कर देते हैं तो पिछले 6 महीने के अंदर मेरी दवाइयां 40% हो गई है, मेरा वजन 5 किलो घट गया है, और इसके लिए सबसे बड़ा डॉक्टर है मेरे बच्चे। ये उनका इनिशिएटिव था, वो सुपर डॉक्टर हो गए और उनके कहने को मैंने कार्यान्वित कर दिया, जिससे कि बहुत बड़ा फर्क। दूसरी चीज है योगा, एक्सरसाइज, वॉकिंग, फिजियोथेरेपी, आपको जो भी करना हो नियमित कीजिए, कम से कम 45 मिनट, ज्यादा की कोई सीमा नहीं है, लेकिन इतना भी मत कीजिए कि अपने आप को एग्जॉस्ट कर दीजिए। सप्ताह में कम से कम 5 दिन, सप्ताह में कम से कम 5 दिन अगर आप ऐसा कर पाते हैं तो शायद बहुत सारे डॉक्टरों से आपको मुलाकात नहीं करना पड़ेगा। और कहावत है, डॉक्टर, पुलिस, वकील और हम लोगों के नए बाप है नेताजी, इन लोगों से जितना दूर रहिएगा उतना खुश रहिएगा। खाना ये सर्वविदित है, सर्व साइंस में पास हो चुका है कि वेजिटेरियन फूड नॉन वेज से बहुत अच्छा होता है। अगर आप नॉन वेजिटेरियन हैं तो जितना एनिमल फैट, चाहे वो मुर्गा हो, मुर्गी हो, क्या क्या होता है, मटन हो, लैम हो, जो कहते हैं, हम तो ठीक से देखे भी नहीं है क्योंकि मैं जन्मजात वेजिटेरियन हूँ। इस सबों में जो चर्बी होती है वो एक तरह की चर्बी है जो ज्यादा हानिकारक, लेकिन वही चर्बी अगर आप मिल्क सोर्स से लेते हैं, चीज में खाते हैं, सॉरी, तो वो थोड़ा कम कर। एक और पॉइंट मैं बताना चाहूं कि हमारे हिंदुस्तान में कार्बोहाइड्रेट, मतलब रोटी, चावल, पुलाव, ये सब खाने की बहुत प्रथा है, प्रोटीन हम लोग भूल जाते हैं। तो अगर आप अंडा खाते हो, चीज खाते हो, प्रोटीन सप्लीमेंट खाते हो, या किसी भी फॉर्म में प्रोटीन खाते हैं, ये जनरल में ये अच्छे स्वास्थ्य के लिए हितकारी है, जिसमें ये सब बीमारियां भी आती हैं। शायद मैं इस जगह रुक जाना चाहूंगा, और आप लोगों में अगर किसी को कोई भी जिज्ञासा हो, कोई भी प्रश्न पूछना हो तो आप सादर आमंत्रित। माइक को बाबू, बेझिझक पूछिए, क्योंकि हमारा कॉन्फ्रेंस का जो ये प्रोग्राम है तभी सक्सेस होगा जब आप जानकारी चाहिए।
सर आपसे आपसे क्वेश्चन ये है, हेलो 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 जी, आपसे क्वेश्चन ये है कि इनका फैमिली में अगर एक आदमी अगर हार्ट से
बिल्कुल नहीं, ये बिल्कुल जरूरी नहीं है। रावण और विभीषण एक ही परिवार के थे, इसलिए अगर किसी को हार्ट की, डायबिटीज, ब्लड प्रेशर कुछ भी हो गई हो तो वो दूसरे को होगी बिल्कुल जरूरी नहीं है। लेकिन उनको प्रिकॉशन लेना चाहिए, कम से कम अपना मेडिकल असेसमेंट कराना चाहिए कि उनको ये सब जो बात कर रहे हैं, डायबिटीज, चर्बी का बढ़ा रहना, ब्लड प्रेशर का बढ़ा रहना, ये सब है क्या। अगर नहीं है तो आप उसी तरह है जैसे जनरल लोग। प्रोस्टेट 40 mm है और आधा घंटा से कम में ही पेशाब हो जाता, और कभी कभी छाती में भारीपन, धड़कन बढ़ जाता, और कुछ ब्लड प्रेशर भी थोड़ा बढ़ा। जैसा कि मिश्रा जी नाम है ना, मिश्रा जी का पहला लक्षण है कि पेशाब जल्दी जल्दी होता है प्रोस्टेट के चलते। तो पेशाब जल्दी जल्दी होने का एक दूसरा कारण है डायबिटीज। तो क्या इनको डायबिटीज है? नहीं है, तो आपको वो प्रोस्टेट की वजह से है। आपका ब्लड शुगर 118 है, रैंडम बिल्कुल सही है। जहां तक छाती के दर्द का सवाल है, आपका जो ईसीजी है वो बिल्कुल सही है, लेकिन ईसीजी का नॉर्मल होना हार्ट की बीमारी नहीं है, नहीं कर सकता। अगर आपको ये दर्द चलने फिरने से होता है तो कभी कभी आप सोच भी सकते हैं, ये कभी कभी दिमाग में भी आता है। लेकिन अगर आपका दर्द चलने से बढ़ता है तो इसमें एक दूसरी जांच होती है जिसको TMT बोलते हैं, ट्रेड मिल टेस्ट। तीसरा टेस्ट होता है ईको, और फाइनली होता है कोरोनरी एंजियोग्राफी। आप वो भी करा सकते हैं, लेकिन अभी तक आपके सिम्टम नहीं है। मुझे यहाँ से अनाउंस करना है कि हमारे अध्यक्ष महोदय, नेशनल जो इस संस्था के संस्थापक है, डॉक्टर एन राय साहब गया से जा चुके हैं। ये हमारा सौभाग्य है कि आज हमारे बीच में इतने बड़े डॉक्टर और इस संस्था के संस्थापक डॉक्टर एन राय साहब आए हुए हैं। हम इनका स्वागत करते हैं। और किसी को कुछ पूछना है? मैं इनको जरा जानकारी दे दूं कि अभी तक हम लोग इस्केमिक हार्ट डिजीज के लक्षण और किनको हो सकता है, क्या करवाना चाहिए, इसके बारे में हम लोग पब्लिक को अवेयर किए हैं। उसी संदर्भ में लोग सवाल पूछ रहे हैं। पूछिए, और किनको पूछना है?
सर आप लोग का काम हो गया तो साइड हो जाइए ना। हेलो,
मेडिकल फ्रेटर्निटी को से ऑर्गेनाइज कराया गया है, और डॉक्टर वाणी से तो मैं उनसे संपर्क में हूँ।
और उन्होंने मुझे बताया कि आज ऐसा कुछ कॉन्फ्रेंस होने वाला। सर मेरे कुछ क्वेश्चंस है कि जैसे आपने बोला कि जो भी सलाद है, सैलेड्स हैं, वो हम लोग खा सकते हैं। तो जैसे एक अवधारणा बनी हुई है कि बाजार में जो भी जमीन के नीचे जो सलाद है, जैसे आपने बीटरूट हो गया या मूली हो गया, क्या हम लोग मतलब ऐसा बोला जाता है कि डायबिटिक पर्सन को नहीं खाना चाहिए, तो क्या ऐसा कुछ रेस्ट्रिक्शंस है?
थोड़ा सा मैं इसके बारे में बता दूं कि बहुत सारी भ्रांतियां भी हमारे समाज में दुर्भाग्यवश चल रही है कि हरा खाएंगे तो ब्लू नहीं, ब्लू खाएंगे तो हरा नहीं, धरती के नीचे खाएंगे होने वाला सामान नहीं तो ऊपर खाने वाला नहीं। अगर किसी को स्पेसिफिक एलर्जी या कोई इस तरह की बीमारी हो तो बात अलग है, लेकिन ब्लैंकेटिव ब्लैंक कि धरती के नीचे का सामान नहीं खाएंगे, शायद ये उचित नहीं है। मैं इसके बारे में हमारे अन्य विशेषज्ञों को प्रकाश डालने बोलूंगा।
ऐसा है कि ये भ्रम है। आपको अपना ब्लड शुगर को कंट्रोल रखने के लिए सबसे पहले डाइट के बारे में जान लीजिए कि डाइट जो है कंसिस्ट करता है कार्बोहाइड्रेट, शुगर, प्लेटेलेट का 50-60% फैट होता है, 25-30% प्रोटीन होता है। तो आपको जो है अपना कैलोरी रिसीव करना, अगर आप लोग खा रहे हैं तो अगर कार्बोहाइड्रेट जो है उसको कम कर, बनाई कुछ नहीं। हाँ, जो बनाई है रेडीमेड शुगर, ये सब बनाई, लेकिन अदरवाइज आप समझ सकते हैं। आप फाइबर के साथ लेंगे तो फल को नहीं ले सकते, फाइबर तो होता है थोड़ा सा लेने से लगा, तो फल के साथ लेंगे तो डीमेज में अंदर लोग कहते हैं ये फल नहीं खाए उसे सब कुछ ले सकते हैं। चावल तो आप बनाई नहीं गया, चावल थोड़ा सा बहुत से डायबिटीज पेशेंट करते चावल खाने के लिए मैं तरह है मैं बिल्कुल खाइए, लेकिन आपको रोटी कम खाती है, चावल लीजिए आपको ऐसा नहीं पहले शुगर में 100% लोगों के बीच में हम जरा सा ये खाना चाहिए हमने स्थापना किया, उसका उद्देश्य पब्लिक को अवेयर करना। क्योंकि देखिए ऐसा है कि
हेलो भाई, हेलो।
आप लोग जानते हैं कि वर्ल्ड की संस्था WHO और उसने प्रेडिक्ट किया है कि बाय 2025-30
हेलो,
क्या बीमारियां
आगे कर जाओ।
नॉन सपोर्टेड डिजीज होंगी। पहले छुआ आ जाती है, हैजा था, कारा था, प्लेग था, ये सब बीमारी होती। अब वो बीमारियां अब हमारे पास जो है लाइफ स्टाइल की बीमारियां, और लाइफ हम इसलिए बोल रहे हैं कि लाइफ स्टाइल से ये जो जितने बीमारियां हैं, चाहे डायबिटीज हो, चाहे हाइपरटेंशन हो, चाहे हार्ट डिजीज हो, ये जो मेजर बीमारियां हैं, इसका दो ही कारण होता है। एक होता है फैमिली, और आपके फैमिली में किसी को है तो होता है। दूसरा जो होता है सबसे बड़ा खतरा है लाइफ स्टाइल। लाइफ स्टाइल अगर आपके फैमिली में किसी को बीमारी है तो आपको अपने लाइफ स्टाइल करना। अब हम एक एग्जाम्पल लेते हैं, दो परिवार, एक ही परिवार, एक आइडेंटिकल प्रेगनेंसी होता है, जोड़वा पैदा हो, एक ही तरह का एक शहर में रहता है और एक देहात में रहता है। जो देहात में रहता है उसको बीमारी नहीं होती सर, और शहर में रहता है बीमारी होती है। इसलिए बीमारी होती है कि हमने अपने लाइफ स्टाइल को बदल दिया है। लाइफ स्टाइल में सबसे बड़ा ये है कि देखिए आपको हेल्दी लाइफ स्टाइल जिसको बोलते हैं, सबसे पहले खाना के बारे में, भोजन के बारे में बताया जा चुका है कि बैलेंस डाइट लीजिए, ग्रीन वेजिटेबल फ्रूट जितना हो सकता है, सलाद ले, सीरियल्स ले बैलेंस लेकर। दूसरा ये है कि आपको अगर रिस्क फैक्टर किसी को डायबिटीज है तो डायबिटीज के पेशेंट को हार्ट बीमारी 4 टाइम्स होता है, आपको डायबिटीज कंट्रोल रखना है। टारगेट ब्लड प्रेशर है तो सबसे बड़ा धोखा ब्लड प्रेशर होता है। ब्लड प्रेशर जो होता है इसको हम साइलेंट करते हैं, उससे साइलेंट करने का ब्लड प्रेशर नहीं जाता और उसको हम दवा देते हैं, दवाइयां बंद करके देखता है तो कहता है कि डॉक्टर दवा खाते हैं नहीं खाते दोनों को तो कोई तरह नहीं पड़ता है। अब वो ब्रेन किसी को लेकर के चला रहे हैं। तो इसलिए हम लोग को कहना है कि देखिए सबसे बड़ा है लाइफ स्टाइल के बारे में है, लाइफ स्टाइल में डाइट हुआ, एक्सरसाइज ये नहीं कि एक्सरसाइज हाफ एन आवर आपको करना है, टाइमिंग आपके ऊपर, आप मॉर्निंग में करें, दोपहर को करें और या शाम को करें, कभी करें। अगर ऑफिस वर्कर है तो आप 6 से 8 घंटा अपने देश में बैठे रहते हैं, वो आपको हर 2 घंटे के बाद उठ करके थोड़ा चलना है, वो बहुत जरूरी है। फिर चलने से क्या होता है कि आपको हार्ट अटैक की बीमारी होने का चांस कम है। सुबह 6 से लेकर 5 बजे तक बैठे रहते हैं, तो हर 2 घंटे के बाद तो ये आपको जो है एक्सरसाइज, डाइट, एक्सरसाइज, बैड हैबिट में स्मोकिंग को आपको जो है आपको सबसे बड़ा ये करना, ड्रिंक को अवॉइड करना, ये सब चीजें हैं। और अपने वेट को कंट्रोल करना। देखिए वेट 2 टाइप का होता है, एक होता है जर्नाइल मोटा होता है, एक होता है कि उसका पेट निकला होता है। हमारे इंडियन सब कंटिनेंट में जो हम लोग इसको मेजर करते हैं जर्नाइल BMI से, आपका BMI कितना है, लेकिन BMI उतना इफेक्टिव नहीं होता जितना हम वेट साइज से करते। अगर आपका वेट साइज मेल में 90 सेंटीमीटर से ज्यादा हो रहा है तो आप इस में 100% आपको रिस्क होगा, तो उसी में ये हो जाए। फीमेल में 80 के ऊपर हो रहा है सेंटीमीटर से, तो वेट साइज से आपने लिए इंडियन सब कंट्री में जो होता है वो पेट निकलता है, दुबले पतले लोग रखते हैं, पेट निकला समझने के बहुत पीछे खा रहा है, किसी को हार्ट अटैक, किसी को सब डायबिटीज सब होता है। तो इसलिए हमको जो है ये जितनी बीमारी, लाइफ स्टाइल बीमारी को हम बोलते हैं, और इसको जो है एक बार हो गई तो हम उसमें खर्चा बहुत लगता है। यही बीमारियां है जो ये जो है नॉन कम्युनिकेबल बोलते हैं, डायबिटीज हुआ, हाइपरटेंशन हुआ, ये जो है इसको हम लोग प्रिवेंट कर सकते हैं या प्रिवेंट नहीं कर सकते। अगर हमारे परिवार में स्कीम में ऐसा है तो हम उसको डिले कर सकते हैं बाई लाइफ, तो लाइफ स्टाइल। धन्यवाद।
पहले हम लोग सवाल ले लें, उसके बाद हमारे अन्य विशेषज्ञ हैं वो भी बोलना चाहेंगे।
गुड मॉर्निंग सर, आप सभी को इस तरह का मौका हमें प्रदान करने की। सर मेरा सवाल ये है कि अगर किसी 58 ईयर्स 60 ईयर के पेशेंट को स्टेंट लगता है, अगर ब्लॉकेज हुआ हो, स्टेंट लगा हुआ है, तो उसको दोबारा उसी जगह पे ब्लॉकेज आने की क्या संभावनाएं हैं? अगर है तो उसका प्रिकॉशंस है।
तो सिंगल वेसल डिजीज है,
यस सर,
उसका इलाज हो चुका है,
यस सर,
क्या स्टेंट लग चुका है,
यस सर,
तो दोबारा चांसेस कम है कि उनको दोबारा होगा, लेकिन ऐसा कुछ भी नहीं कहा जा सकता कि नहीं होगा। कभी कभी वो स्टेंट वाली नली भी ब्लॉक करती है, स्टेंट भी ब्लॉक करता है, और दूसरी और तीसरी नली में भी होता है। उसका एक ही उपाय है कि आपको जो दवाई दिए होंगे डॉक्टर साहब उनको पतला करने का, वो चालू रखें। डायबिटीज, मोटापा, ब्लड प्रेशर इत्यादि जिसके बारे में अभी बात की गई है, वो उसका आप पालन करें तो आपकी संभावना शायद बहुत ही कम है। सेम जगह में ब्लॉक करता है, लेकिन चांसेस बहुत कम है, और अगर ये सब प्रिकॉशन लेंगे तो संभावना और भी कम।
ऐसा है कि अगर 6 महीने में ब्लॉक नहीं किया, टाइमिंग है 6 महीने के अंदर ब्लॉक नहीं किया तो ब्लॉक होने का चांस 20-25 महीने के अंदर होता है। वैसे जो प्लास्टिक के बाद में ब्लॉक होता है, लेकिन जैसे डॉक्टर साहब ने कहा कि चांसेस कम है, लेकिन 6 महीना जो बहुत विकासन होता है, इसलिए उसमें हेवी एंटीप्लेटलेट दिया जाता है।
डॉक्टर राय ने सही कहा, एक बार ब्लॉकेज होने के बाद एक किसी से ब्लॉक हुआ है तो आपको सावधान रहना है कि हमारे शरीर का सभी नस मोटा हो रहा है, ठीक है, वो गर्दन का हो या हार्ट का हो। एक के तो आपने ट्रीटमेंट करवा लिया, बाकी का तो आपने नहीं करवाया, इसलिए आपको उसी समय से प्रिकॉशन लेना है। जैसे डॉक्टर साहब ने बताया कि लाइफ स्टाइल मॉडिफिकेशन या जो दवा दिए हैं वो उसका ठीक से पालन करें, वॉक कर एक्सरसाइज करें तो दूसरी वाली ब्लॉक नहीं होगी, संभावना बहुत कम होगा। और जो डॉक्टर दिया गया है प्लेटलेट पतला, ब्लड पतला करने की एंटीप्लेटलेट बोलते हैं, उसको रेगुलर खाएं, स्टेटिन को रेगुलर खाएं, तब शायद नहीं होगा। जैसे बताया कि फर्स्ट 6 मंथ में ब्लॉकेज होने का चांस 30% 40% आता है, तो अगर वो सब प्रिकॉशन आप ले लिए हैं तो दोबारा होने का चांस कम है, बट सावधान रहिए।
मेरा एक क्वेश्चन है कि कोई बीमार पहले से बीमारी
गैस पर सभी हमारे मंथन निष्पक्षों को मेरा प्रणाम। मेरा एक भ्रम है कि किसी को बीमार पहले से हो, लेकिन अभी जो डाइट में से बताए को चेंज कर देते हैं, फूडिंग हैबिट चेंज कर देते हैं, तो क्या उससे बीमारी एकदम झटपट हो जाएगा, मूल से जड़ से वो खत्म हो जाएगा?
जब वैसी बात हुई थी, बीमारी लाइफ स्टाइल मॉडिफिकेशन से बीमारी नहीं खत्म होगी, लेकिन आपका इंसिडेंस जो है कॉम्प्लिकेशन डायबिटीज जैसे है, केवल डायबिटीज है तो ब्लड शुगर बढ़ा हुआ है, इससे तो कोई ज्यादा दिक्कत नहीं, लेकिन वही डायबिटीज वह ब्लड वेसल्स को डैमेज करता है, आपके आंख के ब्लड वेसल को डैमेज करेगा, आंख चला जाएगा, किडनी को करेगा तो किडनी चला जाएगा, कोलेस्ट्रॉल ज्यादा और भी हुआ तो आपकी धमनियां खराब होगी, हार्ट अटैक हो जाएगा या ब्रेन में स्ट्रोक हो जाएगा। तो कॉम्प्लिकेशन जो होती है कोई बीमारी की वह ज्यादा खतरनाक होती है, इसीलिए लाइफ स्टाइल मॉडिफिकेशन से आपका कॉम्प्लिकेशन कम होगा। जैसे आपको डायबिटीज हो गया, यह नहीं है कि डायबिटीज वाले को किडनी फेलियर नहीं होगा, होगा, लेकिन जो चांसेस है यदि आपका ब्लड शुगर लिमिटेड है, HbA1c कंट्रोल में है, तो आपका किडनी की बीमारी बहुत लेट होगी। यदि वैसे 10 साल में होगा तो हम एश्योर करते हैं कि आपकी दवा अच्छी चलेगी, लाइफ स्टाइल मॉडिफिकेशन रहेगा, तो नॉट लेस देन 20 ईयर्स में आपका किडनी। इसलिए ये हम लोग जो विशेष आप लोग से और आप लोग जाकर के समाज में भी करें, लाइफ स्टाइल मॉडिफिकेशन जो है, जैसा कि डाइट कंट्रोल बताया गया, व्यायाम बताया गया, खाने की में क्या खाना चाहिए क्या नहीं खाना चाहिए, इस सब करने से आपको जो कॉम्प्लिकेशन ऑफ डायबिटीज या हाइपरटेंशन है वह कम से कम होगा। ऐसा नहीं कि नहीं होगा या कोई नहीं होगा। जैसे कि
दवाइयाँ आप दिए हैं,
जैसा कि हमारे सीनियर डॉक्टर देवीराम ने कहा कि डायबिटीज था और इंसुलिन 50 यूनिट तक ले रहे थे, लेकिन इन्होंने लाइफ स्टाइल मॉडिफिकेशन बदला और खान पान की प्रवृत्ति जो पहले से खाते थे उसमें कम कर, सलाद पर ज्यादा जोर दिए और फ्रूट्स पर ज्यादा दिए, तो इनका इंसुलिन का डिमांड जो हुआ वह घट गया। और वह इंसुलिन का डिमांड नहीं है, इन ड्यू कोर्स इनको जो कॉम्प्लिकेशन बहुत जल्दी होता, मैं एश्योर करता हूँ वह कॉम्प्लिकेशन बहुत जल्दी नहीं होगा, बहुत लेट। इसलिए आप लोगों से ये मेरा रिक्वेस्ट है कि लाइफ स्टाइल मॉडिफिकेशन, खान पान पर ज्यादा से ज्यादा जोर दें। दवाई को आपका ऊपर है। अभी कुछ लोग पूर्णिया के साइकिलिंग करते हैं, उसमें 1-2 पेशेंट मेरा था जिसका बीपी मोर देन 180 था। मैं आपको एश्योर करूं केवल साइकिलिंग करते करते उनका बीपी घट गया, उनका वेट मोर देन 1 क्विंटल था और उनका वेट अभी 74 किलो। तो ये क्या है, आपकी दवा भी कंट्रोल है। दवा तो एक सिम्टोमेटिक इलाज है, ये दवा 100% इलाज नहीं है, समझ लीजिए। आपको दवा खा लीजिएगा, आप एस्पिरिन ले लीजिएगा, आपको हार्ट अटैक नहीं होगा। एस्पिरिन खाने वाले को भी हार्ट अटैक होता है, जैसा कि उन्होंने बताया अभी क्वेश्चन किया, ये स्टेंट लगा लिए, क्या स्टेंट लगा लिए तो आपका हार्ट अटैक खत्म हो जाएगा? नहीं, कभी नहीं। आपने स्टेंट लगाया एक वेसल में, हजारों वेसल, 3 मेन वेसल्स है, उसके अलावे भी बहुत से स्मॉल वेसल, और केवल आप एक जगह किए हैं, हार्ट अटैक किया है, डिनोमिनेटर एक ही है, वह कोलेस्ट्रॉल है, वह ब्लड लिपिड है। जब तक उसको नहीं घटाएंगे तो आज हार्ट अटैक हुआ, पेशेंट ऑफ हार्ट अटैक डायड विद द हार्ट ब्रेन इनरेज एंड द पेशेंट ऑफ ब्रेन इनरेज डायड ऑफ द हार्ट माइंड। इसलिए मेरा कल्प्रिट कोलेस्ट्रॉल है, मेरा कल्प्रिट लिपिड है, मेरा कल्प्रिट खाने की प्रवृत्ति है, इसीलिए इस पर ज्यादा जोर दें। आज हार्ट अटैक हुआ तो आप हार्ट अटैक दूसरा नहीं हो, लेकिन आपका ब्रेन इनरेज हो सकता है। इस चीज को आप लोग ध्यान रखें। अभी जो हमारे जो अंडर स्टैंड जो आए हुए हैं कह रहे हैं, उनका जो मिशन है कि हार्ट की बीमारी, हाइपरटेंशन और डायबिटीज बीमारी 70% ऑफ जो मेरा डेथ रेट है उसको कम कर सकता है। इसलिए आप लोग अपने में भी घर पर भी जाकर ये करें कि डायबिटीज ऐसे नहीं है कि डायबिटीज का कोई सिम्टम, प्राय लोग भी है कि कुछ सिम्टम होता है तभी डॉक्टर के पास जाते हैं, ये गलत धारणा है। आपकी धारणा सोच बदलनी होगी। 30 ईयर्स से ऊपर जो भी कोई हो, उनका यह आदत होनी चाहिए कि खान पीन में प्रदर्शित कर दे और कम से कम एक बार डायबिटीज और ब्लड प्रेशर जरूर की जांच कराएं। यह मेरा सब लोगों से अनुरोध है, ये जरूर करें। आप खुद स्वस्थ है, अच्छी बात है, लेकिन आपको कब क्या होगा कोई नहीं जानता, डॉक्टर भी नहीं जानता, आपके घर के डॉक्टर भी नहीं जान सकेंगे आपको क्या होगा। इसलिए
The combination of medicine, food habit और exercise, hypoglycemia में ले जा सकता है।
हाइपोग्लाइसेमिया जो है कर सकते हैं। हाइपोग्लाइसेमिया दवाई से भी होती है, खान पीन जैसे आप दवाई खा लो, लोग हो
सकता है सर,
जरूर हो सकता है। रेगुलर दवाई खाने से भी कभी कभी आप खाना खा नहीं खाए, सब कुछ दवाई एक ही दे रहे हैं, आज दवाई ले ली, आज खाना नहीं बना, आप क्या किए उससे थोड़ा सा सत्तू पीकर चलिए। ऐसा कई बार देखा गया है कि लोग नाश्ता नहीं बना सत्तू पीकर चले गए लेकिन दवाई खा ली, ये भी गलत धारणा है। आप जब भी चीनी की दवाई खाएं उसके बाद कम से कम 75 ग्राम ग्लूकोज के लायक कोई भी खाना, वह 2 चपाती हो, 3 चपाती हो या चावल भी आप खाएंगे। डॉक्टर ने कहा कि चावल बना नहीं होता है, आप लोगों की गलत धारणा है कि डायबिटीज में चावल बना है। चावल खा सकते हैं, चावल और रोटी में 80-100 का ही मामला है। हम लोग ग्लाइसेमिक इंडेक्स में जाते हैं, कार्बोहाइड्रेट कितना उसमें है, चावल में भी और रोटी में भी आप जान लें कि ग्लूकोज है, कार्बोहाइड्रेट है। इसलिए यदि आपको चावल बन गया हो तो चावल कम मात्रा में, यदि वो 4 खाते हैं तो हम लोग 25-20 का 80 करते हैं, उसी तरह आप 60 से 70 ग्राम चावल का खा करके जा सकते हैं। ऐसा नहीं सब कुछ चले गए दवाई खा करके आपको हाइपोग्लाइसेमिया होना नहीं। इसीलिए हर एक डायबिटीज को पॉकेट में 2 चीज रखना चाहिए कि हम डायबिटीज हैं, ये खाने के लिए आपको हो कोई लाइसेंस हो, आपके पॉकेट में ये रहना चाहिए कि हम डायबिटीज हैं। यदि कोई बेहोश हो जाएगा आपके कोई भी कलीग आपको उपचार कर सकते, जैसे हार्ट का बीमारी है, हाइपरटेंशन है, इस सब को भी ऐसा नहीं छुपा कर रखना चाहिए, छुपा कर रखना चाहिए कि हमको डायबिटीज हो गया नहीं बताएंगे, हमको ब्लड प्रेशर हो गया तो लोग जान जाएगा तो क्या करेंगे। गलत धारणा, इस धारणा को बदलिए और ज्यादा से ज्यादा लोग इससे अवेयर होंगे। अभी आपको सुनकर आश्चर्य होगा 30% ऑफ इंडियन पॉपुलेशन जो है अभी हाइपरटेंशन है, उसमें इलाज चल रहा है ओनली 50% का, उसमें भी आपको प्राय लोग 50% से ज्यादा लोग छोड़ देते हैं, लगभग इलाज नहीं करते। इसलिए आजकल हॉस्पिटल में भी आपको चीनी का और ब्लड प्रेशर की दवा भी मिलती है, रेगुलर जांच भी होता है। आप प्राइवेट क्लिनिक में भी प्राय लोग साल में 1-2 बार फ्री कैंप भी लगाते हैं। सदर अस्पताल में भी इसकी सुविधा है कि डायबिटीज और ब्लड प्रेशर का बढ़ सकता है। इसलिए हम लोग का यही है मिशन कि आप लोग जागरूक हो, 30 के बाद हर एक आदमी डायबिटीज और ब्लड प्रेशर की जांच जरूर करें। थैंक यू।
धन्यवाद सर।
सर मुझे थायराइड
पालन का ऑटोइम्यून डिजीज है, उसके कारण की कमी हो जाती है और कुछ लोगों में थायराइड ज्यादा से रहता है जिसके कारण थायराइड बहुत जटिलता है। तो बहुत क्या कारण है जो ऑटोइम्यून डिजीज है और कभी क्यों ऐसा ज्यादा या कम हो रहा है, इसका कारण प्रभाव और माया हम लोग के पास, लेकिन अगर थायराइड की बीमारी आपके हो गई तो नियमित जांच और नियमित इलाज उसका कराते रहना जरूरी है। नहीं कराने से कभी कभी बॉर्डरलाइन दवा के बाद हो जाता है और दवा की जरूरत ऐसा भी देखा है। और लेकिन देखो ब्रांड हाइपोथायराइडिज्म हमारा बहुत ज्यादा है, इसमें दवाई नंबर 1 जीवन भर खाना ही है। और जो हाइपोथायराइडिज्म के पेशेंट है जिसे आप साधारण लगता है उन्हें भी इलाज कराते हैं हम होता है। कुछ नए तकनीक आ गए हैं जैसे जो ट्रीटमेंट देकर जो हाइपोथायराइडिज्म को खत्म कर दिया जाता है, उसके बाद उन्हें दवा की जरूरत नहीं होता। तो फैमिली की बात भी एक उपाय है, उसको रोकना या कैसे नहीं हो इस विषय में अभी हम लोग कुछ नहीं सकते।
और सभी डॉक्टर द्वारा अभी और इसको कैसे
अगर आपका आपकी व्यक्तिगत वर्ष रहता है या रहता है तो ये नॉर्मल है, आप किसी भी चिंता करने की आवश्यकता नहीं है। या अगर 125 या उससे अधिक है तो उसके 2 कारण हो सकते हैं। पंजाब के बात का जो आपका खाना है वो प्रॉपर नहीं है, उसके कारण ज्यादा मिलता है, या लाइब्रेरी का दवाई का वो प्रॉपर नहीं है जिसके कारण पड़ता है। और दूसरा कारण वो भी माना जाता है कि रात को आप जो दवा लेते हैं कि जरूरत से अधिक है, उसके कारण रात्रि नींद रात्रि के बाद आपका ज्यादा काम हो जाता है और बॉडी अपने कंपनसेटरी मैकेनिज्म से ज्यादा तो ये आप अपने चिकित्सक से बताएंगे तो वो इस बात को एसेस करेंगे कि क्या कारण है। आपका लाजमी का खाने का खुराक सही नहीं है, लाजमी का दवा का खुराक सही नहीं है, या इन दोनों के अतिरिक्त दूसरा कारण है कि खुराक में दवा का ज्यादा है जिसके कारण हाइपोग्लाइसीमिया होगा। तो उसको वो सही कर लेंगे और आपका व्यक्तिगत फायदा। हो गया
सेवा आयुर्वेदिक चिकित्सा हूँ और पिछले 1 वर्ष से शुगर मेरा लेवल बढ़ा है। संयोग से अभी तक मैंने कोई दवाई नहीं खाई है, लेकिन मैं जानता हूँ और शुगर का लेवल कभी 145 से करीब 183 तक खाना खाने के बाद रहता है और कभी कभी वो ठीक भी हो जाता है। सब मैं जानना चाहता हूँ कि बिना दवाई खाए ये बहुत मेरा अंडर 200 है और अभी ठीक है, तो इसमें हमको क्या करना चाहिए?
और हम लोग प्रिवेंशन इज बेटर देन बचाव है दवाएं है। तो जीवन शैली के परिवर्तन करने से अगर आप बॉर्डर लाइन डायबिटिक हैं तो आप ठीक हो सकते हैं, आपको दवा की जरूरत नहीं होती। लेकिन इसके लिए अपना जीवन शैली बदलना होगा और जीवन शैली बदलने के लिए पॉइंट्स को बताए गए एक्सरसाइज आज एक्सरसाइज विद मेडिसिन यहाँ फर्स्ट एक्सरसाइज है। दूसरा आपका खान पान, आपका रहन सहन, और तीसरा अगर कोई भी आपको बैड हैबिट्स है लाइक स्मोकिंग, अल्कोहल और सीडेंटरी लाइफ, आप एक्टिव नहीं रहते हैं, हमेशा बैठे रहते हैं। तो अगर आप इन 3 चीजों पर ध्यान देंगे तो आपका जो लेवल है डायबिटीज का और बॉर्डर लाइन डायबिटीज का आपका 180 से ज्यादा नहीं जा रहा है, तो लाइफ स्टाइल मॉडिफिकेशन से आपका कंट्रोल होना चाहिए, हो जाता है। लेकिन अगर सभी प्रयास के बाद भी नहीं नॉर्मल आता है, नहीं कंट्रोल होता है, तो इस स्थिति में आपको दवा अवश्य लेनी चाहिए। ताकि ब्लड शुगर को बढ़ा हुआ करना ठीक नहीं है, क्योंकि डायबिटीज से ऐसे कोई तकलीफ नहीं होती, लेकिन उसका कॉम्प्लिकेशंस जो भी है, उसके जो परिणाम उसमें है, वो सभी बार चाहे डायबिटीज नेफ्रोपैथी हो, किडनी की बीमारी हो, आँख की बीमारी हो, हार्ट की बीमारी हो, जब कॉम्प्लिकेशन हो जाता है तो हम लोग बिगड़ हो जाते हैं। इसलिए बेहतर होगा कि जीवन शैली में परिवर्तन से अगर शुगर आपका नॉर्मल सामान नहीं हो रहा है तो आप दवाई ले। तीन प्रश्न
सर सर मेरे एक और सवाल है। क्वेश्चन कर सकते हैं कि
हेलो, देखिए ऐसा है कि जिसे सभी डॉक्टर्स भी बता रहे हैं, डायबिटीज हम लोग के शरीर का दीमक है, धीरे धीरे आपके शरीर को खा जाएगा। कॉम्प्लिकेशंस, प्रेशर, कोलेस्ट्रॉल, ये उसी का पार्ट है। आपको सबको ध्यान रखना है। स्मोकिंग, लाइफ स्टाइल उसी को ध्यान रखना है। आप एक्सरसाइज आसन के रूप में करें, एक्सरसाइज वॉक करें, स्विमिंग करें, जो भी करें, मोटा मोटी 45 मिनट्स करें। कोशिश करें हफ्ता में 6-7 दिन करने का, तो मिनिमम 5 दिन जरूर करें। इसलिए इसमें कोई कंट्रोवर्सी नहीं है। आयुर्वेदिक खा रहे हैं, होम्योपैथिक खा रहे हैं, तो कोई प्रॉब्लम नहीं है। हमको शुगर कंट्रोल चाहिए, हमको प्रेशर कंट्रोल चाहिए, हमको कोलेस्ट्रॉल कंट्रोल चाहिए। हम वॉक करेंगे रेगुलर, हम रेगुलर एक्सरसाइज करेंगे रेगुलर, और हम स्मोकिंग नहीं करते या खैनी तम्बाकू अवॉइड करेंगे। अगर ये सब आप करते हैं तो हो सकता है धीरे धीरे आपका शुगर कम हो जाए। ये भी हो सकता है, अभी एक टर्म यूज करते हैं हम डायबिटीज रिवर्सिबिलिटी, मतलब आपका डायबिटीज रिवर्स करेगा। अगर आप 7 से 10% अपना वेट कम कर लेते हैं खान पान से, चल के एक्सरसाइज करके, तो संभावना है कि आपका शुगर बहुत कम हो जाएगा, आपका दवाई का मात्रा बहुत कम हो जाएगा। इसलिए इस पर ध्यान रखिए। सभी चीज, चारों चीज पर ध्यान, यही बात ध्यान रखिए कि खाना अकेला भात कोई नहीं खाता है, भात के साथ दाल भी खाता है, सब्जी भी खाता है। इसलिए आपको डायबिटीज के साथ, शुगर के साथ साथ कोलेस्ट्रॉल, शुगर के साथ साथ अपना ब्लड प्रेशर, शुगर के साथ साथ अपना बैड हैबिट, ये सबको भी ठीक करना होगा। अगर ये सब आप ठीक रखेंगे तो संभावना है कि आपका ब्लड शुगर काफी कम हो जाएगा। आपका कॉम्प्लिकेशन जो 5 साल में शुरू होता है, 10 साल में शुरू होगा, हो सकता है आपको कॉम्प्लिकेशन नहीं हो, क्योंकि किडनी फेलियर 100 में 100% वो नहीं होता है। किडनी फेलियर 100, 30%, 20%, 40% होता है। इसलिए अगर आप ये सब परहेज करेंगे तो लाइफ लॉन्ग आप निकल जाएंगे। हम लोग समझते हैं कि आज इंडिया का लाइफ एज जो है मोटा मोटी 70 साल है। अगर आप 70 पार कर गए और आपको कोई कॉम्प्लिकेशन नहीं हुआ तो आप बहुत भाग्यवान है। और कोशिश कीजिए कि आपकी आयु और लंबी हो, अपने लाइफ स्टाइल ठीक करिए। थैंक यू।
तो हम लोगों का जो मिशन है, आप लोगों को, केवल आप लोगों की, आप लोग वॉलंटियर्स हो, आप लोग अपने भी जो जहाँ समाज से आए हैं वहां जाकर इस बात का और भी विचार करें, सब लोग को समझाएं कि ये बीमारी जो है साइलेंट लीडर है, चीनी और ब्लड प्रेशर, इसका जांच मुफ्त भी होता है। हर एक 20 वर्ष से ज्यादा उम्र के लोग जरूर ये जांच करावें। और जहां तक हो सके सरकार की तरफ से भी है, हम लोग की भी है, धूम्रपान, अल्कोहल, इस सब को त्याग करें। और व्यायाम, और ऐसा तो प्रचलन भी चल गया है और बहुत से लोग हमारे दुनिया के मॉर्निंग वॉकर्स हैं, मॉर्निंग वॉकर्स एसोसिएशन भी हो गया है। इसके हमारे जो कर्नल साहब थे, बहुत ही इस चीज को, मॉर्निंग वॉक्स को बढ़ावा दिए और आज उसमें बहुत से लोग मॉर्निंग वॉक कर रहे हैं। इसलिए आप लोगों से यही हम लोग का गुजारिश होगा कि आप लोग ध्यान रखें और जो लाइफ स्टाइल बातें इसका अमल करें। धन्यवाद।
मेडिकल कॉलेज हम
सीसीडीएस के तरफ से आप सभी जितने भी दुनिया के साथी हैं से आए सबको धन्यवाद हम देते हैं कि आप लोग यहाँ आए और हम लोग में आपको जानकारी दी है। हमारा उद्देश्य ये है कि अभी पहले इंडिपेंडेंस के पहले 50 साल के ऊपर बन जाए ये हम लोग सकता है हमारा और उसके लिए जो है ना आपको एक चीज बता दें डेवलपिंग कंट्री और डेवलप कंट्री डेवलप कंट्री के आगे और वो मिलेगी और वहाँ पर कम होने लगा वो चेक कर दिया एक प्रधानमंत्री है जो साइकिल से जाते हैं तो वो आपको फास्ट फूड नहीं चलते तो हम सबसे बड़ा लेके ठीक से रखेंगे डॉक्टर हम लोग का बहुत लोग के बारे में ये करते हैं सारे ग्रेड क्यों कर रहे 30 साल के बाद 4 में एक बार तो पढ़ना ही पढ़ना इसलिए जो है और सबसे बड़ा बात है कि जल्दी नहीं देता बेटी पढ़ेगा और जब तक ये नहीं देता तो फिर हमें होता हार्ट अटैक होता है हमको ये नहीं कमाल से यहाँ पे सही नहीं होता तो हम लोग आगे डॉक्टर भी हमारा हम लोग रेगुलर स्क्रीनिंग करेंगे 3 से 4 महीने का डायबिटीज ब्लड प्रेशर और हमारा अभी जो बीमारी है उसको हम लोग देखें और दूसरा ये कि लाइफस्टाइल के बारे में जो आने वाला चाहिए और बहुत संक्षेप में सभी लोगों को बताया कि आपको आहार आपको एक्सरसाइज और बैड हैबिट को छोड़ना है स्मोकिंग ड्रिंकिंग ये करिएगा तो आप स्वस्थ रहिएगा उम्र जो है आप दिन भर अगर आपको बीमारी है तो लाइफ स्टाइल का बीमारी 100% कंट्रोल नहीं है जो भी कंट्रोल होता है और दवा कंट्रोल भी करना है जैसे बताया वेट बहुत लोग डायबिटीज कम हो सर्जरी कराया मतलब 20 kg 30 kg वजन कम हो गया डायबिटीज कम गया खत्म हो वेट तो ये जो ऐसा बीमारी जो है हम लोग का इलाज जो पारिवारिक जीत से आता है उसको तो हमारे पास है नहीं और उसको तो हम कुछ कर नहीं सकते लेकिन हमको उसे सावधान रहना चाहिए फैमिली में अगर किसी को बीमारी है परिवार में बीमारी है तो हमको सावधान रहना चाहिए आप अपने लिए दूसरे जो है समय निकालिए फिर वो काम जब आपको मौका हो आप बनाओ फायदे के लिए धन्यवाद।
आप सभी का धन्यवाद जो इस सेशन में आए और ज्ञान वर्धन अपना किए और बहुत सारी क्वेरी तो रह गई हम लोग किसी समय और देखेंगे। प्रेस मीटिंग के लिए जो आए हैं प्रेस रिपोर्टर वो लोग ऊपर है वहीं पे अंत में मैंने एक कविता लिखी थी बहुत पहले पब्लिक जागरूकता के लिए और चाहूंगा कि फिर से मैं शेयर करके सुना भी चुका हूँ। जैसा बताया गया कि डायबिटीज का कोई लक्षण नहीं होता ये बीमारी पता नहीं चलती जब बहुत ज्यादा शुगर बढ़ जाता है तभी ये सिम्टम होता है। तो और जैसा हम लोग जानते हैं कि हम लोग डायबिटिक कैपिटल है वर्ल्ड में जिस तरह की पॉपुलेशन हम लोग की सबसे ज्यादा हो गई और कुछ ही दिनों में डायबिटीज के रोगियों की संख्या भी विश्व में सबसे ज्यादा होगी और होगी भी क्योंकि हम लोग के यहाँ अवेयरनेस की कमी है। हमारे आधे लोग को पता ही नहीं कि उनको डायबिटीज है क्योंकि रेगुलर चेकअप कराते नहीं। तो मैं जल्दी से अपना वो राइटअप शेयर कर देना चाहता हूँ क्योंकि समय हो गया है कि जरूरत से ज्यादा अगर लगे प्यास बिना वजन घट रहा था वजन घट रहा बिना वजन खास बार बार चश्मा बदलाए घाव जल्दी घर न पाए हो जा होशियार डायबिटीज के लक्षण है इसका कराओ उपचार। श्रम रहित जीवन उम्र 40 पार श्रम रहित जीवन उम्र 40 पार 130 कर देना चाहिए परिवार में डायबिटीज वजन अपार, परिवार में डायबिटीज वजन अपार, बढ़ा हो बीपी कोलेस्ट्रॉल है, बढ़ा हो बीपी कोलेस्ट्रॉल है, हो जाओ होशियार, डायबिटीज का खतरा है, इसका कराओ उपचार। अंधापन किडनी की खराबी, अंधापन किडनी की खराबी, बाधित होती रक्त वाहिनी, हार्ट अटैक और पक्षाघात, न्यूरोपैथी कर देता जीवन बेचार, हो जा होशियार, डायबिटीज के दुष्प्रभाव है, इसका तुम कराओ उपचार। लेकिन इसके नियंत्रण है आसान, लेकिन इसके नियंत्रण है आसान, कुछ मंत्र है इसको पहचान, लेकिन इसके नियंत्रण है आसान, कुछ मंत्र है इसको पहचान। पहले बंद करो अपनी मुट्ठी, कमर कस हो जाओ तैयार, फिर निकालो अपनी उंगली चार, फिर निकालो अपनी उंगली चार। पहली उंगली आहार नियंत्रण, पहली उंगली आहार नियंत्रण, जैसा सब लोगों ने बताया कि थाली अपनी भरो प्रोटीन से, थाली अपनी भरो प्रोटीन से, कार्बोहाइड्रेट को कम करो, चर्बी भोजन मीठा बंद करो, सब्जी चाहे जितना खाओ। दूसरी उंगली है व्यायाम का, दूसरी उंगली है व्यायाम का, चाहे दौड़ो नाचो खेलो, याद रखो 30 मिनट रोज 5 दिन सप्ताह, 30 मिनट रोज 5 दिन सप्ताह। तीसरा सही खुराक की दवा तुम खाओ, चौथी अपनी नियमित चेकअप कराओ। बन जाओगे यदि तुम होशियार, डायबिटीज को कर दोगे तुम तड़पार। साथ में याद रखो डायबिटीज की एबीसी, A1C बीपी चर्बी, A1C HbA1c बीपी और चर्बी, तीन चीज की आप एबीसी की जरूर जानिए, ये नियंत्रण में रहना चाहिए। डायबिटीज की एबीसी, A1C बीपी चर्बी, इसको यदि नियंत्रण कर लो तो डायबिटीज की। बहुत बहुत धन्यवाद आप लोगों का। अभी पब्लिक अवेयरनेस प्रोग्राम को यही समाप्त करते हैं, फिर मिलते हैं।
और बहुत अच्छी कविता पढ़ी है हमारे अनुज आदरणीय डॉक्टर एस के मिश्रा ने। कहा जाता है कि खाना को आधा करो elderly diabetic, my first case, this is a, it's a fourth part deficiency in must. Since our society is clinical cardiac diabetes society, so we are not going to for hi-fi. The basic thing, ECG. So I'm going to present interesting diabetes cases based on ECG. And the first ECG case is elderly diabetic male presenting with severe burning pain in chest with sweating and restlessness in 3 hours. He came to AIMS emergency for admission and treatment. Before he could be shifted to ICU, he had sudden fit with convulsion lasting for a few seconds. His pulse was feeble and BP not recorded. ECG is given below. What is the diagnosis? So you can see this ECG. What is your diagnosis? This is a very this ECG has been present not because of you can see acute inferior ischemia. This is very simple. We have selected this case. This is a diabetic patient. We have not selected this case for acute inferior ischemia. Simple. Then there is some other thing. What are the other things you will see? Yes, actually it is not a complete heart block because there is no P wave. In complete heart block there should be multiple P wave. P wave was absent and there is a tall T wave regardless. So in the case of diabetes, there is associated hyperkalemia. And this patient next slide is you can see. What happened? Something wrong? नहीं हो रहा इस एक कम नहीं आ कोई फर्क नहीं इसमें नहीं आ इसी से आएगा you can see the report blood sugar was 226 serum creatinine 2.80 and serum potassium was 6.2 so So this is a echo finding which shows characteristic regional osmolality in inferior leads. Management. Patient was put on TPI and hyperkalemia was managed medically by giving IV calcium, nebulization and IV glucose and insulin. In addition to dual antiplatelet and 80 mg atorvastatin, he was thrombolized by retiplase. His diabetes was managed by insulin. He recovered within 24 hours and his ECG is given below. This is a report. Serum potassium has come to the normal, and this is the ECG. So the message, you see why the first ECG why in hyperkalemia, tall T wave appear first, then there is a flattening and disappearance of this P wave. This is very important, and you can call it nodal rhythm. So nodal rhythm is absent P wave. So nodal rhythm was there, but tall T wave, and in the case of diabetes, this is a diabetic patient. So always think diabetes patient, once he has a heart, he must have also kidney problem. And that was the reason. Now next case. ECG immediate diabetic male presenting as severe chest pain since 3 hours. Diagnosis and management. Again, I have selected both tall T wave. Tall T wave. Do you think it's hyperkalemia or something else? It's not a hyperkalemia because you can see P wave and patient presenting with a tall T wave in precardial leads following a severe acute chest pain is a feature of acute myocardial infarction. This ECG pattern we call it the winter pattern. Tall T wave. Initially, previously it was called hyperacute myocardial infarction. Hyperacute myocardial infarction. But now we call it the winter pattern ECG. This is equivalent to LAD obstruction, left anterior descending artery. So left anterior descending artery blockage is there, and this is the characteristic of blockage of left anterior descending artery. And you can see next ECG. Again, the winter ECG pattern is an anterior STEMI equivalent that present without obvious ST segment elevation. First reported by De Winter in 2008. Key diagnostic feature of De Winter pattern include ST depletion and peak T wave in the precardial leads. De Winter pattern is seen in 2% of acute LAD occlusion, left anterior descending artery. So in 2% of left anterior descending, this is presentation. And just see, after this patient was thrombolized, and you can see there is a QS pattern appear. So this was why it is important to present here, because you may hesitate in thrombolysis because there is no classical ST elevation. There is no classical ST elevation. So you think whether whether we should thrombolyze or not. I think we should thrombolyze as early as possible. And after thrombolysis, you can see the changes. Now, this is again, it's a 35-year-old diabetic male was admitted with a history of weakness and giddiness since morning. On his pulse 40 per minute, BP 160 by 100, his ECG came well below. It is a characteristic hyperkalemia. There is no problem. You can see severe hyperkalemia characteristic, no P wave, tall T wave. But why I presented this case, you will come to know later. Investigation blood sugar 300 milligrams, serum creatinine 3.5, serum potassium 6.5. Patient was managed conservatively by giving IV calcium and insulin. He was advised dialysis when he did not show improvement, but refused. Normally, what we do? We first do medical management by giving calcium, glucose, insulin, nebulization. That is a medical treatment. If the potassium does not come down, we advise for dialysis. This patient refused dialysis. And what happened then? He developed this ECG. What is this ECG? Is it VT or something else? Actually, it is not a VT, it is a cine wave. This is it is a cine wave. It is due to merging of wide QRS complex and wide T wave. This is called cine wave. It is not very common, but I presented this case. This case, we have treated this case. Most of you might not have seen this cine wave, but this is a cine wave. This is a cine wave due to merger of white QRS complex with white T wave. Serum potassium was 7.7. Patient was saved after he agreed for dialysis. After this, patient agreed for dialysis and he was saved. And after dialysis, this is the ECG. Elderly diabetic male presenting with fits since 1 day. What is diagnosis and management? ECG given below. Recurrent fits. What does ECG shows? This shows RBV left anterior hip block. So it is a bifascicular, but it is not a classical RBV. There is something we call it. Yes, Dr. Midterm, it is a muscarinic bundle branch block. It is severe degree. What does muscarinic? I will tell you, muscarinic is right bundle branch block in the precardial leads standard and left undulating branch block feature in the limb leads. You can see there is no S wave. White R wave in lead 1 AVL, but there is no S wave. Normally in RBB there should be a S wave. There is no S wave. So this is called masquerading bundle branch block. This is a high degree of bifascicular block, and this patient goes into complete heart block anytime, and he requires urgent pacing. That's very important. So actually this is, and there are two types, standard one and precardial masquerading bundle branch block, which I am going to diagnosis standard masquerading bundle branch block. RBB pattern in precardial leads, LBB pattern in limb leads, is small or absent S wave in lead 1. This is very important. Lead 1 is, normally lead 1 should have S wave in RBB, wide S wave. So this is standard masquerading, and then the also precardial masquerading bundle block. It's in RBB pattern in V1 to V3 and LBB pattern in V5, V6. So this patient requires urgent pacing. Patient requires urgent cardiac pacing since machine BBB suggests high degree of bifascicular block. Case 5. Medial diabetic lady presenting a sudden chest pain, palpitation, giddiness with setting restlessness since one and a half hour. On examination, she had feature of shock and cold limbs with absent pulse and BP. Her disease is given you. What is your diagnosis and how will you manage? This is a VT. This is a classical VT. And after post-DC shock, you can see this patient had acute anterior STEMI presenting with VT. Presenting with VT. Diabetic patient, they present always seriously. That is important. And management is primary angioplasty, thrombolysis, and management of diabetes. Elderly diabetic female admitted in ICU for of AIMS with sudden palpitation and severe breathlessness in 4 hours. She gave history of breathlessness since 3 years. And this is her finding, and ECG and etc. are given. Again, this is ECG. Is it also BT? No, it's atrial flutter with 2:1 block. You can see limb leads, lead 2 is atrial flutter with 2:1 block. This is a cardiomegaly. Actually, this patient was of DCMP. This is echocardiography finding. This is the management we have gave. And you can see this patient has already LVB pattern. The baseline ECG had LVB pattern. That's why it was there. Wide. So atrial flutter is 2:1 block. It was not a VT. Already, because in VT, the patient, once you give shock, patient will sinus normal QRSL. Here, the patient is already having, and this pattern was on that LVB pattern. Thank you.
Thank you. Thank you, Professor Dr. Rai, for your brilliant. Hello. Thank you, sir, for your brilliant presentation and some common and some rare cases of ECG and presentation. The house is open for any query or any question.
Yes.
Anyhow, the discussion will be after completion of the papers session of this session. Now I request Dr. P.K. Sinha, a very good friend of mine, the professor at Gaya Medical College. He is going to present heart failure management beyond symptomatic relief.
Well, friends, ladies and gentlemen, honorable chairpersons, management of heart failure, as you all know, management begins with a diagnosis, which requires assessment of clinical feature of heart failure, looking for ECG changes, looking for NT-proBNP and BNP rising level, finally to echocardiography, which will help you to decide whether it is heart failure with reduced ejection fraction, that is less than 40, heart failure with mildly reduced ejection fraction, that is ejection fraction between 41 to 49, and heart failure with preserved ejection fraction, that is ejection fraction above 50. And thereafter, you need to evaluate, is there any precipitating factor or not, and then you have to begin with the management. Friends, ladies and gentlemen, symptomatic relief is brought about by the use of diuretics to deal with the volume status and congestion. Before 2017, the foundational therapy of heart failure was based on ACE inhibitor or ARB, beta blocker, and MRA. After focused guideline 2017 came with the ARNI, which required replacing the ACE inhibitor or ARB whenever it is needed. And whenever you fail to achieve the target, well, in a specific situation, hydrogen and isosorbide dinitrate, ivabradine, and CRT has to be used. Friends, ladies and gentlemen, this foundational therapy with ACE inhibitor, beta blocker, and MRA is well based on pathophysiology of heart failure and is well supported by the clinical trial. As you could see, damage to the heart failure results into up functioning of RAS and SNS system, which is blocked by the ACE inhibitor and beta blocker. And so the remodeling is taken care of. The better effect comes from the neprilysin, which prevents the remodeling, but this neprilysin is a short-lived element. So we need to block it to get the better effect of the neprilysin, and so the neprilysin inhibitor, sacubitril, comes in. These pathophysiological findings and this therapy is well supported by the clinical trials. As you could see, the ACE inhibitors, a meta-analysis report that 23% reduction in mortality and 35% reduction in the combination endpoint of mortality and hospitalization for heart failure with ACE inhibitor. Copernicus and SOLVE trial has supported this. Beta blocker gives you additional 35% reduction in mortality on the top of the benefit provided by the AC alone. As you could see, the AC carbidopa trial, CBIS trial, and Copernicus trial, and MERIT-HF trial. Well, friends, ladies and gentlemen, in a specific situation with NIHA class 2 to 4, creatine clearance more than 30, and potassium level less than 5, if you use aldosterone or eplerenone, this significantly reduces the morbidity and mortality. Friends, ladies and gentlemen, over this now, the paradigm HF trial came with the result that sacubitril valsartan gives you better result, lesser event rate compared to enalapril. So, friends, ladies and gentlemen, as you could see, the sacubitril gives you over 20% more than better result with as compared to the ACE inhibitor. So, combining ACE inhibitor, beta blocker, and MRA is better now switched on to ARNI beta blocker and MRA that will give you a better result. In a specific situation where the ejection fraction is still lying less than 35%, patient is symptomatic, heart rate is lying more than 70, and patient is sinus rhythm, ivabradine has to be used to get the better result. And you could see, well, in the SIFT trial, it gives you a lesser event rate. In a specific situation in African people, this nitrate hydrogen combination has to be used. And in our setting, where AC inhibitor could not be used for the side effects of or contraindicated, we can well use this nitrate and hydrogen combination for heart failure. Well, friends, in 2021, important breakthrough came in with the expanded role of ARNI and approval of addition of SGLT2 inhibitors. Well, friends, you could see recent data from clinical studies along with the aggregate clinical experience suggested that directly initiating an RNA rather than a pre-treatment period of AC or ARB is a safe and effective strategy. Well, friends, these data include their use as a de novo therapy in some patients, NAP to AC or ARB therapies, evidence for rapid improvement in patient-reported outcome measures like symptoms, physical functioning, and quality of life, and the demonstration of a reverse remodeling effect of RNA in chronic heart failure with reduced ejection fraction independent of background therapy with AC and ARBs. Well, friends, DAPA-HF trial and Imperial reduced study demonstrated a reduction in HF hospitalization and severe death in dapagliflozin and empagliflozin treated patients respectively. Coming to the clinical trials, if you go through the PROVE-HF trial and the PIONEER-HF trial came with the result that in hospital initiation of sacubitril valsartan in stabilized patients with acute decompensated heart failure and reduced insuffisance, irrespective of prior AC and ARB use or prior HF diagnosis. So you can use this in a stabilized patient in hospital. You do not wait for pre-treatment for AC or ARB inhibitors. Coming to the SGLT2 effect, dapagliflozin trial study demonstrated that among 4744 patients with heart failure reducing fraction, the risk of worsening heart failure or death from CV causes was lower among those who received dapagliflozin than among those who received placebo. In addition, dapagliflozin demonstrated a significant reduction in each of the individual components of the composite endpoint with a 30% decrease in the risk of experiencing a first episode of worsening heart failure. So hospitalization for heart failure or urgent hospital visit and an 18% decrease in the risk of severe death. So coming to the empagliflozin Imperial reduced trial in which 3,730 patients with chronic heart failure with reduced ejection fraction were randomized to empagliflozin with placebo. It was found to significantly reduce the composite endpoint of severe death or HF hospitalization in adults without diabetes. The trial also showed that treatment with empagliflozin showed a decline in eGFR over time. A subsequent meta-analysis of DAPA-HF and Imperial reduced suggested that the effects of empagliflozin and dapagliflozin on hospitalization for heart failure were consistent, and these agents reduced all-cause and severe death and improved renal outcomes in patients. So friends, after 2022, there was a change in the paradigm of the treatment. So before AC inhibitor, ARB and beta blocker, and MRA, ARNI was used as a replacement therapy to AC inhibitor. But later on, after 2021 update, ARNI, AC or ARB, we should need to begin with the ARNI therapy. Then we add beta blocker MRA, and of course, the newer one. So ARNI became the regular fashion treatment, and SGLT2 was added to the list. So present situation, we have about 4 pillars of therapy: RD, SAB, ARB, beta blocker, MRA, and SGLT2 inhibitor for heart failure. Friends, ladies and gentlemen, additional therapies for patients with heart failure, reduced ejection fraction. So any patient, as we already detailed with ivabradine, patient with NIHA 2 and 4, ejection fraction less than 45, recent heart failure hospitalization, or when you are used to go for IV diuretics, elevated NP levels, we can use a newer drug, what is known as vericiguat. Symptomatic heart failure, you can use digoxin if the symptom is not being improved. Heart failure with NIHA 2 and 4, PUFA can be used for better effect. Patient with heart failure with hyperkalemia, while taking RAS inhibitor, we need to use potassium binders. So friends, but then friends, no, it is not sufficient to use all the 4 pillars to achieve the maximal benefits of GDMT or in patients with chronic heart failure. Therapy must be initiated and titrated to target and maximum tolerated dose. This is what is the most important aspect. So friends, you could see, so these are the initiating dose, and of course, this is the target dose. For example, you could say the metoprolol, the initiating dose only 12.5 to 25 milligram, and the target dose we have got 200 milligram per day. For example, you can sacubitril, the initiation dose is 50 milligram BD, and target dose is 100 milligram or 200 milligram BD. For example, you could see the ramipril, 1.25 milligram is the initial dose, where the target dose is 10 milligram per day. Valsartan, if you use 40 milligram twice daily was the initial dose, and 160 milligram is the target twice daily is the twice dose. You spironolactone, 12.5 to 25 milligram is the initial dose, where you can go for double dose for the target. Well, friends, dapagliflozin, empagliflozin, well, the initial dose and the target dose remains the same, 10 milligram and 10 milligram. So, friends, ladies and gentlemen, we need to start with the initial dose, and we need to reach the target dose to provide the benefit of the mortality effect. Friends, few examples we'll take, the important drugs we will be taking here. The RNA1, if previously on AC inhibitor, ensure 36 hours off before initiation and select the starting dose. How to select? You have to replace the AC inhibitor. So if patient is taking equivalent of less than 10 milligram daily of enalapril or less than 160 milligram of valsartan, start with 50 milligram BD. If more than 10 milligram equivalent of enalapril or more than 160 milligram of valsartan, start with 100 milligram BD. So we will monitor BP, electrolytes, and renal function after initiation and during titration. Consider increasing dose of RNA, AC, ARB, beta blocker stepwise every 2 weeks until maximum tolerated dose or target dose is achieved. So friends, here we'll do only one, the SGLT2, ensure EGFR more than 30 for dapagliflozin and ensure more than 20 cc the EGFR for empagliflozin. Remember the barriers to medication, hypertension, comorbidities you need to deal with, abnormal renal function, hyperkalemia. If it is there, treat with low potassium diet and new potassium binder like patriumab and sodium zinconium crystolite. So how to follow up? Evaluate every 2 weeks. Thereafter, every 3 to 6 months. Echo has to be done after 3 to 6 months, and repeat imaging can be useful in making decisions regarding device therapy, implantable cardiovascular defibrillator, CRT, or transcatheter mitral valve repair. So friends, so coming to the CRT, patient on ECG showing QRS more than 130 in LVB, you need to go for CRT. In a non-LVB case, QRS is more than 150, it will be useful, and in non-LVB case, between 130 to 149, it may be considered. Friends, if you could see, the ICD can be used for primary prevention in patients with IHD 40 days past MI or DCM with LVF ejection fraction that is less than 35 in NEHA class 2 to 3, despite chronic GDMT for more than 3 months. For secondary prevention, it is also useful. Friends, the additional device therapy, you can use the additional device therapy like Mitra clip and other one as the specific need. Well, as we have already dealt with the definition part, we have got a section of mildly reduced ejection fraction. Friends, diuretic is the treatment. SGLT2 has the class 2A management therapy, and then the AC inhibitor and MRA has to be used, and evidence that beta blocker will be helpful here in mildly reduced ejection fraction failure. A very important section we always fail to diagnose. So the first point to highlight here is you must take care for every dyspnea patient who has got unexplained, which is unexplained, and has got comorbidity like old person, a female person, a CKD patient, a hypertensive patient, patient suffering atrial fibrillation, but still the cause is not explained in dyspnea. Think for heart failure with preserved ejection fraction. And because there is no specific treatment, so screen for and treatment of etiology like hypertension, atrial fibrillation, IDN, CKD, and CAD will make the basis of treatment for heart failure, ejection fraction, and diuretics gives you the symptomatic relief. So friends, the beside diuretic, SGLT2 inhibitor is a class 2A. In patient of heart failure, preservation can be beneficial in decreasing HF hospitalization and severe mortality. ARNI, MRA, and ARB, well friends, in selected patients of heart failure or preservation fraction may be considered to decrease hospitalization, particularly in patients with LVF on the lower end of the spectrum. Friends, why this is? Why all the drugs very, very useful in cases of heart failure with reduced fraction is not so beneficial in heart failure with preserved fraction, because the pathophysiology is different. Here, it is the systemic inflammation and coronary vascular inflammation plays an important role in bringing up the diastolic dysfunction. And these all are taken care by the SGLT2 inhibitors. And so it is being well prescribed for heart failure. Nowadays, the similar effect is also being demonstrated with GLP-1 receptor antagonist and is in the pipeline for heart failure with preserved ejection fractions. Well, friends, management of heart failure with selected comorbidities, I will not go in details of everyone. One very important which would I like to highlight is the iron deficiency anemia, very commonly found in heart failure patients. So this iron deficiency anemia must be treated with IV iron. That is one important message to everyone, because this iron deficiency anemia deteriorates heart failure, and heart failure itself causes iron deficiency anemia. So we need to go for IV iron therapy in cases of iron deficiency anemia. Friends, ladies and gentlemen, even if you get a symptomatic relief achieved at lower dosage of ARNI, AC or ARB, beta blocker, SGLT2I, up titrate to target dose for full disease modifying effect. That is the most important message. Don't leave the patient at the lower dose. Even if he is symptomatically free, go on up titrating to target dose to give the benefit, full benefit of disease modifying effect for the patient and so reduce the mortality. Friends, add additional therapy, ivabradine, hydrogen isosulfide dinitrate, lanoxin, vericiguat as and when needed. Consider device therapy soon appropriate. And friends, lifestyle modification, that is proper education of self-care and exercise program to better the heart-related quality of life beyond symptomatic relief is essential. Well, friends, what is most important, what we have learned just now in our public awareness, at a risk patient must be recognized. At a risk patient must be recognized. Who are at risk? Patients suffering from hypertension, patients suffering from diabetes, patients taking cardiotoxic drug. So all are at risk patients. So they must be recognized and properly managed to prevent the heart failure. And so thank you very much for giving me the present here.
Hello. Yes, thank you, sir, for your illustrious presentation. Now I request another speaker, Dr. Muhammad Saukat Ali, and he will speak on the ACS, acute coronary syndrome, and update. Dr. Saukat Ali, please.
Good morning, my chairpersons and all the delegates present here. I'm going to present on topic of acute coronary syndrome. Acute coronary syndrome is the most common emergency presentation, and we are threatened to treat, and this is a most common emergency. And there is a continuous evolution in the process of management in acute coronary syndrome. So according to the guideline 2023 ESC guideline, I am presenting my presentation over management of acute coronary syndrome. We know that most of the patients affected from acute coronary syndrome, around 80% present with history of chest pain or chest heaviness and pressure. Some patients may present with diaphoresis, epigastric pain, indigestion, shoulder or arm pain. In elderly or women or patients of chronic kidney disease may present with rare symptoms like dizziness, nausea, vomiting, jaw pain, or sudden onset of shortness of breath or sudden onset of weakness. we should classify these patients into different categories, and according to these categories, we should prioritize our treatment and management. Suppose the patient came in the emergency department with a complaint of chest pain, we should first do ECG, and ECG within 10 minutes of presentation. This is class 1 indication according to the ESC 2023 guideline. And after that, we should go for the biomarkers. New guideline mentioned that we should evaluate through the high sensitivity troponin level, and which categorize and can rule out the ACS patients into non-ACS or ACS within 3 hours of presentation. According to these presentation, we could classify the patients with non-ST elevated acute coronary syndrome or ST elevated acute coronary syndrome or STEMI. STEMI patient may present with malignant arrhythmias or sudden cardiac arrest, and after that, the STEMI or STEMI patient should undergo early invasive therapy or coronary angioplasty. And unstable angina patient can manage to the medical management. If there is a less chances of ACS, that patient can follow through the CT coronary angiography, which is previously was class 1 indication. Now it is class 2B indication. There are certain change in ECG through which we can categorize the patients and improve our prognosis or classify the prognosis to the patient relatives, like patients who have only T-wave inversion in 5 leads, like 1 to AVL or V2 to V6. These only signify mildly impaired prognosis. But if the patient's having same ST segment depression, but downward or horizontal sloping of more than 0.08 millisecond in more than 1 lead, this suggests of more severe ischemia. And after that, D Winter sign and Valen sign, these are the worst sign which suggest the left anterior descending artery blockage. D Winter signs has 2 types, type A and type B. Type A suggests biphasic T-wave presence in the V2 and V3 lead. It can happen in V1 to V4, but usually it happen in V2 to V3. Type A valence pattern suggests acute ischemia, likely blockage of proximal LAD, and type B suggests the recanalization of LAD. It has a specificity of around 90% for the prediction of left anterior descending artery proximal blockage of more than 90%. D Winter sign is the earliest phase of anterior wall MI. In these patients, the anterior leads, chest leads, V1 to V6, present with upsloping ST segment depression of 1 to 3 millimeter with tall positive and symmetrical T-wave. This is the pattern which is very life-threatening, and there are confusion in treating these patients with fibrinolysis or invasive coronary angiography. But some suggest fibrinolysis can be done in patients of D Winter sign, but there is no clear classification or guideline for the fibrinolysis in D Winter sign patients. We can treat these patients through the urgent coronary angiography. Now, as we belong to the poor socioeconomic strata of Simanchal region, most of the patients having poor financial status, so they are not willing for coronary angioplasty. We should treat the patients of STEMI with fibrinolysis, because one of the registry came in Kerala, which suggests that around 40% patient of STEMI did not get the fibrinolysis therapy at the time of presentation, which are required to do. And around 19% of patients which are of STEMI or unstable angina get thrombolized due to the mimics of MI, like suppose LVBB pattern or unstable like LVB pattern, LVH or vasospastic presentation can thrombolize through the STK or different thrombolytic agent. This is reported as the inadequate thrombolysis of around 19% through the Kerala ACS registry. So we should classify which patients should need fibrinolytic therapy. The STEMI patient which are presented within 12 hours of chest pain should need fibrinolysis, and fibrinolysis timing should be less than 10 minutes of hospital presentation to the lytic bolus dose to the IV agent. And the drugs which are preferred, that is tenecteplase, L-teplase or Retaplase, as compared to previously used streptokinase. But in case of age, which are more than 75 years of person, we should half the dose of tenecteplase as required in the normal person. And this dose came into effect after STEAM trial. STEAM trial was done with the enoxaparin with tenecteplase in many of the patients, and in that patient, there is a high risk of bleeding was found in the cases of patients which are having age of more than 75. And we are confused about which drugs should be loaded before fibrinolysis, like we have aspirin, clopidogrel, ticagrelor, and prasugrel. So before fibrinolysis, we should only use aspirin and clopidogrel. And clopidogrel loading dose in case of fibrinolysis is 300 milligram. But if the patient having age of more than 75, we should not use loading dose of aspirin, clopidogrel. We should only use 75 milligram of clopidogrel in that patients. Then the role of anticoagulation in patients of fibrinolysis. What should be the drug preferred in case of anticoagulation in case of fibrinolytic patients, and how much duration we should give these anticoagulation drugs. The recommendation is we should use anticoagulation drug till revascularization has been done or the duration of hospital stay up to the maximum 8 days. And the drug which is preferred is enoxaparin. First, we should give IV bolus followed by the subcutaneous injection. If enoxaparin is not available, then we should give unfractionated heparin. And there is a recommendation of IV bolus of fondaparinux. If we use streptokinase as a fibrinolytic agent, we should give IV bolus dose of fondaparinux stat and followed by subcutaneous dose 24 hours after that. If the patient presented with a chest pain of more than 12 hours, then the role of fibrinolysis is very unlikely and success rate of fibrinolysis is very less, then we should go for primary PCI at that time. And even after the patient presented till 48 hours, the fast MI trial suggests that the patient presenting with the chest pain around 12 to 48 hours, then primary PCI decreases the rate of cardiac mortality. So primary PCI can be done till 48 hours of chest pain. But after 48 hours of chest pain, after angiography, we can see that the vessel is 100% blocked. That artery should not be opened because our trial suggests that the opening of that artery leads to the more mortality or less benefit as compared to on medical therapy. That artery should be managed just like CTO patients in the chronic coronary syndrome patients. If the patient are thrombolyzed, fibrinolytic agent has given, and patient is successfully thrombolyzed, chest pain gone off, even though now recommendation is that we should do coronary angiography and if required, coronary angioplasty after 2 to 24 hours of fibrinolysis. This is the class 1 recommendation. And in case of non-ST-SES patient, if the patient having high risk like malignant arrhythmia, mechanical complication, refractory angina, that patients should take for the early coronary angiography for the prevention of death. And if there is a selective invasive approach can be done in the patient of low suspicion of acute coronary syndrome. In cancer patient, there is a new recommendation. If the cancer patient having expected survival of more than 6 months, then we can take for the invasive strategy. If the expected survival is less than 6 months, then we should proceed through the conservative management, through the medical management. Now, we came to the technical aspects in invasive strategy. Suppose we have done coronary angiography and we have seen that the patient suffering from the coronary artery dissection. In coronary artery dissection, the role of PCI is only when if there is a large area of myocardium at the geoparity and reduced antegrade flow. If there is a reduced antegrade flow and large area of myocardium in geoparity, then only we can do PCI in the spontaneous coronary arterial dissection patients. And during PCI, we should use intravascular imaging. This is the newest guideline. It is a class 2A recommendation, even in the ACS case or STEMI cases. The optical coherence tomography is the newest modality for the morphological and architectural evaluation of the coronary arteries. This should be used in preference to the IFAS. In case of cardiogenic shock presented with multivessel disease, suppose in patient having cardiogenic shock and on angiography, we see that the patient having multivessel disease, the preferred modality is we should only do the coronary angioplasty of the infarct-related arteries. We should not do the multivessel PCI in case of cardiogenic shock, and that patient is planned for the multivessel PCI within the hospital stay or at least 45 days of initial presentation. In case of STEMI, the recommendation of PCI of non-culprit artery is that the evaluation of non-culprit artery should be only to the angiographic severity. We should not use the functional assessment like the functional assessment like IFR. IFR should not be used in the STEMI patient because the microvascular occlusion may impair the result of IFR in case of STEMI patient. But in non-STEMI, we can use the functional assessment. Now, the patient with STEMI which are planned for primary PCI, previously it was mentioned that unfractionated heparin should be used only. Now there is a recommendation of class 2A, the use of enoxaparin and bivalvulotin 2 can be used in before the primary PCI. And fondaparinux should not be used before primary PCI because OASIS 6 trial suggests that there is a high rate of catheter thrombosis in patients who have used fondaparinux as an anticoagulation agent before primary PCI. And there is a recommendation that patient with a NST-ACS patient which having early angiography, which is planned for early angiography within 24-hour period, the fondaparinux should not be used. But if the patient is planned for coronary angiography more than 24 hours, then the fondaparinux can be used, and even enoxaparin and unfractionated heparin can be used. There are many of the patients now suffering from atrial fibrillation presented with acute coronary syndrome. Then during PCI, how can we proceed? Suppose if a patient of NOACs or suppose a patient are on vitamin K antagonist. The recommendation is that the use of unfractionated heparin should be in the patients who are suffering from acute coronary syndrome and plan for coronary angioplasty. Even if the patient on NOACs, but if the patients have on vitamin K antagonist like acetrom or warfarin, if the PT-INR level is less than 2.5, then we should use unfractionated heparin. But if PT-INR is more than 2.5, then we should not use unfractionated heparin. There is no role of unfractionated heparin if the PT-INR level is more than 2.5. In case of oral anticoagulant like a vitamin K antagonist, and we are using antiplatelet, then the level of PT-INR should be 2 to 2.5, and this should be more than 75% time in the therapeutic range. Suppose in patients of oral anticoagulation and PCI performed, we should do without interruption of vitamin K antagonist or NOACs. And we should not administer unfractionated heparin if the INR is more than 2.5. But if patient is on NOACs, the dose of heparin and enoxaparin is unfractionated heparin dose is 60 IU per kg and enoxaparin dose is 0.5 milligram per kg. But if not, in normal person, the dose of unfractionated heparin is 100 IU per kg. Aspirin is indicated, but please avoid pre-treatment with P2Y12 inhibitors. And the use of tirofiban, eptifibatide is only for bailout or peri-procedural complication. There is no clear-cut role of tirofiban in acute coronary syndrome management. This is only used in the primary PCI if the grade 3 thrombus present or there is a no flow, reflow or no flow in the patients of acute coronary syndrome management through the primary PCI. This is the guideline, the pictorial guideline of STEMI and anesthesia patient management. The use of unfractionated heparin is class 1 indication, and enoxaparin and bivalirudin is class 2A in STEMI patient which are planned for primary PCI, and role of fondaparinux is class 3, it is contraindicated. In anesthesias, and if angiography planned in less than 24 hours, we should use unfractionated heparin, and even enoxaparin, it is a class 2 indication, and if angiography is planned for more than 24 hours, we should use fondaparinux. We should avoid preloading with P2Y12 inhibitor, but if patient is of STEMI and plan for coronary angioplasty, we should prefer loading with prasugrel as compared to ticagrelor on the basis of ISAR-REACT-5 trial. Prasugrel should be avoided in patient of TIA and stroke, and loading dose should be same 60 milligram per kg, but maintenance dose should be vary depending on the age and weight. Not in normal person which are having age of less than 60, age of less than 75 and weight of more than 60, the maintenance dose is 10 milligram per day. If the age is more than 75 and weight is less than 60, the maintenance dose of prasugrel should be 5 milligram per day. Now, the continuation of antiplatelet therapy, usually we should continue antiplatelet therapy, DAPT, around 1 year in patients of ACS. But if the patient having high bleeding risk, we can stop DAPT at 1 month, and after that, continuation of P2Y12 inhibitor till after that. Even we can discontinue DAPT at 3 to 6 months. This is a class 2A recommendation, but discontinuation of DAPT at 1 month is a class 2B indication. And even de-escalation of antiplatelet should not be done within 1 month of presentation of acute coronary syndrome. De-escalation is like the changing of prasugrel and ticagrelor to the clopidogrel. If patients of anticoagulation and who have done coronary angioplasty, we should give oral anticoagulant with DAPT till 1 week to 1 month, and after that we should give only oral anticoagulant with P2Y12 inhibitor till of 1 year. After that, oral anticoagulant only the drug given. For the role of management in the complication, heart failure should be managed. If there are mechanical complication or severe hemodynamic instability, IVP should be used. And if the left ventricular thrombus found in the echocardiography, usually in anterior wall MI, we should give oral anticoagulant till of 3 to 6 months with either vitamin K antagonist or novel oral anticoagulant. Even if the patient presented with atrial fibrillation in acute coronary syndrome, these patients are cases of oral anticoagulant. And for the management of the ventricular arrhythmia, even after revascularization, after 4 to 6 weeks, and if not revascularized, we should assess these patients after 3 months of optimal medical therapy, and EF if less than 35% with a functional status of class 2 to 3, we should indicate the ICD therapy in these patients. In case of permanent pacemaker implantation, if there is a patient of acute MI presented with high degree AV block, which are not resolving even after 5 days of presentation, we should implant permanent pacemaker in these patients. If the heart block is reversible, we should not do permanent pacemaker implantation. There is a new drug, low dose oral colchicine, 0.5 milligram OD, according to the LODOCO trial and COLCOT trial. These are advised for the patients of acute coronary syndrome, even chronic coronary syndrome patients. This is a class 2B recommendation. This significantly reduces the cardiovascular motility and improve the patient outcome. And influenza vaccine is mentioned in the yearly in all ACS patients. Thank you.
Dr. Shaukat, please conclude. Thank you. Now, the house is open for questions and answers. Sir, I have a question to Dr. A.N. Rai, sir. in diabetic patient, the most frequent finding on ECG is the left axis deviation. So what could be the reason, sir? What is the mechanism? Sir, in diabetic patient, the most frequent finding in ECG is the left axis deviation. Yes. So what could be the mechanism for this left axis deviation in diabetic patient? Sir. Yes, sir. Please. Thank you, sir. Any,
You came late, but I presented a very interesting case. He asked, bifascular clot. And how will you differentiate between bifascular clot and muscarinic medial transplant? Because I presented a case. And that case, normally we will diagnose RBB with left atrial plaque is bifascular. But how will you differentiate between muscarinic and bifascular clot? I presented that is this was the case. And this is the funding entering the clot, bifascular clot. There's no urgent pacing, but it is muscarinic urgent pacing. So if this LBB pattern, normally lead one, select the lead one. If there is no airspace, that is muscular department. That was the case. That's why this. Second thing, your question, AVR, the forgotten lead of AVR. ST elevation AVR with key depression in precardial lead. So this is a very critical condition. Either left anterior, left main, or triple pressure is very severe condition. That is the bad prognosis. ST depression in precardial leads and ST elevation in AVR.
Thank you, everybody, sir. We can't go more for this question and answer session. If anybody has any query, they can ask individually to the speakers in the free time. So now I request our organizing chairman, Dr. S.P. Singh, to please come on the dais and please present the memento to our organizing chairperson. Was to Dr. D. Ram. Dr. Umesh Khan, sir. Dr. Umesh Khan. Dr. B.K. Singh, sir. And Dr. P.K. Sinha. P.K. Sinha. May I request our patron, Dr. D. Ram, to present memento to our honorable speakers. First to Dr. Professor A.N. Rai, sir. To Dr. P.K. Sinha, sir. And our dear Dr. Shaukat. Thank you, sir. So now, group photo. So now we move ahead for the So now we move ahead for the next session, diabetes prevention to remission. And for that, I invite Dr. Hemshankar Sharma ji to be the chairperson. Dr. P.K. Singh. Dr. P.K. Singh, is he here? Dr. P.K. Sinha, sorry. P.K. Singh, chest. Dr. Ajit Kumar Sinha. Dr. Ajit and Dr. Manish Kumar. There is one announcement. All those postgraduate students who are presenting their posters, please go upstairs and post your posters so that later on it can be judged and analyzed. So I hand over to the chairpersons to conduct this session. Thank you, sir.
Hello. Very warm good morning after this lucid sessions, the three components when we are speaking. Now we will be listening to all those stalwarts and giants from diabetes prevention to remission. And the first is none else than Dr. Anand Shankar, the camera catching man for diabetes, and let us see that what he is telescoping through his lenses of diabetic eyes. So over to Anand without wasting time.
Good morning, everybody. At outset, I must thank Dr. Rai sir and organizing and Purnia organizers for giving me this opportunity. And last time, I think I come in 2015. So it's a quite long time I came to Purnia on the same podium and the same hall with Dr. Ajay sir. I think sir, you remember it. When Modi sir called me, आनंद तुमको एक टॉपिक देना है, बोले सर दे दीजिए. तो प्री डायबिटीज से बोलना है, बोले सर वो भी दे दीजिए. लेकिन हर आसान चीज बहुत मुश्किल होता है बोलना. सुनने में प्री डायबिटीज बहुत आसान लगता है, लेकिन quite difficult when we start. So the topic is pre-diabetes, the opportunity and way ahead. First, we must know what is pre-diabetes, and that is the most difficult because it's a gray area. They are not diabetes and they are not normal. So the first time the terminology pre-diabetes was conceived in 70s, and the National Diabetes Data Group used the term pre-diabetes to designate the impaired glucose tolerance and to define using 2 hours glucose load sugar between 140 to 199. And the IGT definition was adopted by the ADA and WHO subsequently. But before that, ADA in 1997 and WHO in 1998 had introduced a new terminology, that is impaired fasting glucose. And that time it was 110 to 125. It was not 100 to 125. Later in 2003, ADA has decreased from 110 to 100. So we are adding more people in pre-diabetes. And in 2009-10, the international group and ADA has added the HbA1c for the diagnosis of the pre-diabetes. So these are the historical part of the pre-diabetes. As per the definition, is a chronic metabolic condition where the glucose levels are above the upper threshold considering normal, but below the threshold of diagnosis the diabetes. And currently we have 5 different society having different parameters, but we are using ADA, WHA, IEC and RSSTI. And you can see all are little more or less same. ADA and RSSTI having the same figure. So we consider that should be the diagnostic criteria for pre-diabetes in India. These definitions identify the phenotype of the basis of various tests by the hyperglycemia, depending the fasting hyperglycemia, 2 hours or HbA1c. And these phenotypes characterize the various degree of insulin resistance and beta cell dysfunction, where the maximum insulin resistance and loss of the more than 80% of beta cell dysfunction is in IGT. Because the HbA1c is measure of chronic hyperglycemia, this phenotype defines both the fasting and the glucose load hyperglycemia. Now, according to the Center of Disease Control, US in 2020, National Diabetes Static Report estimated that 13% of the US adult more than 80 years old having diabetes and 34.5% meet the criteria for pre-diabetes. And US Preventive Task Force has formed in 2021 and given its report, they have conceived that evidence are there to treat it, because if they don't treat, they will develop to type 2 diabetes and subsequently the all chronic metabolic complications after type 2 diabetes. Now, prevalence of pre-diabetes is increasing. In 2010, it was 343 billion and estimated to 471 billion by 2035. So this is the IDF calendar report that we are going to have a very big number of patients who are not knowing, and they are not covering into the umbrella bracket of diagnosis of type 2 diabetes. So we have to be very cautious that we should not leave those subjects also who are not classically qualifying to be diabetics. And this is the INDAB study. I think Dr. Ajay sir has gone out, and in this study, Dr. Ajay sir was also the participated, and this is 2023 study, the latest from India. This shows the pre-diabetes in India, 15.3%. It's a huge number, 15.3%, because we are 140 crores. So considering that number of population, 15.3% is a very big number, and it's a bigger challenge to us, because it's very difficult to conceive that आपको diabetes नहीं है, लेकिन आपको diabetes के पहले का situation हो गया. So acceptance to the normal people is very, very, very important, and we have to teach them. And all metabolic anxiety except pre-diabetes were more frequent in urban and rural area. So this is not the only the who are in the urban. It is a universal phenomena in India. So we have to be very cautious in that when we have gaps in diagnosis of diabetes. The factors are there, the prevalence of diabetes. Epidemiological factor studies demonstrated clear relationship between the ethnicity, likely pre-diabetes, African Indians, Caucasians are less, and South Asians are more, blacks are more, browns are more having because of the ethnic and predisposition to have genetic predisposition. Complex interaction further in facts like the life expectancy, socioeconomic status, wealth, access to healthcare service, and living longer. All these factors are adding to the pre-diabetes. Population, more urbanization is also one of the factor. More access to the nutrition is also one of the factor for the pre-diabetes. And these increase the expected to be more pronounced in developing country rather than the developed country. And just in a last session, we heard, sir, that in developing country, they have slowed down the disease progression, metabolic disease progression, but developing countries is catching to that pace due to the westernization of our lifestyle. But what is the dynamics? How this IR affects and how this IR is culprit? Because we are talking about the IR all the time. So this is the 2022 study, and they want to see to assess the contribution of the beta cell dysfunction and insulin resistance in Asian pre-diabetic phenotype. Just want to know what happens to that. And they concluded the low acute insulin response to the intravenous and beta cell responsibility to the oral glucose on the background of mild insulin resistance are major contributors to the dysregulation of glucose homeostasis in Asian with pre-diabetes. So we are born, we are harvesting something which is not we are supposed to have, and that is making us pre-diabetic and diabetes subsequently. But the question arises to me, the upper you have seen the Google engine, which I wrote, does insulin resistance present in non-diabetics? And within 5 seconds, not 0.5 second, it given me 8 crore 15 lakhs articles in PDF. And from that one article, metabolic signature of insulin resistance in non-diabetic individuals. And what it has shown that people with higher IR were significantly younger, had higher education level, BMI, waist circumference, fasting plasma glucose, HbA1c, ALT, triglyceride, cholesterol, non-HDL cholesterol, uric acid, and low HDL level as there. So the IR is there since our birth. So the next question arises to me, if IR is so problematic, insulin resistance is identified as an impaired biological response to the insulin stimulation to target tissue like the muscle, liver, adipose tissue, and it impairs the glucose disposal, resulting the compensatory increased beta cell insulin production and hyperinsulinemia. The metabolic consequences of insulin resistance and can result in hypertriglyceridemia, hypertension, hyperglycemia, dyslipidemia, hyperuricemia, elevated inflammatory markers, endothelial dysfunction, and prothrombotic state. So if IR is so detrimental for normal physiology, why physiology is letting us develop? Why we are developing IR? Body, why? We should ask ourselves, what went wrong? Why IR is there? This answer is given in 1967, but Chahal and Wen, they have theory to postulate that more insulin resistance an individual, the more efficient will be his ability to decrease the proteolytic when faced the calorie deprivation. So when I am not eating and when I am starving, when I am not getting nutrition, this IR is helping us to live, to be alive. And Chakravarti and Booth has in 2004, insulin resistance evolved to aid metabolic patronization between the physical activity and other functions during the constrained insulin supply, energy supply, sorry. So when energy is not there, this IR is there, which keeping us alive. So IR is not bad. So when IR is not bad, insulin resistance is effective in decrease the proteolytic when calorie is deprived. So what is the question? Why then the pre-diabetes? Why the IR is there? What we think about the insulin resistance is all true or is a questionable true? And we must ask ourselves that why IR is there. The answer lies here. This is a clethodoprotein function. If you go back to your physiology class, you must remember the clethodoprotein. And this is found in type 1 diabetes. This clethodo system plays a very important role in the regulation of human body metabolism. And one hand, this promotes longevity. And other hand, it promotes the insulin resistance. And the insulin resistance is important in various states such as starvation, immune activation, growth, cancer, to spare glucose for different biosynthetic processes. So insulin resistance is not bad. So then if it is also not bad, then why we are developing pre-diabetes? Why we are developing having so much complication of IR? This is, we know that safety gene, safety hypothesis, safety protein, this is the new concept. And this is published in 2007. The money is a recent phenomena in the evolution of the history of humans, and therefore separate brain center to handle money related emotion and information processing unlikely to have involved. The brain are involved in handling food related emotions and information and presumably expand to handle money. So the food and money is having the same center in the brain. And it is possible that the desire to accumulate wealth results in the tendency to store fat also. So this is the problem starts here. So the origin of pathophysiology, the insulin resistance is an adaptive response. And furthermore, at least under certain condition, insulin resistance can actually increase the lifespan. Tendency that adaptive have a turn into the pandemic disorder. And the pathological effects are caused by the supernormal stimuli. So IR is there, a beta cell function is there, but there are few supernormal stimuli are there. And all the stimuli for development of either phenotypic transition or some postulation of density, social connectivity, economic motivation, social inequality, sedentary lifestyle, and rich diet have reached unexpected level today, to which the body given extravagant response leading to pathological condition. And I request all to go and read this book. This book has given very beautiful, describe how the human instinct, we are instincted to survive for food, sex, and territorial protection, developed for the life of the savannas for thousands of years back. Not today, because we are overloaded with the supernormal stimuli, and those are not able to adapt in the modern lifestyle, and that is proceeding towards the metabolic disease. So what are the etiology of IR? To this August gathering, I don't have to explain everything, but the acquired and genetic insulin resistant disorders, etiologies are there, and the health risks associated with the pre-diabetes. Progress to diabetes, neuropathy, retinopathy, kidney disease, neuropathies, retinopathies, and macrovascular complication. And you can see the IR. Both has the same complications in disease. So both are having hand in hand. So if we handle one, we'll handle the both. The identification and treatment of pre-diabetes individual is crucial to make healthcare more affordable, prevent preventable disease, and save life. So this is the US preventive task force that's given us a guideline how to screen the pre-diabetes and diabetes and how to treat them. And they have more emphasis that on the lifestyle modification. And of course, they want to pick them early. But another paper has shown that if you pick them early also and given the intervention, unless until the sugar values are more than 6.4 in HbA1c, it will not help also. But the sample size is too small for that. These are the novel markers for the pre-diabetes. And of course, HbA1c and oral glucose tolerance test is the baseline. These novel markers should be considered for the diagnosis of the pre-diabetes and of course the IR. Now the time is right to develop proactive approach towards the pre-diabetes. Develop a business case for screening for the and treating the pre-diabetes, estimating the cost-saving result for preventing hundreds of thousands of patients from diabetes minus the estimated cost of screening all the patients' risk for diabetes. Develop a guideline for the healthcare providers how to identify and manage pre-diabetes. It's us determined to standardize the approach of treating pre-diabetes. Develop a registry program as we have done for asthma, hypertension, diabetes. Let's a registry program for pre-diabetes also. Developed a low-cost, easy accessible lifestyle management program that would be potential to available for hundreds of thousands of patients of pre-diabetes, and they will prevent it for further complications. So pre-diabetes, time to prevent the preventable disease. So if we have not existed or still on the opportunity, there's a caution that diabetes is ahead. Thank you so very much.
Hello. Thank you, Anand. It was within time, but the question answers will come after the second talk. Okay, thank you. Take your seat.
Thank you, Dr. Anand, for excellent talk. And for the next talk, may I invite Dr. S.C. Jha, sir. He is going to talk on prescribing exercise in diabetes. As we all know, lifestyle modification is the mainstay in diabetes management. And before we rush into prescription, we have to advise lifestyle modification for all our patients. And it is very apt that this talk is being delivered by Dr. S. Jas.
Respected Professor A.N. Rai sir, Devi Ram sir, all respected seniors and honorable colleagues. If you want to combat the epidemic of diabetes, in recent 4 decades, the number of diabetes has multiplied 4 times, and most of this multiplication has unfortunately taken place in countries like India. So this is the time to talk about the strategies, and one of the most important strategies is exercise. Yes, we can prescribe exercise to combat this deadly disease, and if you have not developed diabetes, pre-diabetes is there, then we can prevent it by this. This is the classical triad: diet, exercise, and medication, and monitoring glucose. And out of this, we are pumping billions into the medications. We are talking in all conferences about diet and exercise, but maybe more awareness is required. In the morning, there was public awareness program, and this is the time to make ourselves aware that simply walking 1 hour is not good enough, and there may be more to it, and we can prescribe exercise judiciously. It is, in fact, the biggest insulin sensitizer, better than any medication which is currently available. And it is, unfortunately, a $1 billion drug, which is seldom prescribed. Physical activity includes all movement that increases energy used, and it is the structured physical activity to achieve a medical goal. The activity may not be structured. They are also important. They are simply known as physical activity. This is very interesting, the physiology of exercise. To put in few lines, in the first few minutes of the exercise, glycogen in the muscle is broken down anaerobically. And after 10 minutes of activity, there is hepatic glycogenolysis. So first stage, glycogen is broken in muscles. Second, glycogen in the liver, and then comes the metabolism of adipose tissue, 20 minutes or beyond. That is why if reducing fat is the primary goal, then a longer duration exercise should be preferred. One metabolic equivalent is defined as the amount of oxygen consumed while sitting at rest, and it is equal to 3.5 ml oxygen per kg per body weight per minute. So energy expenditure during rest is measured by one metabolic equivalent, and amount of energy which we consume during exercise can be compared to that. Less than 3 MET is the light exercise, 3 to 6 MET is the moderate, and above 6 is the vigorous. And how can we grade the exercise on the basis of heart rate, which is so simple to do in our day-to-day life? Maximum heart rate we can calculate 220 minus your age. That is the maximum heart rate. And low intensity exercise is defined as 40 to 50% of maximum heart rate, when one can talk and sing during the exercise without getting breathless. Moderate intensity is 50 to 70% of maximum heart rate. One person can chat, but cannot sing comfortably. And the high intensity exercise is when we achieve 70 to 85%. उसके बाद का स्लाइड चाहिए ना. The vigorous intensity exercise is when we achieve नहीं सर बोल रहे हैं अभी रुक जाने के लिए. The importance of this is we can count it then and there and can decide whether it is low, moderate, or high intensity. High intensity is 70 to 85% of maximum heart rate. Patient can barely talk. Role of physical activity, all of us know: improving blood control, improving insulin sensitivity, lowering insulin requirement of other drugs, maintenance of body weight, reduction of coronary risk factor, and favorable changes in body composition. The decreased body fat and weight. Weight may remain the same, but maybe the fat has decreased and muscle we have gained in. That is the positive thing. And it lowers overall cardiovascular and overall mortality. Now, exercise. If you want to prescribe the exercise, we have to know the types of exercise. Basically, aerobic exercise and resistance exercise. Other two exercises are also being talked about: flexibility and balance exercise. This is a very busy chart. This is easier to read. In walking, we consume 300 to 400 calories per hour, cycling 600, running, swimming 600, rowing 840, and jump rowing, roping is 1000 plus. So aerobic exercise means with oxygen, which means that breathing controls the amount of oxygen that can make it to the muscle to help them burn fuel and move, like walking, cycling, jogging, swimming. And benefits of aerobic exercise: it improves the quality of mitochondria. Resistance exercise doesn't improve the quality of mitochondria that much. Insulin sensitivity, oxidative enzyme, compliance and reactivity of blood vessels, lung function, immune function, cardiac output, substantial reduction of cardiovascular and overall mortality. And anaerobic exercise or resistance exercise, on other hand, they are the short, fast, high intensity exercise that don't make our body use oxygen like it does for cardio. Instead, anaerobic activities break down glucose that is already in your muscle for a form of energy. Examples are exercises with free weights, weight machines, and elastic band exercises. Even body weight exercises like Diabetic, they are very good exercises. Benefits of resistance exercises: that they improve the function of glucose transporter 4. We know that in the skeletal muscles, the glucose transporter 4 is there, and insulin is usually required to utilize glucose and to bring GLUT4 into action. Muscle hypertrophy, improved strength and better physical function, better tolerability, mental health, BMD, and more effective in preventing slowing sarcopenia. Yes, we are the nation of sarcopenia. We are losing muscle every year. And if you can increase the muscle, then our metabolism will improve. So this is the point to be emphasized upon. This is the way some of the changes noted in skeletal muscle in response to exercise: enhanced mitochondrial function, increased number of glucose transporter. This is perhaps the very important. If you want to remember just one slide in this whole talk, this is the slide we should remember, that irrespective of the presence of insulin, insulin in fact is not required for glucose to enter into the cell when we are exercising. That is the most important statement of this talk. A form of non-insulin dependent glucose uptake, contraction mediated glucose uptake occurs when exercise. So essentially, muscle contraction allows glucose to enter the cell. And what is very important, this contraction mediated glucose uptake effect continues for several hours when exercise is over, maybe for 24 to 36 hours. Just acute exercise, patient has not been doing one exercise, one bout of exercise. Increased immunosurveillance, frequent mobilization and redistribution of effector lymphocytes. In response to just a single bout of exercise, literally billions of lymphocytes are mobilized. Flexibility exercise, they improve the range of action around the joint. Balance exercise improves the gait, benefits the gait and prevent falls. Activities like Tai Chi and yoga combine flexibility, balance, and resistance exercise. Recommendations for reduced sedentary time. Whatever all adults and particularly those with type 2 diabetes should decrease the amount of time spent in daily sedentary behavior. We talk about exercise, we don't talk about non-exercise time. Even during the non-exercise time, the ADA has recommended that every 30 minutes of sedentary behavior should be punctuated with at least 3 minutes of aerobic exercise. Adult pre-exercise screening tool, you can have the questions to see whether the patient has any difficulty, and then you can assess. Pre-exercise assessment is very important before prescribing an exercise regimen, be it neuropathy, retinopathy, coronary artery disease, peripheral artery disease. We have to frame the exercise according to the individual requirement of the patient. How much exercise? It should be according to FIT principle. F stands for frequency, 4 to 6 times a week. Intensity is 30 to 40 minutes of exercise at 50 to 60% of target heart rate. Type is the safe exercise should be recommended, and morning time is ideal. Recently, few evidences have come that it is more beneficial during afternoon also, some studies. Aerobic exercise, we always remember the exercise, but before exercise, warm up and later cool down is also important. And gradually progress over 12 weeks to 50 minutes per session of brisk walking. Alternatively, shorter exercise session. Many people say, I am very busy. Okay, you plan them 10 minutes of exercise morning, afternoon, and evening. And resistance exercise, 6 to 8 exercise targeting the major muscle group. Gradually increase the resistance when you can perform 3 sets of 8 to 12 repetitions. When beginning resistance exercise, it is best to receive initial instruction and periodic supervision. Interval exercise training is coming in a big way, performed in intervals, alternating between higher intensity exercise and lower intensity. They can shorten total exercise duration, increase fitness gains, and increase variety. For example, try alternating between 3 minutes of faster walking, 3 minutes of slower walking. One thing which is now being talked about is the HIIT, high intensity interval training. It is also an option. It is a form of interval training, a cardiovascular exercise strategy that you go into the burst of physical activity to achieve the vigorous exercise status. And then after that period of vigorous exercise activity, don't come to the rest, come to the comfortable limits of 50 to 60 of maximum heart rate, or maybe 40 to 50 of heart rate. This is very important because this increases the mitochondrial content, more oxidative capacity, slows down sarcopenia, more cardiovascular fitness. But needless to say, when we go for this, the gradual approach, upward titration of exercise, that is very important. Soleus push-up is doing the rounds, and globally, people are interested. And Professor Hamilton, who has discovered this, he said, this is the emerging sensation. We never dreamt that this muscle has this type of capacity. It has been inside our body for so long, but no one ever investigated how to use it to optimize our health. Yes, soleus muscle is interestingly not dependent on glycogen. It is dependent only on the glucose. So the glucose lowering capacity is maximum. And though it is 1% of your body weight, it can do big things to improve the metabolic benefits in the rest of your body if it is activated correctly. So this discovery unlocks the potential of this special muscle. EDA recommendation, we know 150 minutes or more of moderate to vigorous intensity exercise spread over at least 3 days per week with no more than 2 consecutive days without activity. Shorter duration, minimum 75 minutes per week of vigorous intensity or HIIT can be enough. Children, adolescents, whether type 1 or type 2, 60 minutes per day. And individuals with diabetes or pre-diabetes are encouraged to increase their total body, daily non-exercise physical activity. Type 1, we have to be very careful. Insulin resistance is there, but it is not a major issue like type 2. Variable glycemic control, more chances of hypoglycemia, decreased insulin dose prior to exercise, shorter session, frequent glucose monitoring, and frequent carb feed if required. Gestational diabetes is very important. 20 to 30 minutes of moderate intensity exercise every day. And today, the postprandial exercise is also being promoted in GDM and even in other cases where 30 minutes after a food, patient can walk for 30 minutes for a good benefit. Gestational diabetes in check, creating a health carb strategy, small meals, staying active, monitoring blood glucose, and share details with consultant doctors. This is very busy slide, sample walking program. The peripheral neural, if peripheral and this is the conspiracy of pharma people to talk again about the lifestyle modification. In peripheral and autonomic neuropathy, recommended is non-weight bearing activities, swimming, bicycling, chair and arm exercise. Contraindicated is treadmill, prolonged walking, jogging, and step exercise. In nephropathy, obviously we have to go for low to moderate intensity form, and high intensity exercise should be discouraged. In diabetic retinopathy, contraindicated is strenuous activities, pounding or jarring, such as weightlifting, jogging, high impact aerobics, racket sports, etc. Low impact cardiovascular exercises will be much better. Useful tips are the identification card should be there, and check your feet before you walk, and choose good footwear, light clothing, drink a lot of water, don't exercise during hot seasons and when not feeling well. Hypoglycemia, everybody knows that this is one of the most important complications of diabetes, where for want of just 20 to 30 grams of glucose, patient dies. Patient may die. And even if corrected, it has got the after effects. So we have to be aware of this. I'm not going into details. All of us are fully aware of this. Snacking should be there. Physical activity lowers blood glucose in type 2 diabetes. Muscle cells become more sensitive. keeps the liver from producing too much glucose, builds more muscle, you lose weight and keep it off. This is the response to 100 grams of glucose in mild type of type 2 diabetes after 12 months of training. The red one is before the training and yellow one is after the training, how the patient has got the benefits. There are celebrities with diabetes mellitus. They have lived with diabetes a full life. They have given to the world so much. Thomas Alva Edison, Mario Puzo, Kamal Hassan, Sonal Kapoor, Nick Jonas, Tom Hanks, and many more. So this is Billie Jean King, many times Wimbledon champion. Determination makes a champion. Wasim Akram is one of my favorite hero, not because of his cricketing ability. For cricketing ability, he is there. He was the best outswinger cricketer in the world. But what was there? Despite diabetes, he made it. And Wasim Akram's statement is, I won't let diabetes bowl me out. That is like the determination of a champion. Excuses, I don't have much time. It is so boring. Never get a six-pack. Why to do go for that? Don't like this. It is so bad. My son gets early in the morning. His school is there. My wife, she has to do this duty. Yesterday, my father became ill. And some excuse or other will be there. To those, I want to say, a 15-minute intense workout is only 1% of the day. A 30-minute workout is just 2% of the day. 60-minute workout is just 4% of the day. And we are fighting the tsunami of diabetes. So there is no excuses. There is no choice. You have to go for it. You have to go for it. There is no other way out. So take home exercise message is, exercise is an invaluable drug. We are pumping billions into developing a drug which is so insulin sensitizing. We talk about pioglitazone having insulin sensitizing effect, metformin doing. And here is exercise, which is multiple times better without any side effects if properly conducted. Contraindications should always be kept in mind. All diabetes should be motivated and educated about planning out the exercise and to accept exercise as a way of life since our school days. Dietary education along with is very important to fight this disease, and different academic institution can advise the government to make the exercise an integral part of a school curriculum and to spread the awareness right in the school. Today we are doing the awareness program there and there and there. This should start in the school itself. If we want to lessen the burden of socio-economic burden and remove our tag of diabetes capital of the world. Thank you so much.
Thank you, Dr. Jha, for the excellent deliberation on a very important subject. Actually, time is less for you. तू कहे अगर मैं जीवन भर गीत सुनाता जाऊं, एक्सरसाइज ऐसा टॉपिक है कि कितना हो समय उसके लिए कम है. तो हम कहना चाहेंगे कि no two persons are same, so exercise should be tailor-made. Seeing different kinds of diseases, a person is suffering multiple metabolic disorders and other diseases. Number two, exercise should be aimed to make active those components of body which remain idle during our day-to-day life. It should be targeted like that. And there are two components, amplitude and length. Amplitude shows
intensity and duration. Intensity and duration.
Adapts to heightened need, and length. 1 hour of exercise daily is not better, not good. Actually, major portion 20 minutes, 30 minutes at a time, and rest should be scattered, as you have already told, that after every half an hour or 1 hour, one should do some activity. And there must be time given to adapt the body. All these things should be taken care of, and thank you for your good deliberation. If any questions from the audience.
House is open to the question. One question I can allow.
No, sir.
Or we
Sir,
will just pack it up. Amit is here. Ready for the talk of it? Okay. Just load your. Yes, sir.
Very important to give him water during walking.
Yes,
Even after 15 plus or 20 minutes, it's slipping out of it.
yes.
So if you are not giving proper water, he will be.
Particularly in elderly, because elderly
Sir,
people, they
Umesh sir,
have got
we will be
less,
coming down to question answers
because they have got less
Amit has
sense of
just come
thirst.
in time.
And if elderly people are thirsty, they will not ask for water.
Okay,
This
no
is a
problem.
very important point which Dr. Umesh Khan has raised.
Yeah, very good. We will be coming to those discussions in the last words. Amit, may I just now request you? For the medical nutrition therapy. He has already given the physical nutrition therapy. So now it is open to you for a medical nutrition therapy.
Can I have my slides, please? How does this work? No. Thank you, sir, for giving me the right opportunity. Because you need to exercise more before you eat.
नहीं आ रहा है पेन ड्राइव रीड नहीं कर रहा है सर लैपटॉप वाईफाई से जोड़ के व्हाट्सएप पे ले करके या फिर मेल पे ले करके फिर अपने हमको डाउनलोड करना नहीं और वाईफाई पेन ड्राइव में नहीं आता
System is not reading the pen drive. No, no, video.
रीड नहीं कर रहा है ये बोर्ड नहीं ले रहा अब ये कर देने का लैपटॉप को वाईफाई से जोड़ के व्हाट्सएप या मेल कर दें मैं वहां डाउनलोड
I think Amit will be taking a couple of minutes. So any more questions? Sudhir has done his part. The first speaker was here. To Anand के लिए कोई question है तो बताओ. BK Singh is going to ask.
I must thanks Dr. Anand for his presentation, for making his presentation very artistic and emotional.
Thank you, sir.
My first question is that you said that the pre-diabetes is particularly equivalent to the coronary artery disease. Maybe. My particular question is that whether the 1 hour post-glucose test is more valid and appropriate than the 2 hour post-glucose level for diagnosing impaired glucose level.
Sir, as per today's guideline, the WHO is not recommending 1 hour glucose challenge test. It is not yet validated. But in Tamil Nadu, studies has been done in 1 hour also, and Dr. V. Mohan also done a study with the 1 hour, and in Chennai they are practicing this one. But if we say from any forum that it is validated to do 1 hour, till date we have no validation. WHO says 2 hours. But your question is whether we can do or not. Of course, sir, we can do, because there's a study yet to be published, unpublished study in the gestational diabetes mellitus. 1 hour glucose challenge test is equivalent to 2 hour challenge test in diagnosis of GDM. So if it is in the GDM, it could be outside GDM also validated. The time will come that we can do 1 hour challenge test validation also.
Anand, can I just say something? The point you raised in GDM, it was 50 grams of glucose and 1 hour testing. This was almost 10 years ago and all that. But later on, when the WHO took over and the ADA guidelines they took over, again these societies of the gynecologists, they went back that 2 hours oral GTT is the best one, which is recommended by the WHO. What is your comments?
Absolutely correct, sir. That 50 gram 1 hour for the screening. It is a two-step method by the ADA. First, they want to screen, and then the subsequent days they want to diagnose. If the screen is positive, that is the 50 gram 1 hour. But we are talking about the challenge test. The standard challenge test is 75 gram or 81 gram anhydrous glucose in 280 ml of water to be taken within 3 minutes and 1 hour after the last sip of the drink. So that is a different one, sir. Both are the different because the quantity of the glucose are different in both, and the purpose of the seeing the test, one is screening and one is diagnosing.
So once you go into the community or the society, you screen first.
Absolutely.
Once you just screen them and they come in the purview of this category, then they can be subjected for 2 evaluations. We are just taking this time only till then. The moment they start, we will be stopping. The moment they stop, then we will be stopping. Come on.
Pre-diabetes has same complications, or it affects in same way as type 2 diabetes. Like it has retinopathy, it has premature coronary artery disease, it has neuropathy and whatnot. So is there a time to redefine or change in the criteria for diagnosing diabetes? Why do we say pre-diabetes? It is diabetes. Any comment?
You are absolutely correct, sir. But the guideline has to be a consensus. That's why in the last slide of my presentation, I described that let's start registry, because unless until we do a pilot study or a registry program to give a substantial amount or data to make it accountable, then only it will be accepted to be diagnosed.
Exactly. Thank you very much.
Yes, sir.
I will answer your question. The diagnostic criteria for diabetes is based upon the cutoff for the retinopathy, nothing to do with cardiovascular risk or whatever, right? So retinopathy risk was initially found to be going suddenly high from 110 onwards. Then people realized 126 should be more appropriate because they looked at the, secular data across several decades. If you start diagnosing pre-diabetes as diabetes, you will be subjecting millions of people across the world to unnecessary treatment. And that is the reason it is not done.
Thank you, sir. We go on to the Amit's talk now. Thank you. We stop it here. Thanks, Amit, for giving this much of time.
Thank you, sir, for accommodating me. Respected chairpersons, Dr. P.K. Singh, sir, Dr. Hemshankar Sharma, Dr. Manish, sir, and stalwarts sitting in the dais, and dear friends from Purnia. Today, I'm going to talk on diet and how does it play a role in management of diabetes. What do we call it as medical nutrition therapy? So whenever a very, innocuous, innocent person asks you in your chamber, "Sir, kya khaye?" So this is the response of the doctor, "Baap re." So it opens the whole Pandora's box, and normally in a busy practice, you try to avoid. So talk to my dietitian, talk to my compounder, talk to my medical help. So normally this is our attitude. We avoid answering so many questions because there are so many caveats to that questions. दूध तो गाय का कि भैंस का, बकरी का दूध पी सकते हैं कि नहीं, ऊंट का दूध पी सकते हैं कि नहीं, उसका खीर खा सकते हैं कि नहीं, उसका पनीर खा सकते हैं. So many caveats to the question. So because it's going to open a Pandora's box, you are trying to avoid those questions. But आज की बात is nutrition is very, very important. It can decrease the HbA1c to almost 2.6%, better than any oral anti-diabetic agents. So such is the importance. So however hard we try to avoid this question, it should get back to you every time because it is more potent than all of your weapons that you have to treat diabetes. So MNT is very, very important. And if you go on to the subject of MNT per se, so what is the importance? So what is the principles? So why do we talk of MNT? What are we going to achieve by talking on medical nutrition therapy? Because it's going to give you a appropriate energy and nutrients for health, growth, and development. It will definitely reduce the blood sugar and hence symptoms of diabetes. And if you are able to control your blood sugar to the tune of 2.6%, even just by diabetes control, you are going to prevent, delay, and even treat the complications. And then you will be able to achieve an acceptable ideal body weight, what we call. And MNT will integrate diet, which means me today, activity, which means Sudhir sir today, and pharmacological, which means all of us today. So it will integrate everything. So we need to understand that MNT is in one stop out of the 3 parameters. And if you are able to give you a proper nutrition, able to give proper nutrition to your patients, that patient will be very happy in maintaining his health, which is physical only, which you are concerned only, but you should also be concerned about the mental health and of course the social health. So the social and psychological well-being of the patient is equally important. And by maintaining a good nutrition, you'll be able to integrate these things into that patient and the patient will be very happy. But if you talk of diabetes, we talk of type 2 diabetes. But if you talk of type 1 diabetes, if you talk of diabetes per se, there are so many subsets. And then you'll have not only the elderly, not only the adults, the usual understanding that we are talking of adults only. But if you talk of nutrition, there are many subsets. So you'll have children suffering from type 1, type 2. You'll have elderly who have had long lives living with diabetes, and you have a subset of patients who are very, very special, which is pregnant ladies. So there would be many subsets apart from your usual adult population, and there would be many demands. So children, your aim would be to maintain an appropriate growth and achieve the milestone of development for that individual, for that child. And if the child is obese, you need to take care of weight loss for that obese child. if the person is elderly, you need to consider the concomitant conditions of that individual. So if the patient is having a CKD, if the patient is having a serious what do you call cardiovascular disease, a patient who has had a stroke and not able to eat properly, and of course very minor things needs to be taken in elderly, like teeth loss. The patient is not able to chew food. And of course, we have the pregnant ladies who have increased calorie demand to ensure optimum growth of the fetus. And there is a huge responsibility on the treating doctor of reducing the diabetes related complications in those gestational diabetes mellitus patients. Before we embark on the journey of diet, we need to have a proper assessment of that individuals, and you need to take care of the psychological, social, physical status, the lifestyle, the cultures, the feeding habits, the socioeconomic status, the age, oral health, and everything. So before talking on diet directly, you need to have a slight assessment of what the person likes, what the person dislikes, from what community that patient belongs to, from what socioeconomic status that patient belongs to, how is the teeth, is he able to chew? So these are very detailed things which you need to look out before you give a prescription of diet. Normal calorie requirement is this. These are all physiological things, and I'm sure you must all be knowing this. I don't want to go into the details. So there are calorie requirements for every age, and we need to understand this. So this is the normal calorie requirement, and this is the normal daily recommendation. So carbohydrate should incorporate 50 to 60%, fats 20 to 35%, proteins 10 to 20%, and dietary fibers 20 grams per 1000 kilocalories in a ratio of 50:50. So we'll be coming to some details on this topic, and we need to understand the importance of micronutrients as well in certain subsets of populations. So this is the basic of carbohydrates, fats, and proteins. I don't think we need to go into details. We also need to understand that vitamins, though very small in amount, need to be present in your normal dietary constituents. But remember, for the majority of people with diabetes, there is no need for additional vitamin and mineral supplementation, because that is taken care of the usual balanced dietary intake that you will prescribe to that patient. So multivitamin prescriptions should not be a routine affair in your prescription, but then if there are certain special circumstances, you need to take care of that. So don't write vitamins in all your prescriptions. Ensure that the patient is actually requiring, and then you can go on to prescribe vitamins. Of course, as I told you, fibers are of two types. Insoluble fibers like wheat bran, whole seeds, fruits and vegetables, and then soluble fibers like legumes, oat bran, barley, apples, citrus fruits, potatoes. So you need to recommend a fiber content for every 1000 kilocalorie. You need to give at least 20 grams of fibers in a ratio of 50% of insoluble and 50% of soluble fibers. So ensure that this is taken care of. Minerals should be present in the natural food. Supplementation is only required when there are certain special situations, like elderly people, pregnant and lactating women will require calcium supplementation. Pregnant ladies and anemic patients would require iron supplementation. And again, pregnant ladies and patients of certain subsets would require folic acid supplementation. So minerals, not in all population, but only in special populations. Salt. We are very salty people. नहीं, उनके चेहरे में बहुत नमक है, हमारे शरीर में नमक है. So we are very fond of salt. So we eat chutney, achar, papar. You'll eat just outside this hall today also. So chutney, papar, achar, these are all salt condiments made of salt, full of salt. So ensure that your salt intake is taken care of properly, and also ensure that your patient's salt is also taken care of properly. Salt is essential. Do not deprive the patients with salt, but also do not preach of taking extra salts in your diet. Alcohol, not to be discussed in Bihar. Yet, it has to be done in moderation. One thing which needs to be talked is, so if you are going to take binge of alcohol, you'll go into hypoglycemia. Binge drinking is what is seen in Bihar populations nowadays. They go to outside the state and they have whole, no, I cannot say the words, but whole lot of alcohol. Quota of last 1 month, 30 days, 15 days, quarter days. So binge drinking is nowadays common in Bihar, and young people, they go into outside the state for binge alcohol. Binge drinking will lead to hypoglycemia. So there have been many instances where patients have landed up in hypoglycemia and the family has thought that the patient is, unconscious because of the alcohol. Hypoglycemia, you all understand that can be a killer. Therefore, alcohol, पे इतना ही. Artificial sweeteners, these are nutritive as well as not nutritive sweeteners, which you add in your food just to make it sweet. So the sweeteners which are recommended are sucralose and stevia, which is sugar. But then there are recommendations of all artificial sweeteners. Mind it that you need to take care of the acceptable daily intakes of artificial sweeteners. Certain artificial sweeteners can be carcinogenic. Artificial sweeteners have been found to have a negative impact on diabetic patients because they can increase the body weight also. So if you are in the habit of taking large amount of artificial sweeteners, you need to take care of the amount. Weight management becomes very important, and we all know that even 10% of weight loss can have huge impact on your metabolic profile. So weight management can be done by me, which is diet, by sir, which is physical activity, by behavior modification, and our support and monitoring. So weight management becomes important. Nutritional educational tools are very simple steps which you can just teach in your OPD chambers. A healthy eating plan would ensure that there is sufficient amount of vegetables, fruits on one half of your plate, and the other half would contain whole grains and healthy proteins. So this would ensure a healthy eating plan. You can educate by your finger and hand guide. So this is teaspoon, this is tablespoon, this is 1 cup, this is almost 3 ounces, which is the amount of meat protein which you can take. So these are small hand guide techniques by which you can educate your patient in your OPD, even in your busy schedules. And then you need to educate the signal system, what are red foods, what are yellow foods, what are green foods. Green foods means which we can go. No, green is for going. So low glycemic index foods, high fiber content, and low in fat. Yellow foods, stop. So take in moderation. Be careful. So high GI foods, low fiber content, and moderate fats. And red foods are to stop. So rich in fat, sugars, high glycemic index foods, low fiber content. And I'll just give you an example that if you talk of rice, तो भात जो हमारे यहाँ घर में खाते हैं वो ग्रीन जोन में है, और बिरयानी जो आज आप खाएंगे, मोदी सर खाएंगे ना? अच्छा, तो बिरयानी खाएंगे तो वो रेड जोन में है. So similar quantity, similar type of food can be made green, can be made yellow, can be made red. Bread, whole wheat bread, roti, white bread, मैदा वाली रोटी जो रेस्टोरेंट्स पार्टीज में मिलेगा, और केक्स, रेड जोन. Noodles, steamed noodles versus deep fried noodles, Indian bits like chapatis, naan, butter naans, potatoes, baked potatoes, French fried. So these are some examples of green foods, yellow foods, and red zones. So you need to understand that this is the spread of food. You can choose any one, choose the green one. It would help you. Food exchange is a kind of technique where you exchange food, equivalent foods in 1 quarter. So I'll just tell you that for same kilocalorie, cereals, pulses, cow milk, buffalo's milk, and these are some of the fruit exchanges. So amongst the fruits, you can take anyone. So fruit exchange is a kind of technique where you take similar quantity of food with the similar calorie value and you can exchange it. So you cannot ask your patient to eat similar food every day. So you can just exchange them. Then you need to have the habit of carbohydrate counting. So it's a way of planning carbohydrate intakes to manage your blood sugar levels. And for men, per meal, 60 to 75 grams of carbohydrate is allowed, which is equivalent to 4 to 5 carbs. And women, 3 to 4 carbs, and for snacks, 1 to 2 carbs per meal. So one carb is 15 grams. So let's see this. One carb, 15 gram, will be one sliced bread, which is white or wheat or whole grain, one small pav, adhi roti, which is made of bajra, makai, jwar, one chapati with a diameter of 6 inches, 3/4 of a paratha. So you can allow these 15. So you are allowed to have, for men, you are allowed to have 5 carbs. So you can have one from this, the other from the cereals, the other from the sweets, the other from the fruit juices. So you can have a whole meal made out of this. So you need to know this carbohydrate counting, and you need to practice it, and you need to educate your patients. So carbohydrate counting becomes handy. Beware of young children who become diabetics, say type 1 diabetics. So they have the habit of eating, those French fries and all those cold drinks. So these are empty calories. They are going to add more fats and sugars, increase more calories. So avoid empty calories. Calorie requirement is slightly different for type 1 and type 2. And gestational diabetes depends upon the pregnancy status, where you can just increase the kilocalories, 30 in the first trimester, 36 in the second, and 38 in the second, 38 in the third trimester. Moderate calorie restrictions and approximately 1800 to 2200 kilocalorie has been shown to prevent microsomia. If you're taking insulin, and you need to educate what kind of food, if your patient is taking insulin. So twice daily mixed insulin would require 3 meals and 3 snacks per day. Multiple daily injections, which is the basal bolus, would require similar kind of food pattern. So even your prescription of drugs would also require slight changes in the dietary habits of your patients. So you need to be aware of these very small things also. So this is a classical diabetic diet plan for Indians. I don't need to go into details. 1500 kilocalories. If you have the time, you can just prepare this for your patient. If you do not, you can ask your people who are assisting you to make this. So these are functional foods where methi seeds, they have been found to control blood sugar and cholesterol levels. Oats are rich of soluble fibers, especially beta glucans, antioxidants, and bioactive compounds, including carotenoids, phytic acids, and phenolic acids. Nuts are very rich sources of high biological value proteins and other beneficial advantages. Soy proteins, omega-3 fatty acids, and flax seeds are rich source of omega-3 fats. So these are beneficial functional foods which you can definitely recommend to your patients. Free foods are those foods in which you can allow in plenty. So raw vegetables, tea, coffee without milk and sugar, green tea is always welcome, plain lemon juice, thin buttermilk, clear vegetable soups, and tomato soups without sugar are free foods which you can freely recommend to your patients. Sick days for type 1 and type 2, you need to understand that type 1, if the person becomes sick, you have to take the usual insulin, but do not omit or reduce your dose. Eat according to how you feel and what food you can tolerate. Monitor your sugars. Similarly, for type 2 diabetes also, if you do not, if the person cannot take a meal, so take small quantity of snacks. Drink plenty of waters. So one few slides of remission in diabetes. We talk of remission. Remission in diabetes, is it a myth or a reality, is a question which is pondering us. All of us, we have solid scientific evidences which say that diabetes can be remitted for pretty long time. And this is the scientific basis of the twin cycle hypothesis, which tells you that if you can lose your weight, you can reverse your diabetes, you can take your diabetes to remission. And weight loss by dietary intervention is a definite scientific way of reducing it. 15 kg weight loss can reduce 15 grams of pancreatic fat, and that can remit your diabetes. So low carbohydrate diets and very low carbohydrate diets have been found to cause remissions, and direct study showed that persons who lost more than 15 kilos went into 86% of patients went into remission. Type 1 diabetics also can go into remission. There have been some studies, especially I'd like to quote this, that nutrient dense plant rich diet have been found to slow the further destruction of beta cells if dietary intervention is initiated early in the course of type 1 diabetes. So remission in type 2 diabetes is a possibility which we need to look into.
Amit, little quicker.
So to summarize, dietary control plays a vital role in diabetes self-management. Calorie requirements should be taken into consideration while planning the meal, and it's important to consider the GI, means glycemic index of foods, while planning a meal. So we are proud of litti chokha. It gives you 620 kilocalories. Sabudana khichdi will only cost you 486 calories. So marji aapki, आखिर सर है आपका. Thank you very much.
Thank you for लिट्टी चोखा प्रोपोनेंट. जो उसमें एक डब्बा घी आता है उसको आप भूल जाते. एक डब्बू घी भी आता है लिट्टी चोखा में. अच्छा 2 चम्मच का साइज देख लेना. Right. So thank you very much. And now can I
Running short of time, sir. We are already 15 minutes late.
Sir, I will take a minute. Can I just call upon all the speakers to felicitate them?
Yeah.
That should be done or no?
Yes, that should.
Okay, thank you
That
so
has to
much.
be done.
Actually, come on, please.
May I request our chairman organizing reception committee, Dr.
you.
Pathak, to come. Dr. Pathak, is he here? During lunchtime, Dr. Jha will train you for exercises. May I request organizing chairman, Dr. S.P. Singh, to please honor the chairpersons and speakers. First of all, let's honor our chairpersons. Please present a memento to Dr. Hem Shankar Sharma ji. S.P. Singh. To Dr. P.K. Singh. P.K. Singh. Dr. Manish Kumar. And may I request our patron, Dr. D. Ram, to please honor our honorable speakers. First, to Dr. Anand Shankar. Then to Dr. A.K. Das. And then to Dr. S.C. Jha. Please stand for a group photo. And now the next session, for the next session, I invite Dr. R.S.P. Singh for the chairperson. Dr. R.S.P. Singh. Dr. P.K. Agrawal. Dr. P.K. Agrawal, is he here? May I invite Dr. K.K. Mishra to chair the session? Dr. Mohammad Sadiq and Dr. Avijit. Dr. R.S.P. Singh, Dr. K.K. Mishra, Dr. Sadiq and Dr. Avijit. Please take your chairs as chairperson and conduct the session of insulin workshop. So the honorable speaker is Dr. Divyendra Bhushan, will be talking on insulin injection technique and glycemic monitoring. So I hand over the stage to Dr. Divyendra Bhushan for this talk. Dr. Divyendra Bhushan.
Today we have a workshop on insulin injection technique, and as we all know that for insulin to work, it needs to go into the fat layers under the skin. And to give injection of insulin, we need to know how to fill the syringe, choose the right syringe, choose the right dose, and decide where to go, where to give and how to give. And insulin injection technique is everything in which it makes making insulin more safe and more effective. And to elaborate on this, we have with us a learned speaker, Dr. Divyendra Bhushan. I request you, sir, to discuss on this issue.
Thank you, sir. First of all, I would like to extend my warm greetings on behalf of AIIMS Patna to all of you. I am thankful to all CCDSI committee members and founder president Dr. A.N. Rai sir, present president Dr. Umesh Khan sir, Dr. Modi, Dr. Abhishek, and many more. I think I can forget, but all the team who is working hard, and this program seems to be very successful. So I have been given the task of organizing a workshop, but it is with the help of few postgraduate, I would like it is a bi-directional talk, and but it is more likely a didactic lecture. It became a didactic lecture. So insulin injection techniques and glycemic monitoring is very important when we come across the patients of diabetes. It is everyday thing which we have to look. There are various kinds of errors we encounter in our day-to-day practices. We see that how can we avoid them. So just a slide about the insulin. Insulin is a amino acid based a protein hormone which is released from the beta cells of the pancreas. It is a 51 amino acids, contain 2 chains A and B. The endogenous insulin has a half-life of around 4 to 6 minutes. But for the commercial use, the insulin has been had various modifications, and it become by the recombinant insulin. And newer insulins are coming, as we are seeing that Degludec and various other insulins are coming, long-acting. So these are the types of insulin we have when we prescribe. So ultra short acting like Lispro, Aspart, Glulicin, and regular. Intermediate acting like NPH, and long acting like Glargine, Determir, and Degludec. we can see that the onset of action of the ultra short acting is around 0.25 hours. It is around 10 to 15 minutes. And it reaches a peak up to the 1 hour. And total duration of action is 3 to 4 hours. Let me remind you, these all things are when the insulin is given subcutaneously. It is not when the insulin is given IV. So it is just for the when we give the insulin subcutaneously. For identification of the insulin, the companies has given them the color coding. So regular is giving yellow, mixed start is giving brown, and various other giving various color coding. That can be easy for a person to recognize it, to separate it. Now the site and the methods to use. So if any of the postgraduate can want to volunteer and come over here, then it is very desirable. Otherwise, I will ask someone from the postgraduates can come here. What they do, anyone can come. Please don't hesitate. मतलब कोई exam नहीं है, कोई number नहीं है, कोई इनाम भी नहीं मिलेगा, लेकिन you will get some experience. Any postgraduate, come. So the most preferable site is abdomen. We all know abdomen is the most preferable site, followed by the lateral side of the thigh and then the arm. So what we taught to the patient कि कहाँ लगाना है? In the busy OPD, what we say? How you describe? You like when you are which year postgraduate? First year. Have you seen? Have you prescribed insulin? So what you tell to the patients? कैसे? Abdomen तो बहुत बड़ा है. Around them like this. Around. Do you give guidelines? Around them like. Around umbilicus मतलब umbilicus यहाँ पर है, यहाँ या यहाँ. Around 4 to 5 centimeters. 4 to 5 centimeters. Exactly, he is doing very correctly. What we prescribe is the four fingers from the umbilicus. We can apply from the rotational basis. And as it is shown in the diagram, we can rotate it. We can rotate the slides. We rotate the side. Very good. Just stay over here. You can come here. So now, before going to what is the exact method of giving the insulin, let me have a first-hand experience. How you give the insulin? Have you given the insulin in your ward? Yes. So कैसे देते हो? It is. I have one insulin syringe, one vial. Am I audible? I'm audible. No? So I have an insulin vial, which we usually give in the ward. So tell me how you give insulin. How you give? So you just tell the steps. So we have to see which kind of insulin we have to give. Mostly in the wards, we are giving multiple subcu. We are giving regular insulin 3 times a day, and when the long acting insulin in the night, bedtime, mostly, not always. So this is the insulin vial, regular, and now Dr. Sir has to, what's your name? Dr. Priyank has to give 10 units of the HIR insulin. So how will you take it? What will you do the patient and what will you do the? Come. So if the vial, upper part. So if the vial is already open, we have to alcohol से इसको थोड़ा सा clean कर लेने का है ना? अपने hand को wash कर लेने का है. We have to clean our hand. Okay, then. Good. Okay, then you will just apply it in a second. Huh. So up to the 10 units, okay? And then how will you inject it? You just not inject me, but you can show it. Yes. So it is an abdomen. It is not my hand, it is an abdomen. 4 centimeter from the umbilicus. Around 15 degree. Okay. Do you want to pinch the skin? Want to make a fold of the skin? Then you will do. Any colleague of him who want to correct it or want to modify something? Anyone? No one? Directly? Directly. So but you make it an angle. Classically, we don't make an angle. So this is about the vial and the syringe. So let's go through what is the correct way of giving it. First of all, we have to wash our hand. So first of all, we have to take the whatever unit I have to do, then take it here. So we have to wash our hand, gather our supplies. We need an insulin syringe or pen or cartridges in the form of insulin. What is the difference between the insulin vial and the pen? Can anybody tell me? When we give insulin by the syringe and the vial and by the pen. So insulin pen is a very thin needle. So in that case, it is not always needed to fold the skin because it is very thin and very small. So it can directly go into the subcutaneous tissue. It can't reach to the muscular plane. So that is the one difference. Prepare the injection site. We have to clean the injection site with the alcohol swab and let it dry. Not to keep just we have done the swab kiya and then just injected. We have let it dry. Prepare the insulin as I have told you. Then we have to draw the insulin by we have to take the air and put the air into the vial and then draw the injection. Inject the insulin. Wait for the few seconds as I described. Just after giving the total amount, we have to wait for the say 2 to 3 seconds, 3, 4, 5 seconds, and then remove the needle. Apply a gentle pressure, do not rub it, and record the injection. In the pen, it is a facility. There are certain pens which has facility what amount of insulin we have given in the last room. And then we can rotate the injection sites. So what are the adverse effects of insulin? So what are the So adverse effect of insulin, it is a hypoglycemic agent, then it can cause hypoglycemia very well. It causes weight gain, it causes pedal edema, it can cause lipoatrophy and lipohypertrophy. So insulin can cause all those things. If you have followed the patients of insulin, patients having insulin, you must have seen all these complications. So what are our targets when we treat a patient with insulin? When we treat diabetes. So target is around target is pre-meal should be less than 130. Classically, post-meal should be less than 200. Random should be less than 200, and HbA1 should be less than 7 or less. With this mark, that patient must not go into the hypoglycemia. So how we describe monitoring in the home? When you prescribe a patient to take insulin in the patient to take the insulin at the home, how you describe to monitor it? What you tell them? कि कैसे monitor करना है? So all the diabetic patients should have glucometer with them. It is must. So how you prescribe? Daily करना है? Daily fasting करना है. Then postprandial, then so any symptom suggestive of hypoglycemia. So it is always good to explain the symptoms of hypoglycemia. Your prescription should have this written. The symptoms of hypoglycemia has been explained to the patient and measures to combat it has been explained. It is very important. Any diabetologist want to treat the diabetes or not, he doesn't want to get his patient into the hypoglycemia. है ना? थोड़ा सा बड़ा रहेगा कोई बात नहीं, लेकिन hypoglycemia nobody wants. So as he exactly says, if there is any symptom of hypoglycemia, person has to check it. So fasting, postprandial, whenever the patient have feeling of hypoglycemia like increased thirst, sweating, palpitations, all these suggest if a person is having hypoglycemia. Then at night. So these are the things. How frequent we advise? How frequent we advise glucose monitoring? Daily, twice in a week, weekly, or once in 2 weeks. Anyone? Yes. Yes, very, as sir has correctly said. Yes, sir, it depends upon how good the blood glucose control is. So if the person is having stable blood glucose control, you can make it once in a week or once in 2 weeks. Or if it is not, it is fluctuating very high, then you can recommend it once in a day also. So when we are checking the blood glucose, I would like to just ask few things. How to do blood glucose with the glucometer? Have you done it? कैसे करते? So this is a glucometer. We all must be aware of this. This is a glucose strip and this is the pen. This is the pricking device we should have. Do you have this involved? You have needles. So this is the one of the fault. The needles usually the stylets are very, it is a painful thing. But okay, so ideally we should have a pen. Then yes, yes. So where to prick? No, this is my finger. Where to prick? So distally. So we have to prick on the sides of the finger. So whenever you have seen a person whose blood sugar is getting repeatedly checked in the ward, but we used to check classically 6 times in a day. So when we check it, when we prick on the tip of the finger, it is very painful for any diabetic person. The person is all mostly having neuropathy, and this prick make it more painful. So try to have this on the sides of the finger, on the side of the finger. So in hospital, but as I have said, that it depends upon if the person for which patient has been admitted in the medicine ward. Classically we used to do pre-meal and 2 hour post-meal, or many times we do a one glucose at the midnight also. Or if the person's eating pattern is not good, then we measure it 4 or 6 hourly. In the intensive care, mostly we give IV insulin. Then the blood sugar has to be monitored hourly, or if it is stable, then maximum 2 hourly. So what common mistakes we have? If anybody, we have various diabetologists here, and if they want to add something, they can add. So this is what we prescribe most, 30-70. But many times patient get this. Why? The reason? Because when the patient used to be in the ward, we are giving this yellow wala insulin, regular. So that person purchased it regular insulin only. When you ask them, when you prescribe them 30-70, 14 or 10, he went there and he used to continue with the regular insulin. Then that is why when he come back with a poor sugar control, then he come back with a poor sugar control. This is the common mistakes we do. Not timing. This was a study done, and it was checked that how the patient used to take the insulin with the meal. And it is seen that only 40% of, if we take 15 to 45, only 40% people take on time. Most of them take either after the meal or beyond it. Storage of insulin, it is very important. So storage is, we should not refrigerate it, must never be frozen. And direct sunlight, we should avoid that direct sunlight should be there in the insulin. After first use, the insulin vial should be discarded after 3 months if kept in the 2 to 8 degree temperature, or 4 weeks if kept at the room temperature. So if once it is opened, this vial is opened, then it can be kept at the room temperature. Or what we prescribe classically, घर का जो भी सबके घर में फ्रिज नहीं होता, yes, it is true. So we prescribe it कि आप जब भी जहाँ भी सबसे अंधेरा है और जो सबसे coolest part of the घर है, आप वहाँ पर रख लो. You can keep it there. I don't know how you are visible or not. How many times? How can we use insulin syringe? How many times we can use? Classically, only one time. You can see how it becomes. It is used 2 times, so it is just bended it. And many times if bend, it will cause more and more pain. It causes more and more pain. Site. So people use it wrong sites. In the hospital also, we used to train our sisters regularly, because the staff is also more convenient to give the insulin on the arm, because they are more convenient to give any subcutaneous or intramuscular injection at the arm, and they don't see it is outer aspect, inner aspect, they just give it. So we have to reinforce it to the our staffs. So this is all about. I would like to listen from the from the experts, if anything they want to add. Thank you.
Thank you, Dr. Devendra Visan, for illustrating on the injection insulin technique and glycemic monitoring. And the importance of this topic is quite evident, as the organizer has devoted 20 minutes time for discussing this topic. And we all know how important is insulin, and we all are quite aware the life of our patients of diabetes before the advent of insulin. So insulin used in proper way gives rather a lease of life to our needy patients. And we must devote some time whenever we start our patients on insulin. We know that majority of, or rather almost all patients of type 1 diabetes mellitus needs this throughout their lifetime. And majority, a good chunk of our type 2 diabetes mellitus patients also needs exogenous insulin in their course of diabetes. So this is quite essential that we should know the proper technique of insulin injection and frequent monitoring, glycemic monitoring from time to time. And whenever we institute such treatment to our patients, we must devote some time. And these issues at the outset should not be left to our compounders only. And whenever we institute treatment, we must give some time patiently to our patient for this, explaining all these proper ways that you have already demonstrated. I don't think there will be many questions if
we have to settle the question session, sir. We are 25 minutes late almost. So now I request our organizing secretary, Dr. Ajay, to present the memento to our chairperson. To Dr. RSP Singh, sir. To Dr. K.K. Mishra ji. To Dr. Sadiq. Dr. Abhijit. May I request Dr. R.K. Modi to present memento to our honorable speaker of the session, Dr. Divyendra Bhushan. Thank you. Thank you, everybody. So now we move on to next session. Today's keynote lecture. I don't. For that, I invite Dr. Professor A.N. Rai, sir, to chair the session. Dr. M.L. Jain, sir. Dr. M.L. Jain was here, I think. I can't see him. If he's outside, please call him, Dr. M.L. Jain. Then Dr. S.P. Singh. Dr. S.P. Singh and Dr. Divyendra Bhushan to chair the session. And the speaker whom we always wait for to listen, a great maestro in the field of diabetology nationwide, Dr. Ajay Kumar, please deliver your talk.
Good afternoon. We are going to have a talk by none other than a master speaker, Dr. Ajay Kumar. He is well known as a diabetologist, not only in Bihar, India, but also internationally. He has participated in multinational studies. So he is going to give us talk on newer technology in diabetes. Dr. Ajay Kumar, please.
Honorable chairpersons, ladies and gentlemen, and dear colleagues. The person who is on the screen is no more is Steve Jobs. And we know his contribution towards the science. And almost 50% of people sitting in this audience must be having the iPhone in their hands. And of course, we know the great technological innovations done by Steve Jobs and his team. And look at this statement that he made. I think the biggest innovations of the 21st century will be at the intersection of biology and technology. So majority of the engineers who are working today in mega engineering institutions of the world, they are mostly looking and doing their research, which can be applied to the medical field. And there are hundreds and thousands of such examples. I will just give you a peep into what is in store. And if you just look at this slide and think of this person standing on the screen as a diabetic person and start from the bottom. Today we have smart weighing scales, which not only give you the body weight, but will give you the body fat percentage and the distribution of the body fat. Then you have a smart socks for diabetic patients, where the neuropathy is not only prevented, but it will exactly tell you the alteration in the temperature pattern and will guide you about how to save the limb in future. We have the smart ECG machines, which gives you artificial intelligence conducted reports, which we already see in our day-to-day practice. We have the smart BP machines, and of course, we have the continuous glucose monitoring system, and I'll come to that in a minute. But the two things which is extremely important, which is not available today, but is likely to be available in short period of time, is the one written on the left-hand side, that Google and other companies are developing glucose monitoring by tiers. They will put something in your lens here in your eyes, and that will give you the 24-hour glucose measurement across the continent. That's something very special. And even more important is one on in the middle on the right-hand side. We are now developing a smart technology where every medication will be delivered to a patient, which will read the physiological response of that particular individual, because we know the science of pharmacogenomics, that every individuals respond differently to individual drugs. And that particular smart technology will determine that whether metformin is going to be effective in this patient or not. And if not, then that has to be substituted by some other products. That is the power of innovation today. All of us now today are using electronic health records, which obviously is become an integral part of the diabetes care. The data which you store in your electronic health record is not only important for your patient, but it can be shared across with the other physicians, with other scientific bodies, and a lot of things which can be done. Obviously, a better disease management will take place. But it's also raising certain issues about the patient privacy, the confidentiality of the data, and these issues will continue to bother us in future, and we have to address these concerns as well. This is my digital prescription, and compare this with my handwritten prescription. I think this is one example which will tell you that maybe my handwriting has now become so bad that the pharmacist or the patient will not be able to read it. So it is extremely important that we should all be shifting towards the digital prescription, which is legible for everybody. And one of my friends very rightly said, कि भैया जो प्रेस्क्रिप्शन लिखते हो तुम अपने लिए नहीं लिखते हो, दूसरों के पढ़ने के लिए लिखते हो. तो ऐसी लिखावट होनी चाहिए जो दूसरे इंसान पढ़ सके. इतना थर्ड क्लास हैंडराइटिंग में प्रेस्क्रिप्शन मत लिखा करो. That is the importance of scientific technology, and this was my prescription. I of course agree that my handwriting has become very bad. It was not bad to start with, but with more and more patients it has. Now look at the advancements in technology. I think we are not only talking about telemedicine and mobile health, we are talking a whole lot of artificial intelligence completely usurping the science that you are practicing today, and there are hundreds of such examples. Particularly during the COVID times, we understood the importance of telemedicine, the power of telemedicine. I'm sure telemedicine saved millions of lives during the COVID pandemic, and of course it will continue to do so. But once again, the legalities around the telemedicine are something that our associations across the country and across the world need to address. The other issue is that when you talk about a technology, there should be some regulation. And the good thing is that FDA in US and the European Medicinal Agency, they have now started approving digital technologies. And these are some of the examples. These are the technologies like, Gluco and several of them. I will not go into the details. They have now been approved that yes, this particular tool can be used by a diabetic patient or a diabetes practitioner, and that will be beneficial to the patient. Next logical question is, why do you say so? If this telemedicine and everything is so important, how is it going to help the people? One, I told you that the data can be shared by the patient, by the scientific team. It can be analyzed for research purposes. But look at the bottom, the blockchain technology. How many of you know that the blockchain technology of this artificial intelligence variety is used in the cryptocurrency? All of you know that cryptocurrency? Now, cryptocurrency is completely based upon this blockchain technology. And therefore, when you use a blockchain technology in diabetes care, every patient across the world can have one block of the data. And you do not need to ask a particular hospital or a scientific body for that data. Every patient's data is there on the cloud or whatever, and the whole world can access that data if it is permitted by that particular patient. So utilizing a blockchain technology is going to completely revolutionize the technology in the medical care. But then the next logical question is, how does it matter? If I use technology, is it going to do a better control of my blood sugar? Do we have the data? Yes, we have the data in type 1 diabetes. We have the data in type 2 diabetes. I can show you a number of studies both in type 1 and type 2 diabetes, where randomized controlled trials have shown that using technology will give you an additional reduction in the HbA1c close to 0.3 to 0.6%, and which is a lot. And this is not one data. We have 35 randomized controlled trials. We have Cochrane review of 21 studies, and we have systematic review of 46 studies, and all of them clearly coming to same conclusion that if you use digital technology, you are going to have a better diabetes outcome. Now, moving beyond, let's come to what the Bindu was showing, the classical syringe and needle for treatment of administration of insulin, and compare with the smart pens. Remember the era of vials and syringe? And then we came to pre-filled smart pens. And then look at the revolution in the size of the needle. All this has been achieved by technology. Today injections of insulin are nearly painless. We have 32 gauge needles available today, which is almost like, pinching your bottom out of joke. And therefore, these technologies have to be welcomed. But I'll tell you about this smart pen, which is an absolutely amazing thing. In one pen, you have both the bolus and the basal insulin together, and it will determine itself how to deliver this much dose of the basal and how much to bolus. And that is the beauty of the technology, as you can see in the insulin injection techniques. Mobile apps on your mobile phone. Look at the range of mobile apps which are now available and approved by the international regulatory bodies, Diabetic Body and Log Frog and Wave Sense. There are and this is only 3. There must be more than 100 apps today. And what do? Just look at one of them. It not only actually gives you idea about the diet, about your exercise, about your meal pattern, about your timing of the drug. It will warn you that wake up, this is the time to take your medication. Wake up, you have to do your exercise, and so on and so forth. The Apple Watches, that's one example of this kind of a smart technology. If you wear Apple Watch, it will tell you, come on, you have been resting for so long, go and do some exercise. This is the smart technology that is doing to this. And the number of health apps are of all addressing almost every single issue in the management of diabetes. Nutrition apps, physical activity apps, glucose monitoring apps, insulin titration apps, insulin delivery apps. So you think of every single reason for diabetes management, and today you have a very nice FDA or other international regulatory bodies app, and you can see how beautifully the data, your data is displayed on your mobile phone in such a nice manner that is certainly going to motivate you to do much better control of your diabetes on a day-to-day basis, and that's certainly going to be helpful. Moving on to the other area of technology, type 1 diabetics. Think of those children who have to take 3, 4, 5 injections of insulin every day, and then the insulin pump was discovered. But look at the first insulin pump, how big that was, that person carrying that insulin pump on his back. And from there, we have come to today's insulin pumps, which are so small that they cannot even be seen, almost they can be implanted, and the patient is not aware, almost forgets that I have got an insulin pump in my body. That's the beauty of technology that we are talking about. And continuous subcutaneous insulin infusion, and this spectrum has moved to artificial pancreas. And I will explain to you how this has changed. We have the open loop sensor augmented pump, hybrid closed loop, and fully closed loop. What is the difference? If you take the open loop, you have to manually adjust the dose, basal dose or bolus dose or whatever. In hybrid, you have to partly adjust and partly the system will take care. But in the fully closed loop system, everything is done by the machine. You don't have to do anything. Think of the technological innovation which would have achieved this kind of system on a day-to-day basis. These are the examples of sensor augmented pump, which I was alluding to. And this is the fully closed loop system. What is there? There is a sensor which will 24-hour monitor your blood sugar, and that center, CGM data, will be reviewed by that system within it through an artificial intelligence technique, and then it will be fed into a central algorithm which will determine कि इसको 6 unit insulin चाहिए कि 12 unit insulin चाहिए, and the syringe within the pump will inject that amount of insulin. So everything is done by the machine itself, and this is called fully automated system, or let us say artificial pancreas. A similar variety is called patch pump, which is not very widely available. It can be just put on the skin. You don't even need to implant, and that patch pump will deliver the insulin. But this patch pump will possibly not do the reading at this point of time, but maybe in future they will develop, which will also read the blood sugar level and then decide the appropriate dose to be delivered through the patch pump. This was considered to be one of the greatest medical discoveries, bionic pancreas, which is a fully automated closed loop delivery system, which I was just alluding to. FDA in 2019 actually designed this, one of the most important medical innovations in the world. And this was done by this famous scientist, Dr. Edward Damiano. Think of the glucose monitoring the Bindu was just alluding to. Initially, we had these glucose strips, which had so many fault lines. But today we have such a smart strips that even tomorrow, a time will come when you will not need even the battery for your glucometers. So that's the kind of innovation the engineers are doing across the world, and they are making our lives much better. Now coming to the most important innovation in the field of diabetes management, which is called continuous glucose monitoring system. And they are of the two types. One you simply put on the body, or the others are which are implanted in your body. And today we know all of us are using the flash monitoring system, Libre. I'm sure many of you are using on your patient, and Libre Pro. All these are so much useful, and I will tell you why they are useful. And you can go even one step more and implant them into your body for 365 days monitoring. Now let us look at this continuous glucose monitoring data. In 24 hours, they are measuring 288 times. And then you can have two types. You can download that on your mobile phone or a computer and then decide what to do after 5 days or 7 days or 14 days. Or you have the real-time data also, where every minute or every hour you can check what is happening in my continuous glucose monitoring system. And on the same day, you can decide whether I have to change the dose of my insulin, I have to increase my exercise, I have to decrease my carb content or whatever. Whether it is diet, exercise or medications, all of them can be done on a real-time basis by using this continuous glucose monitoring system, which is available. Why this is important? I'm sure many of you sitting in this audience know that we have two patients with the same HbA1c 8%. So you would say that this is a reasonably good control of 8% of HbA1c, but look at the huge glycemic variability on the patient on the top and compare that with a very nice tight control with minimal glycemic variability with the patient at the bottom. Obviously, the patient at the top is much more at the hazard of developing cardiovascular disease or incidences of hypoglycemia, whereas the patient at the bottom is likely to have much better prevention of long-term complications and minimal risk of hypoglycemia because of this. And this has become so important that HbA1c is now going to be replaced by another metrics of glycemic control, which is called time in range. And these green bars are showing that in most of your patients of type 2 diabetes, if 70% in 24 hours, you are in time in range, you are doing extremely good. And it is not only time in range, time above range. You should not be going more than 20% of the time, and particularly time below range. It actually tells you the risk of hypoglycemia. So now we have international consensus about the CGM data. How should you look at time in range, time above range, and time below range? And that will give you much better. And I assure you that now technology is coming, which will make you 100% time in range, and that time is going to come very soon. We will come to that time in future. This is the Abbott's flash glucose monitoring, and we have a whole length of other glucose monitoring system, and these are not in the research pipeline. All of them are available today in the market for users' application, and this is so very good. These are the commercially available CGM systems across the world. Non-invasive glucose monitoring. You can use tears, you can use sweat, Think of it. What a great revolution this is going to happen, that you will have such easy monitoring systems for your blood glucose control in future. Diabetic tattoos. There are strips which are pushed like tattoo, and those strips have electrical current, very slow electrical current, and that will give you the measurement of the blood sugar for months and years together. That's the beauty of technology that we are talking about. So the possibilities of digital technologies are absolutely enormous. I talked about so many things, but I'll give you a brief peep into how technology has completely revolutionized the even discovery of the drugs. Now think of insulin. We first had the regular insulin, which had to be given 3 or 4 times a day. Then we got the intermediate acting insulin that you can give once or twice a day. Then we got the basal insulin, which is available for 16 to 18 hours a day. And then long-acting basal insulins, which are having a half-life of 25 hours, so basically available for 40 hours. Now, we have developed this new insulin, Icodec, which is a weekly insulin. Can you think of it? And what marvel technological alteration we have done? Very simple. If you look at the insulin structure, the A chain and the B chain, only at 3 positions, we have done some amino acid substitution. And at position 29, we have applied a spacer and combined it with a very heavy diacid carbon chain. Now, what it does, it prolongs the half-life, it prolongs the binding with the albumin, and so much so that the half-life of this insulin Icodec is 196 hours, almost 1 week. So you can give weekly injection of basal insulin. And I'm going to this meeting in Denmark on this 24th. We have the final meeting. Our data is now weighted with FDA. And I think within 3 to 6 months' time, this is going to be approved and going to be commercially available across the world. Now coming to change in the HbA1c over time. And what you can see here, that this weekly insulin gives you better HbA1c control than the daily insulin of basal insulin glargine. And we are now working further on this smart insulin. You know what is GLUT4, glucose transporter? Everything that you eat, it converted into glucose, and then it is transported by the glucose transporters. So what you can do, you can develop glucose transporter inhibitors and combine your insulin with the glucose transport inhibitors. So what will they do? When your blood sugar is normal, they will do nothing. When your blood sugar goes high, it will block that glucose transporter and it will be acting like an inhibitor. If you try to go into hypoglycemia, it will stop the system and you will not go into this hypoglycemia. So 24 hours, your blood sugar will be controlled and you will not have a single episode of hypoglycemia in spite of receiving what? Insulin, which has the highest potential to cause hypoglycemia. That's the innovation that we are talking about, and that is the digital technology. And I'll finish off with this GLP-1 receptor agonist. You know, for the first time, a large protein had been converted, and all of you know that now oral semaglutide is available. But have you ever think what was the technological advancement which was done? If you take any large protein, what will happen? It will enter into your stomach. We have a very hostile pH because a very acidic pH, and we have the digestive enzymes. So the low pH and the enzymes will completely destroy this whatever protein that you take. And then, even if it is not destroyed, its transport across the gastric epithelium is almost impossible. And therefore, any peptide which you administer orally has an extremely low bioavailability. So what technological advancement we did? We first made the similar alteration in the GLP-1 molecule, only again at the 3 places. At position 8, we made it DPP-4 stable. At position 26, we again applied a very heavy carbon fatty diacid chain so that the half-life was prolonged. And at position 34, it looked almost like 26. So that false binding doesn't place, we changed that one also. So now, like Icodec insulin, you had half-life of 196 hours. So 1 week half-life. So you have the most potent GLP-1 receptor agonist tested till date in the world. And this half-life is close to 1 week. But even then, the problem is that if you take it orally, it will be destroyed, and the transport across the gastric duodenal epithelium will not take place. So now what we did, we identified an absorption enhancer, which is called SNAC. And this SNAC helps to break that barrier across the gastroduodenal epithelium and will allow the semaglutide to go across the gastric epithelium and obviously increase the bioavailability and availability so that a therapeutic dose is available. And by this smart technology, what we could achieve was the oral semaglutide, which is the first peptide in a pill to treat diabetes. And you know, it not only gives you more than 1.5% reduction in the HbA1c, but close to 5 kilograms or 5% of the body weight loss, and a huge potential to give you cardio-renal benefit for your patients of type 2 diabetes. Look at this smart thing. I just want to show you what this smart technology has done. When you combine oral semaglutide with SNAC, and then you take it orally, in the entire stomach, that pill goes into that small pit area. You can see that a small blue dot. Only in that area, the pH is different from the rest of the pH. So the rest of the pH is acidic, and that a small area where that pill is located, it has got a different pH. So it is not destroyed by the acid, it is not destroyed by the enzymes. And it is then facilitated by the SNAC for a very nice transport across the gastroduodenal epithelium, and suddenly from 0.001% bioavailability, you have almost 96% or 100% bioavailability. That's the power of technological innovation. Ladies and gentlemen, let me summarize that technological advancements have completely revolutionized the diabetic therapy. And obviously, these technologies are going to be individualized. For this patient, this technology is good. For that patient, that technology is good. And all these developments one day will ensure that not only your HbA1c is in target, but the new metrics time in range that we are talking about will be 100% time in range for patients of diabetes. And therefore, they will help the patients, the healthcare givers, the policymakers, all of them to completely alter the course of management of diabetes. But even though this says summary slide, I will show you two more slides. First is, how should we respond to these scientific innovations? Healthcare providers should embrace this change and become more professional. Otherwise, we would be dinosaurs of our age. This is extremely important. All of ये सब दिल्ली, बंबई, कलकत्ता के, ये तो लंदन, अमेरिका के लिए. No, each one of you should now start adopting digital technology in your clinical practice. You should make your mind aware that these things are not something in the realm of dreams. These are there in front of you. You have to use them. But at the same time, whatever advances takes place in the technology will aid and improve the triage of diagnosis, will reduce the cost and increase the access, reduce the medical errors and administrative burden, but it cannot be completely free from the data issues that I was talking about, data confidentiality and privacy issues, and it can never substitute the on-ground experience of the physicians. This is extremely important, and it will never be able to empathize with the patient, which is the crux of management of diabetes. This is so very important. Thank you very much for your attention.
Hello. Thank you, Ajay, for giving such a beautiful, extensive deliberation on the newer technology of the diabetes. You have already given the value of the data. Or what is the value of the data? It is you have given the value of the revolution of the insulin. You have given the value of the continuous glucose monitoring, and you have given the value of the mobile app. I think you have given a masterly oration on this topic, and thank you very much.
With this, we conclude this session. Now the presentation.
May I request Organizing Secretary Dr. Sadiq to present mementos to our chairpersons? First to Dr. Professor A.N. Rai, sir. and to Dr. S.P. Singh, sir. And to Dr. Dibendu. May I request Dr. Umesh Khan to please present the memento to our honorable speaker, Dr. Ajay Kumar. So the first half of scientific session comes to an end, and now we have the inaugural program. We will take 5 minutes break just to arrange the dais. So please bear with us. You can have tea or anything, but please make sure to come inside the hall within 5 minutes. We'll have the inaugural program. Thank you. उसको सुनो वो दीप 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 वहां पहले रखो पहले उसको वहां रखो वहां रखो ना टेबल पर रखो दीप नीचे रखो हैं? आठ चेयर लगेगी 10 चेयर है 10 चेयर बहुत बड़ा 10 चाहिए 10 टेम्पलेट लग पाएगा लगा दो बना टेबल सटानी है रवि टेबल इधर तो पूरा एकदम किनारे पे कर दो वो टेबल भी ले अब लगा दो वो नेम टैग था ना नेम टैग लगा दो ये इस ऑर्डर में जाएगा सबसे पहले डॉक्टर सादिक लगा डॉक्टर सादिक हम बोलते जा रहे हैं डॉक्टर सादिक सबसे पहले वो हटा लो ये भी हटा लो किनारे किनारे डॉक्टर एस डॉक्टर आपके मूर्ति आपकी मूर्ति एम राय डॉक्टर उमेश खान डॉक्टर मृत्युंजय कुमार मृत्युंजय कुमार मृत्युंजय कुमार मृत्युंजय कुमार के बाद सबसे क्या हो जाएगा आप इसके पाठक
पहले ऐसा करिए ना कि सबसे पहले तो एक पाठक को बोलना है एक पाठक को इधर रख दीजिए
कट रहे
हाँ
ठीक है अभिषेक कुमार डॉक्टर अजय कुमार का इधर दोगे कि उधर दोगे शादी किधर आ गया अजय उधर अजय उधर कर, सादिक को उधर करो, अजय को उधर करो। ठीक है, ऑल सेट, पानी गिलास से कर। कौन कौन 4 आदमी कौन?
AK Pathak and Mrityunjay. हम लिख के दे देते हैं। AK Pathak, Devendu Bhushan, Hemsindar Sharma, Devendu Bhushan, Achyut Sharma, Shankar Sharma और मृत्युंजय अभिषेक। ये लोग क्या करेंगे? देवेंद्र भूषण, हेमशंकर शर्मा, मृत्युंजय अभिषेक। वो they will they are the judges evaluation. They will evaluate. They are the judges.
पंखा चला दो यार, ये पंखे बंद क्यों कर रखे हैं? अच्छा, ठीक है, हो गया? ऑल सेट, प्लीज प्लीज। ओ हाँ, तुमको अजय को करना होगा। अजय ही इनिशिएट करेगा ना, सबको बुला लो पहले, फिर हमको दे देना माइक। सबको हॉल के अंदर बुला लो।
We are ready for the inaugural function. I request all the delegates and guests to kindly come inside the hall so that we can start the proceedings. जितेंद्र, बाहर जो लोग हैं ना, कोई 2 आदमी बोल दीजिए सभी लोग को आने। रवि, बाहर लोगों को बोल दीजिए कि please be seated. On behalf of CCDSI Purnia, I welcome all the dignitaries and delegates who have taken so much trouble to grace this occasion of midterm conference of CCDSI, Bihar and Jharkhand. We are especially thankful to our founder president, Dr. A.N. Raya sir, for his effortless guidance and continuous support. We are honored to have a galaxy of stalwarts and experts amongst us all across the state. And we are sure that we will get benefited and by their deliberations and their knowledge sharing, it will improvise our skill and expertise. We have tried our level best to make this academic feast smooth going, but we will extend a humble apology for any shortcoming. With these words, I request Dr. Vinod Dharewa to conduct the inaugural function.
Good afternoon, respected colleagues and friends. First of all, let's start the inaugural session, and I invite our organizing chairman, Dr. S.P. Singh, to please be on the dais. Chairman reception, Dr. A.K. Pathak, please be on the dais. Chairman scientific session, Dr. Modi, please. Both the organizing secretaries, Dr. Ajay and Dr. Sadiq. May I call upon our State Secretary, Dr. Abhishek, to please be on the dais. Our National Secretary, CCDSI, Dr. Mrityunjay Kumar, please be on the dais. May I request Dr. Arvind to escort our National President, National Chairman, CCDSI, Dr. Umesh Khan, sir, to be on the dais. May I request our patron and our senior most member, Dr. Devi Ramji, to be on the dais. Dr. C.K. Singh and Dr. BP Saha kindly escort our chief guest, the founder chairman of the CCDCI, Dr. Professor A.N. Rai, sir, to the dais. Saraswati Vandana. Saraswati Vandana. So we'll have Saraswati Vandana now. Please go ahead.
या ब्रह्माच्युत शंकर प्रभृति देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा ब्रह्म विचार सार परमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you. And as it is customary in our Hindu tradition, we start any program by lighting the lamp. May I call all the dignitaries on the dais, off the dais, to please join for the lighting the lamp. Thank you, everybody. Please take your seats. CCDSI Purnia branch would like to honor the dignitaries, those who have come from outside and those who are the big luminaries in the field of medical science. So first of all, I would request our patron, Dr. Deviram sir, to please honor our chief guest of the program, Professor Ray and Rai, sir, by presenting him a shawl and a bouquet. Sir, please honor our National Press Chairman, Dr. Umesh Khan, sir. Dr. D. Ram, sir, to do the honors. May I request Dr. A.K. Pathak, Chairman Reception, to honor our National Secretary, CCDSI, Dr. Mrityunjay. Also, please honor our State Secretary, Dr. Abhishek. Has our civil surgeons here? No. I think not. Do we have our IMA President Purnia here? May I request our Organizing Secretary, Dr. Ajay, to please honor our IMA President, Dr. A.K. Sinha. Next, we would like to honor our Regional Deputy Director, Dr. Vijay. Also, please on Dr. Ajay, please honor our Regional Deputy Director, Dr. Vijay. Is Principal Purnia Medical College present here? No. Okay. Head of the Department of Medicine of Purnia Medical College? No, it's also, sir. We would like to I will request our Organizing Secretary, Dr. Sadiq, to please honor our governing body council members of API, Dr. D.P. Singh, sir. Also, please honor our respected Sir Dr. Hem Shankar Sharma ji. May I request Dr. R.K. Modi, Chairman, Scientific Committee, to honor Dr. Amit Das, who is also a governing council member. Sadiq Sahib, you can come. Dr. Amit, please honor Dr. Amit Das. Dr. Amit Das. Okay, no issue. We would like to honor Dr. P.K. Sinha. Ravi, please do the honors. Dr. P.K. Singh, sorry. P.K. Sinha. And also honor Dr. B.K. Singh. Ravi, do the honors for Dr. B.K. Singh also. And may I request our organizing chairman, Dr. S.B. Singh, to please do the honors for the most respected and loved and important speaker, Dr. Ajay ji. Please honor Dr. Ajay Kumar. हो गया? उनका चला गया. Now I request our Chairman Reception Committee, Dr. A.K. Pathak, for the welcome address.
आवाज Good afternoon, everyone. With great pleasure, we would like to welcome all our honorable guests and hosts, either on the dash or off the dash. We are especially grateful to our National Secretary, Dr. Mrityunjay, and State President, Dr. Umesh Khan, and State Secretary Abhishek of CCDI, who had given us the opportunity of organizing this midterm CCDSI at Purnia. Purnia being a small town with no airport or limited railway connectivity, you all still took the trouble to travel from so far, which I, on behalf of all the doctors of Purnia, salute them and pay the regards from core of our hearts. We would like to extend a special thanks and cordial welcome to the founder, president of CCDSA. He is no more Dr. A.N. Rai. He was head of Department of Medicines at Gaya Medical College. After retirement, with his unprecedented visionary approach, started CCDSA in Bihar and Jharkhand, and now proudly spreading across many states of India. With the contribution of our many young and old colleagues, we hope CCDSI will take this learning platform to a new horizon. We are also grateful to our National Secretary, Dr. Mrityunjay, State President and Secretary, Dr. Abhishek, for their relentless efforts in advancing mission of CCDSI. It gives me immense pleasure to welcome Dr. Ajay, who is no more than a dynamic personality in the diabetic fields, and Dr. D.P. Singh, Dr. Hemshankar Sharma, and so many more, who took time from their busy schedules to grace us in this occasion. Thank you.
May I request our organizing chairman, Dr. S.P. Singh, sir, for blessings.
Good afternoon, everybody. On behalf of the CCDSI Purnia, I want to welcome all the delegates first, the CCDSI officers, our faculty members, and everybody present over the dais and off the dais. First of all, I would like to welcome our founder president, Dr. A.N. Rai, for the trouble he has taken of traveling from Gaya to Purnia, and he has given so many directives during the preparation of this conference, and we took all those instructions like blessing. Then the other, we would like to welcome all the officers of the CCDSI, Dr. Mrityunjay Kumar, Dr. Manish Kumar, and Abhishek Kumar, Secretary CCDSI, for coming and taking and blessing this occasion. Then I would like to thank and welcome all the faculties member who have traveled, who have taken a long trouble. Those persons are From Patna, Dr. Ajay Kumar, Dr. Anand Shankar from Bhagalpur, Professor D.P. Singh, Professor Hem Shankar Sharma, and Bharat Bhushan from Muzaffarpur, Dr. Amit, from Gaya, Dr. P.K. Sinha, and Dr. Lohani, from Aurangabad, Dr. B.K. Singh, and all other persons who have taken trouble of coming and bless this occasion. I want to thank all the volunteers, and because due to their effort, our dream came into reality. And lastly, I thank the media people who have taken a very wide and very nice coverage of this function. Thank you all for the coming.
Now I request the man who is behind this program, who made such big efforts since last, he was making all the efforts since last month and a half, I think, and to put this grand show, our chairman, scientific committee, Dr. Modi.
Thank you, Dr. Dhareva. Respected Chief Guest, Dr. A.N. Rai sir, National Secretary, Dr. Mrityunjay, State President, Dr. Umesh Khan sir, State Secretary, Dr. Abhishek, IME President, and our esteemed guest, Dr. A.K. Sinha, our guardian and elder brother, Dr. Devi Ramji sir, and Dr. S.P. Singh sir, my teachers sitting in front of me, Dr. D.P. Singh, Dr. Hem Shankar Sharma, Dr. Ajay Kumar, my seniors, Dr. B.K. Singh, and all respected faculties and all delegates coming from different part of Purnia, outside from Purnia. It's my great pleasure to welcome you all in this conference. Local organizing team gave me this opportunity and responsibility to conduct this scientific program, and I have tried my best to present this in front of you with great help given by Dr. Abhishek, our State Secretary. But the greatest help and support is actually provided by respected speakers, chairpersons, and of course, all delegates who are here to make this CME a great success. I especially welcome the delegates who has come from different places like Saharsa, Katihar, Madhepura, Bhagalpur, Forvesganj, Begusarai, Kishanganj, Jogmani, and from other places. Of course, Katihar. I am also thankful to the entire CCDI SI team of Purnia and API team of Purnia for giving me all strength, support, and encouragement. In fact, organizing an event like this gives you a pain, P-A-I-N, pain. But also, this pain is different. It is a different pain because it gives you pleasure also. So it is a pleasurable pain. I am really overwhelmed, sir, because all of you are here. Really, I am overwhelmed. Thank you very much. Long live CCDSI, sir.
And now the man without whom no activity is possible in India, the great legendary Dr. D. Ram.
Thank you very much, Dr. Binod Dhareva. I'm sure that you will all agree that we in Purnia are just privileged to have such a smart, handsome, fantastic orator as Master of Ceremony, that is Dr. Binod Dhareva. It's not only today, but over the years, or I would say decades, he has been doing it not only in medical association, but in various others like Lions Club. Dignitaries on the dais, off the dais. A very good afternoon to all of you. I'm extremely delighted and thrilled to welcome all of you. I wish to congratulate Dr. A.N. Rai, founder president of CCDSI, under whose capable leadership and charismatic personality, CCDI has grown by leaps and bounds with the support of its members in just last few years. For the success of any conference, though proper arrangement, food, etc. is important, but its real success depends on the presence of faculty and delegates. Presence of Dr. Khan, Umesh Khan, State President, Dr. Mrityunjay, National Secretary, Dr. Abhishek, State Secretary, Dr. Ajay Kumar, MRCP, renowned national and international orator, Professor Duo from Bhagalpur, Dr. D.P. Singh and Hem Shankar Sharma. You will see them everywhere. सिर्फ निर्मा और सर्फ के प्रचार में नहीं आते हैं, otherwise you will see them everywhere. Doctors from Kishanganj, Kathiawar, Dr. S.C. Jha from Darbhanga, Dr. I.D. Singh from Saharsa, Dr. K.K. Lohani, Dr. P.K. Sinha, Dr. B.K. Singh, A.K. Das. If I have left any name, please excuse me. Your presence has made this conference successful. I am pleased to inform this august house that almost all the eligible physicians of Purnia are now life members of CCDSI and API. Further, I wish to mention that senior physicians of Purnia, including myself, have been rather worried and concerned about the future of Physicians Association and its leadership in Purnia. But we are totally relieved and delighted to inform you that our traditionally vibrant association has become more vibrant due to active involvement of many younger physicians. I will not give one name, there are many. Under the leadership of Dr. S.P. Singh, Dr. Ajay Kumar, Vinod Dharewa, A.K. Pathak, R.K. Modi, Dr. Sadiq, Arvind Kumar, C.K. Singh, etc. So that's a great relief for us. You have seen that they have done it itself, arrangement of this conference. You will be pleased to know that team of physicians under the leadership of Dr. R.K. Modi, scientific chairman, has been working enthusiastically and tirelessly in the preparation of conference for last many weeks, blessed by seniors and supported by many young pharma boys. Now you see the result in front of your eyes. So I will request you to give him a standing ovation for organizing this thing, which he totally deserves. Thank you very much indeed. Last but not the least, I would like to thank the electronic and press media, all the faculty, PG students, delegates, my juniors and seniors who have participated in this conference, and please excuse us for any shortcomings. Long live CCDSI.
Thank you, sir. And now I call upon Secretary DSI, Dr. Mrityunjay, for the overview of the CCDSI.
मंचासीन आदरणीय महानुभाव, इस सभा स्थल में आए हुए विशिष्ट अतिथिगण एवं IMA पूर्णिया, API पूर्णिया, CCDSI पूर्णिया के सदस्यगण, PG स्टूडेंट्स एवं अन्य व्यक्ति जो भी यहाँ पर स्थित है, उनको मेरा प्रणाम। मैं सबसे पहले तो CCDSI पूर्णिया को अपना धन्यवाद ज्ञापन करता हूँ। उन्होंने एक एक अच्छा एक एकेडमिक माहौल को बनाया यहाँ पे और इस मिड टर्म CCDSI को बहुत ही अच्छे ढंग से किया। मुझे ये आप लोगों को बताते हुए बहुत खुशी हो रही है कि नाउ वी आर अ रजिस्टर्ड बॉडी. CCDSI is a registered body. Only last month we have got the registration under the Society Act. Second, we are now pan India presence. We have made 3 new chapters in this year only, one in Haryana, one in UP, and one in Rajasthan. So these 3 bodies are now working under CCDSI. We have pan India presence with more than 500 members now. So और इस सब का श्रेय जाता है हमारे फाउंडर प्रेसिडेंट डॉक्टर एन राय सर को, उनके विजनरी जो उनका विजन है उसको जाता है। और मैं यही कहना चाहूंगा कि आप सब भी CCDSI से जुड़े। बाहर फॉर्म रखा हुआ है, उस पे अभी हम लोगों ने जो किया है लाइफ मेंबरशिप को घटाया है, तो 5,000 रुपया देके लाइफ मेंबरशिप मिल सकता है जो भी एलिजिबल कैंडिडेट होंगे। और अंत में मैं यही कहना चाहूंगा कि अकेला ही चला था जानिबे मंजिल, लोग आते गए और कारवां बनता गया। धन्यवाद।
Now I request the most lively man and chairman of the CCDSI, Dr. Umesh Khan sir, to address us.
Thank you, Dr. Binod. Dear honorable colleagues, respected guests, all delegates, and all gentlemen, friends from media and press. On behalf of whole CCDSI, Bihar and Jharkhand Program Committee, I would like to kindly welcome you all to the CCDSI 23 half-yearly conference at this beautiful historic city of Purnia, Bihar. It is an honor to be here with you today. Purpose of this conference is providing an ideal academic platform for all the specialists to disseminate their skill and awareness in their respected field of medical specialties. Before we start the conference, I would like to express my sincere gratitude to all esteemed personalities who have attended this program and kind enough to be part of it. Scientific Chairman Dr. R.K. Modi has very methodically planned out the scientific program, which I am sure are highly relevant and all of us shall benefit immensely. A very special welcome to colleagues of their extraordinary effort as a member of the executive committee of this half-yearly conference, along with our founder president, Dr. A.N. Rai sir, chief patron, Dr. Devi Ram, organizing chairman, Dr. S.P. Singh, organizing reception, chairman reception committee, Dr. A.K. Pathak, secretary CCDSI Central, Dr. Mrityunjay Kumar Singh, Dr. Sadiq, Dr. Abhishek, secretary CCDSI Bihar and Jharkhand, Dr. Ajay Kumar, organizing secretary, and all the dignitaries who are there. My colleague, Dr. Ajay, Dr. Sudhir S.C. Jha, Dr. Pramod Kumar Sinha, Dr. P.K. Singh, Dr. Hemlal, Dr. B.K. Singh, Dr. K.K. Lohani, Dr. Ajay Kumar, Dr. P.K. Singh, and all other colleagues who are here. Thank you again for coming here. Lastly, I shall give you two important information that we are going to have annual conference at Jamshedpur in the month of April next year. And I will request all of you and inviting all of you to please join there. I will let you know, all of you, including Dr. R.K. Modi, and I think he will give the detailed information to you for joining the conference. And one other information is, yesterday, because I came earlier, so I've got one get-together program in Dr. A.K. Sinha's residence, and Dr. Binod was kind enough to give us a very good CME program, and I think everybody will take opportunity to learn from him the new CME program.
Thank you.
Thank you, sir. And now I request our chief guest of this program, Dr. Professor A.N. Rai, sir, to bless us.
Dignitaries on the dais, off the dais, delegates, print and media. At the outset, I would like to congratulate the Pune, CCDI branch of Pune for arranging such an excellent conference, a memorable scientific program and hospitality we had to. And in particular, I would like to thank the core team of the members, the patron, headed by patron, Dr. D. Ram. We all know his support and blessing is everywhere. And organizing chairman, Dr. S.P. Singh, reception committee chairman, Dr. A.K. Pathak, chairman scientific committee. I think he has worked. I think one person who deserves credit is Dr. Modi. He is our chairman-elect. He is going to take charge of the chairman of the Bihar and Jharkhand. We are going to have our national state conference at Jamshedpur in April, where he will take over charge. So after that, we will have opportunity to come here once again, or it is up to him where he organizes where we will go. I think everyone has said about everything, but I would like to say a few things about CCDSI. CCDSI was formed on World Diabetes Day in 2016. Since its inception, the first state branch was Bihar and Jharkhand. Then we have got now 8 established state chapters, followed by Tamil Nadu, Odisha, West Bengal, Gujarat, and then already Dr. Madhuri said UP, Haryana, and Rajasthan, and 3 are in the pipeline. Very soon you are going to have, that is Chhattisgarh, Mumbai, or Maharashtra, and Karnataka. So with this, I think the number Dr. Madhuri said, we have got more than 500 members. I think with the support of this, and actually with the gradually diminishing communicable diseases, it is the non-communicable diseases, lifestyle diseases are taking part. And the aim of this society is to make aware the society and our doctors in periphery about this lifestyle disease, important life disease. We had an opportunity to meet our President of India last year, where we explained her about the why this association was formed, and she was really very happy. Because what happened? Once the person has developed the disease, you can control it, or you can prevent the complication, but still the patient financial every burden is there. But there is one thing, we can at least prevent or delay that this occurrence of disease by regular screening camp, regular promoting about the lifestyle or जीवन शैली के बारे में बताने के लिए. So if you do this, we are going to do great service to the society, because the burden of disease will be so much that it is difficult to treat. I think we just heard pre-diabetes 15%. How many population we are going to have? So actually it is a prevention, and the prevention, as I told you earlier, these lifestyle diseases are only 2 predisposing factors. One is genetic factor and second is lifestyle. We cannot do to the genetic factor, but we can change our lifestyle, healthy lifestyle, and avoid bad habit like smoking, drinking, sedentary life, and controlling the risk factor like diabetes, hypertension, dyslipidemia. I think with this, we can serve our society. Long live CCDSI. Thank you, everybody.
Now we are heading for the end of the program, but before I ask our organizing secretary to propose vote of thanks, may I request Dr. A.K. Pathak Dr. Devendra Bhushan, Dr. Hemshankar Sarma, Dr. Mrityunjay, and Dr. Abhishek to take a look at the poster presentation and evaluate the presentation and announce the winners. After lunch, yes. Soon after the inauguration, we will have a lunch, and that will be a break of half an hour. And again, we have 2 scientific sessions. And now, at the end, I request our organizing secretary, Dr. Sadiq, to propose vote of thanks.
Founder Chairman, CCDSI, Dr. A.N. Rai, sir, National Chairman, Dr. Umesh Khan, Secretary Mrityunjay, State Secretary Dr. Abhishek ji, our Chief Patron Dr. D. Ram sir, Organizing Chairman Dr. S.P. Singh, Chairman Reception Dr. A.K. Pathak, dignitaries on the dais and off the dais, esteemed colleagues and friends. First of all, my sincere gratitude and thanks to national and state team to give us the opportunity to host this midterm conference. Thanks to Dr. A.N. Rai, Dr. Umesh Khan, Dr. Mrityunjay, and Dr. Abhishek, who traveled a long distance to bless the occasion. Dr. R.K. Modi made all efforts to give us a voracious scientific feast, thanks to tons of him. Organizing body headed by Dr. S.P. Singh, Dr. Pathak, Dr. Ajay, deserves all compliments for such a grand show at Pune. Thanks a lot. Dr. Umesh, Dr. Arvind, Dr. Nishikant, Dr. Imtiaz, Dr. Manoj, Dr. Krishna Mohan, Dr. Sujit, and others, all my friends, I salute you for your selfless effort to make the event successful. Thanks. Team of our volunteers had been the backbone of event. Pune CCSI team, thanks a lot for your sincere effort. Thanks to all eminent doctors who spoke on various topics, doctors who chaired persons, various sessions and enriched our knowledge, which is the motto of such conference. Thanks, sir. Media has been with us since last 1 week. They supported our event through their encourageous column. My sincere thanks to all media persons for giving us so much space. Nothing could have been successful without this August gathering, who patiently attended the program. Thanks a lot to all. Being organizing secretary, I had enormous support from all of you. I wish CCDSI keeping growing and keep delivering the best at academic level. Though we tried our best to make this conference successful, still some lacuna maybe have been there. I sincerely apologize for any shortfall and hope you will ignore and forgive us. And now, lunchtime. Lunch is ready. I invite all of you for the lunch.
Just wait. We'll have national anthem. Just wait. And the next session, make it sure that we start by 2:45. So be there at 2:45. And now the national anthem. Jana Gana Mana Dinayak Jai Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkal Banga Vindhya Himachal Yamuna Ganga Uchchal Jaladi Taranga Tava Shubh Thank you. So please gather again at 2:45.
Cheers, cheers, madam. Anand, cheers. हाँ, हटा दे। सर ये सब तो अब हटा देंगे। ये सब हट जाएगा ना? हाँ, उज्जवल। Sadab.
ये पीछे में कोई डाल लेगा भैया फिर बाद में पीछे में ये नहीं दे रहे कैरी बैग है सबका कैरी बैग है वेद विशाल
रवि रवि
चले गए सर चेयर यहाँ रहे 4 चेयर वहीं पे रहेगा चेयर पर्सन के जैसा भैया 4 वो चेयर उधर पीछे कर
ಪಡೆದ ಹೊಡೆದಿಲ್ಲ ಬಡೆ ಅನ್ನದ ಹೊಡೆದ್ರು আর কিছু আসছে না 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 ওটা ইয়ে করো ব্রাইটনেসটা বাড়াও
जो बोलेंगे वो यहाँ आता है, वहाँ जो दिख रहा है लोग को वो आपको दिख रहा है, वो भी ऑप्शन है, बढ़ाने के लिए कौन वाला है इसमें, आगे पीछे किसको
पॉइंटर जो है इसमें
ये है,
हाँ ये आगे बात फॉरवर्ड करने के लिए
बस ठीक यही दोनों होगा, आगे पीछे का काम है।
Hello. Hello, 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 hello. All delegates are requested to gather at scientific hall. All delegates, please gather at scientific hall. Delegates, please gather at scientific hall who has finished their lunch. आवाज नहीं आ रही है
Please be seated. Now we start our second half session. Topic is diabetic renal metabolic access. For the first session, for the chairpersons, I invite Dr. SNQ Nasser. बाहर होंगे जरा सा उनको बुला लीजिए. Sir, please take your seat. Dr. Rajiv Sinha. Dr. Rajiv Sinha. Dr. Arvind Kumar. And Dr. C.K. Singh. And I request our esteemed speaker, Dr. Shanil Hars, DM Gastroenterology, to present the topic metabolic liver disease and diabetes.
Hello, thank you.
Dr. Shanil, please be.
I take privilege to invite the young gastroenterologist, Dr. Sunil, to give the deliberation on liver metabolic disease in diabetes. Now, the liver metabolic diabetes is the new old name, and now is the metabolic disease is diabetes is a old new name. On the old name is the non-alcoholic fatty liver disease. Now I invite to the
Screen पे कैसा है? Screen share कर. Good afternoon, everyone. First of all, I would like to thank the CCDSI for giving me the opportunity to speak on metabolic associated fatty liver disease. So this is a very disease which is coming up very fastly, and till 2047 it is said that it will be having the highest burden on the society. So what does liver do? We all know, but still I would like to have a recap. Liver tolerates everything, and it is the largest lymphatic organ which is having lot of NK cells. It synthesizes, stores amino acids, proteins, vitamins, and fats. It detoxifies, it gives us clotting factors, it gives us bile. And what we are going to discuss is it even does blood glucose regulation. So how does liver regulates blood glucose? So this is a slide which shows that there are many countries over here, and we can see the graph over here, the red line, which shows that there is a proper correlation between the obesity and the diabetes. And it was always like understood that diabetes is somewhat like a subset of obesity. But over here, when it was published, we can see that there are many countries like Mongolia, Indonesia. These are the countries which is having obesity, but the prevalence of diabetes is very low. Whereas in the South Asian countries like Pakistan, Afghanistan, India, Sri Lanka, and even China, the obesity is very less, but the prevalence of diabetes is more. So 11% of the diabetic population is from India and China, where obesity is not so epidemic. So is obesity the problem, or there is something else which is causing it? So when the data was analyzed for the US population for the last 20-30 years, it was seen that obesity was increasing worldwide by 2.78%, whereas diabetes was increasing by 4%. So it was definitely, this data showed that diabetes is like obesity and diabetes are just not the subset. It even has some other pathophysiology. And same trend was seen when we did the graphing over here. It was seen that in the US population, 25% of the obese people did develop diabetes in the 30 years, and same, the diabetes developed in the normal weight percentage was, both of them had 25%. So how was it happening? And this is the wave diagram of the metabolic dysfunction
which showed that 30% of the US population were obese and were metabolically sick, whereas the 70% which seemed that they were metabolically healthy were also sick. So in total was, though the persons were having normal weight or normal BMI, they were having metabolic dysfunction. So to conclude how it was happening, so they did MRI fat function map. And here we can see, this is the first slide. Here we see a lot of fat on the love handles, but the liver is quite dark. So this is the MRI of the patient, which is obese. The person is obese, but metabolically he is healthy. Here we can see a lot of fat over here and a lot of fat over here. So this person is what normally we think. It is the fatty liver as well as obesity. But the last one, there is very less subcutaneous fat. But still we can see a lot of fat in the liver. So these are the patients who are like when we weigh them on the weighing machine, they have normal weight, but they are not metabolically very well. They are not doing metabolically very well. They are metabolically sick. So to prove this, Dr. Khan had a lab in Boston, and he did, this is like a tissue model. And what he did, like he knocked out all the insulin receptors from the tissue. And the most prevalent finding in this was when the glomerular podocytes were knocked out with the insulin receptors were knocked out, though they were exposed to the normal sugar and the sugar level was normal, these animal models had diabetic nephropathy. So it was something which was not relating everything to the glucose, but it was the insulin, how it is being metabolized. So this is the slide which shows how the normal liver metabolizes. So we take dietary glucose, the pancreas is getting the secretion, and then insulin is secreted. From here we have two pathways. One is FOXO1 phosphorylation, from where the enzymatic action takes place and glucose is lowered down. And another one is there is excitation of SREBP1C. When this is excited, then the EG level goes up, and then this goes out, gets stored into the fat, goes to the muscle, and this is the cycle how the normal liver metabolizes. So a person who is even obese but having normal function will not be having diabetes, whereas he can be obese. So again, this is a mouse model where what was done, like both the receptors were blocked. When both the receptors were blocked and the insulin was came over there, then the liver was not able to lower down the glucose. The glucose was very high, so that is diabetes. But the triglyceride was not high because it was low, because this action is also blocked. So this is a diabetic patient, but the triglyceride was normal over there. But what do we see? Over here, when in the diabetes, there is the phosphorylation of FOXO1 is blocked, but somehow there is partial insulin resistance. There is one insulin, it goes into the one molecule, but over there are two receptors. Resistance is there, but somehow FOXO1 is resisted, but SREBP1C is not. And this is how it happens. The glucose goes up and the triglyceride also goes up. So the person presents with obesity, hypertriglyceridemia, and this is what is happening. And this is how the liver is very, very important in controlling the sugar. The insulin level is normal, the glucose level is same, but if one receptor is blocked and somehow normally in a clinical practice, we must be seeing a lot of patients coming over us. They seem to be very, very normal weight. And when we see they are having a normal, high triglyceride. So this is where a lot of research going on. This is something like $1 billion, $1 zillion question. Until the time they solve it or we have more data, what we can be doing in a clinical practice, we'll go through that. So someone who is having metabolic related, like associated metabolic dysfunction and liver is affected, then these patients, what are the symptoms when they present in the OPD? So when they present, they are asymptomatic. They might be having fatigue. They might be having right upper quadrant pain. What are the signs? Like on clinical examinations, they can be having hepatomegaly and the patients can be having acanthosis nigricans. So these are the laboratory features. We can see they could be like the liver enzymes might be high. They could be having mildly elevated GGT and ALP. ANA could be positive in some around 1/3 of the patient, and abnormal iron indices can be there. So when we come to the imaging, so what are the modalities we can be having to detect this? So the ultrasound, CT scan, MR, and CAP. So CAP is something which is related to fibroscan. So this is the normal ultrasound of the liver. Here we can see we can differentiate by just seeing the diaphragm, the color of the liver, and it could be compared with the renal cortex. So which one is darker over here, and then whether the vessels of the liver are the echogenicity is clearly visible or not visible. As the fat content increases, it becomes shiny, it becomes lobulated, and then the vessels demarcation are not easily appreciated. So this is something which this is a image of a fatty liver. And then on CT scan also, what we can see is we can just compare with the spleen and the liver. Once there is lot of fat, then the Hounsfield will be low. And then MRI spectroscopy can be there, which quantifies the fat amount in the liver. And then comes the MRI might be like expensive, and then this comes like fibroscan. Fibroscan is a very like easy, and nowadays with the help of some of the pharma companies, there are a lot of fibroscan camps which are being run, and that is almost free of cost for the patient. So this can be easily done in the OPD basis. It hardly takes 4 to 5 minutes of time. So this is the EcoSense machine. Normally what we are getting over here is present is 430 mini. It has two validation, like one is 2 parameters. One is the LSM and one is CAP. So this patient is having somewhat like 278 is the CAP. So a patient who is having something which is CAP which is above 250 can be thought about like is having someone around F1 of fibrosis. But as it goes up like more than 300, 350, it is F2, F3, and above 350, it could be like you can be thinking about of liver biopsy if you really want to quantify. And then comes the LSM. LSM is something which is very simple. The sound waves goes through the liver and it just comes back. And when it comes back, you have to, the time is calculated in how many milliseconds it comes back. And then it is through the algorithm. We talked about the technology. So the technological algorithm just gives the numerical value. So here if it comes between like 60 milliseconds, then the liver is normal. And if it is coming like lesser and lesser, so there is more fibrosis. Like for 40 milliseconds, 30 milliseconds, the more less it is, it will be, the fibrosis level will be more. Just before the lunch, we talked about the technology and about the weighing scale in the body. So this is somewhat like body composition analysis. This is a machine which is very like very simple. You can do it very easily. And we have seen like weighing machines. The concept of this machine is a kilo of muscle is not equivalent to a kilo of fat. So the normal weighing machine will be, you will be showing 78 kilo, but it could be like a higher proportion of fat could be there in the body of the patient rather than this. So this gives you the BMI, the percentage body fat, the waist hip ratio. The waist hip ratio should be less than 0.9 in males and 0.85 in females. If we don't have anything like any machines, then definitely, and we are even in the primary care, then the patients can be easily, we can have the scoring system on the OPD. We can do FIB4. It just takes age, ALT, platelet, and AST. And it can be easily found on the Google. We can just put the values and we can see if it is more than 1.3 or less than 1.3. So similarly, we do have a NAS scoring. And all this can be done, like we can just put the values and they don't need anything which is like very extra. Like they normally a patient is coming, we do the simple test and it can be done by that. So if we have diagnosed, then also what the primary treatment is, the aim of the treatment is to reverse NASH and how to to prevent the progression of cirrhosis and its sequelae. So the main standard of care remains the dietary, exercise, and the behavior changes. And it should be like three-prong attack, and the approach should be holistic. So what should we be doing? We just talked about the ADA recommendation all, but what we in the liver, what we talk about is we should be doing around 45 to 60 minutes of exercise. We should be doing, if we calculate per week, it should be somewhere around 200 minutes per week. And what should we be doing? We could be doing any aerobic exercise, but the maximal heart rate should be achieved. What is maximal heart rate? The maximal heart rate is 220 minus age. And 60 to 70% of the maximal heart rate should be achieved. And if a person is having fatty liver, the best reversal is there when you lose around 10% of the body weight. So this we talked about, the weight loss should be there, and 10%, there is, we can see a lot of, like, even the fibrosis can be seen reversing. So if everything, the patient has done everything and we are trying and the patient is not improving, or if we are not able to encourage him and we have to go for pharmacological intervention, then the study which was there was published in NEJM 2010, was previous study. Over here, pioglitazone, vitamin E and placebo was seen on the non-alcoholic steatohepatitis patients. And what was seen was pioglitazone as well as vitamin E. So pioglitazone was seen like that all the secondary outcomes were not met with the pioglitazone, but in the discussion part, it was always there that the pioglitazone group had more number of patients and had more of the patients which were having more ballooning of the hepatocytes in the liver histopathology. So pioglitazone and vitamin E is there, and these are the drugs which can be used. Then comes a newer drug which is being right now a lot of the pharma companies are talking about it, a lot of promotion over there. So this is saroglitazar. Saroglitazar is a glitazar which came up and now it is promoted. The other glitazars which came up before it has dual PPAR, the alpha and the gamma. The previous glitazars were having a lot of side effects on the gamma, and gamma is present on the skeletal muscles. So the patients had a lot of fatigue and they were not there was some morbid thing. They were saying that they are not able to do proper routine work. So this saroglitazar does have very less effect on the gamma and have more effect on the alpha. And so it was this was the study which was done, evidence 2. It is even the evidence 3 was done in India, multi-center trial under Dr. Sareen, and this showed that it had lot of significant improvement in ALT, as well as there was even seen some of the reversal in the fibrosis. But this is not effective in a patient who has already developed cirrhosis. So a patient who has not developed cirrhosis but having dyslipidemia or NASH can be given trial with saroglitazar, but saroglitazar is only DGCI approved. It is still US FDA approval is awaited and there are data being collected. So still evidence 3 data is. So this is what the INAZL recommendations talk about. It is the vitamin E, 800 international unit in 2 divided dose, and the suggested minimum duration is 2 years. Pioglitazone, but we should always be thinking about the osteoporosis and even the blood glucose. And then saroglitazar, which we already talked about. So the saroglitazar is a newer addition in our armament, but still it is up to you because it's only not US FDA approval, but DGCI approval is there. And though there is no recommendation of seraglutide over here, and we talked about the oral bioavailability just before the lunch, that is a wonderful drug. And what I can say is diabetes with dyslipidemia, then that is a very, very wonderful drug. The only side effect was that beforehand it was just the IV administration was there. But now as the oral formulation is also there, so it can be a game changer. But still more data is required. So thank you for your patient listening.
Hello. Thank you, Dr. Salim Hertz.
Pankaj,
I will ask the audience if they have any questions before finally closing.
Thank you, Dr. Sanil, for your extraordinary presentation. Now, I would like to say a few words regarding this. We have multiple drugs like vitamin E, metformin, pioglitazone, obeticholic acid, or sodium-oxycholic acid, and saroglitazone. But other part of treatment is reduce your weight. So, first and foremost treatment for this metabolic fatty liver disease or non-alcoholic fatty liver disease is to reduce your weight by the help of exercise.
please be here. May I request Dr. UB Singh to present mementos to the chairpersons? Dr. SNQ Nasser. Dr. Arvind. And Dr. CK Singh. May I request organizing chairman, Dr. SP Singh, to present memento to our speaker, Dr. Shanil, your son, sir. एक सेकंड आइए डॉक्टर सनील हर्ष Thank you, chairpersons. Please take your seats. And now for the next session, we have Dr. H.K. Singh as our chairperson. May I invite him? Dr. H.K. Singh is here. Dr. M.L. Maheshwari ji. Sir, please come forward to chair the session. Dr. Bharat Bhushan. Dr. Bharat Bhushan. Dr. O.P. Saha. And I request Dr. Mrityunjay Kumar Singh to present prevention of kidney diseases and diabetes. Dr. Mrityunjay, please.
Respected chairperson, sir, at the outset, I would like to thank the organizers for giving me this opportunity. So let us start the talk. So what is chronic kidney disease? It is defined as abnormalities of kidney structure or function presents for more than 3 months with implications for health. Now, what is diabetic kidney disease? It is a clinical diagnosis. It encompasses all form of kidney injury in diabetic patient attributed by diabetes. So let us see this trajectories of kidney function in diabetic kidney disease. Diabetic kidney disease is actually not an homogeneous entity. You can have in your patient all the 4 trajectories. So you have to keep in mind these all 4 trajectories. First one is this classic one. Classic one is from normoalbuminuria to microalbuminuria to overt proteinuria and then renal failure. This is what we see in mostly in type 1 diabetes. And this has been proposed by Mogensen, but this is not true for the type 2 diabetes mellitus. In type 2 diabetes mellitus, mostly we get this number 4 trajectories where there is non-proteinuric or non-albuminic DKD occurs. We will see what is this non-albuminic diabetic kidney disease, what this entity is. During the last decade, prevalence of non-albuminic diabetic kidney disease has increased significantly, around 20 to 40%. Some reports indicated that it might be associated with clinical characteristics such as obesity, aging, female sex, smoking, hypertension, and absence of diabetes retinopathy. Macrovascular rather than microvascular injury and tubulointerstitial damage may be the two different pathogenic mechanisms. Regarding prognosis, the risk of end-stage renal disease, cardiovascular disease, and all-cause death were reported to be consistently lower in patients with non-albuminic diabetic kidney disease than those with albuminic diabetic kidney disease. Diagnosis and managing non-albuminic kidney disease is quite challenging. So now you see, this is the this is the normal slide, which shows that how we define chronic kidney disease and how we prognosticate our patient. In the x-axis, we can see here the albuminuria, and the y-axis, you can see the glomerular filtration rate. And that is the way we define, we write our diagnosis. Means if a patient is of diabetic, then we write diabetes. If patient is in G3A, A2. This is the full diagnosis. This is the all what we do in our patient, and accordingly we treat our patient. Accordingly, we give prognosis to our patient. But is this the right way? Because albuminuria in diabetes, we all have seen that we can get non-albuminic diabetic kidney disease. So you can see the diabetic kidney disease with albuminuria. There are so many trials. You have trials which have targeted only albuminuria. But what will be the non-albuminic diabetic kidney disease? Because non-albuminic diabetic kidney disease has not been included in any of the trials. So what will be the status of this SGLT2 inhibitor or this RAS inhibitor in this non-albuminic diabetic kidney disease? We don't know. For this, we have to include this entity, this patient, this group of entity in our trials in near future. Again, albuminuria is non-specific. It can increase in many conditions. It has quite variability. And for serum creatinine, we all know that it can be variable with muscle mass, diet pattern, and the formula chosen. So how can we diagnose diabetic kidney disease at the earliest? We don't have any troponin-like markers for kidney disease. But in the near future, we might get, these are the tubular biomarkers, several tubular biomarkers, which are in pipeline, but still they are expensive and they are not well validated. So till then, we get these markers for early detection of diabetic kidney disease. We have only this albuminuria and EGFR. So CKD with diabetes, this is all about diabetic kidney disease? No. We might get non-diabetic kidney disease in CKD, in this patient entity. And why this is important to diagnose this non-diabetic kidney disease? Because 50% of the kidney disease in diabetes is non-diabetic kidney disease. And it is very important to diagnose this because it will change the treatment pattern, it will change the management, it will change the prognosis. Because in non-diabetic kidney disease, we might have glomerular disease, interstitial nephritis, autosomal dominant polycystic kidney disease, and treatment, we can provide steroids, immunosuppressant, or these tolvaptans. So we have to be cautious while treating our patient of CKD with diabetes. And this should be keep in our mind. And so how will we diagnose this non-diabetic kidney disease entities? For this, we might go for this renal biopsy. And in certain subset of patients, we have to do renal biopsy. And what are those patients? Where there is absence of retinopathy in type 1 diabetes, albuminuria developing less than 5 or more than 25 years after the onset of disease in type 1 diabetes, immunological markers or active urinary sediments, acute sudden onset macroalbuminuria or the nephrotic syndrome, nephritic syndrome, hematuria, rapid decline in renal function, significant reduction in EGFR more than 30% after initiation of RAS inhibitor or acute kidney injury. So in this condition, we should go for renal biopsy. So chronic kidney disease, we all have heard that this is irreversible disease. So why to treat it? Is it too late? No, because with treatment, we can prevent or delay the progression of the disease. We can prevent CV events. We can improve quality of life. We can reduce the cost of care of end-stage renal disease. So you can see here, a small change make a big difference. If in a patient of 25 years, say he is losing his EGFR by 5 ml per minute per year. If by the maneuver, we can decrease it to 3 ml per minute per year, then he can have 10 years of dialysis-free life. So we should always try to reduce, we should always try to target this EGFR in our CKD patient, because a small change makes a big difference. So what is the treatment? Cardio-kidney risk factor management. This is all called as. And this includes lifestyle, physical activity, smoking cessation, nutrition. Again, glycemic control, blood pressure control, and lipid management. So coming with this salt restriction, less than 2 grams of salt per day unless contraindicated. But this is easy to say. How can we tell our patient to have this less than 2 grams salt? For this, you have to remember these 10 ways to cut out salt in our patient. We should give some time to our patient and tell these things to our patient so that he can have salt restriction, because it is very important to have salt restriction in these patients. Again, for diet, we suggest maintaining protein intake of 0.8 gram of protein per kilogram per day for those with diabetes and non-dialysis. For dialysis, patients should consume between 1 to 1.2 gram of protein per kilogram per day. Plant protein is always better than animal protein because it has get less protein, less phosphorus. So in kidney patient, we prefer plant proteins. Now about the exercise, moderate intensity exercise of 150 minutes per week is required in our patient with cardiovascular and physical tolerance should be checked before starting the exercise. Smoking cessation, it is always retard the progression of CKD in diabetes patient. Lipid control, dyslipidemia is very common in diabetic kidney disease. According to recently released KDIGO guideline, statins are recommended for all patients with diabetes and non-dialysis dependent CKD, and atorvastatin has the minimal renal excretion. So this should be the drug of choice in diabetes, in CKD patients. Now coming to the hypertension, what should be the target and which drug we should give to our patient? So we have several trials over the years, and previous trial have told that with stricter control is only required if proteinuria is more than 1 gram. But with this sprint trial, things have changed because it has shown that intensive reduction in systolic blood pressure reduces cardiovascular events. Intensive reduction in systolic blood pressure has mortality benefit. And with adoption of systolic blood pressure less than 120 mm of Hg in all CKD population, separate blood pressure target for proteinuria is not required. So KDIGO guidelines says that we should suggest that adults with high BP and CKD be treated with a target blood pressure of less than 120 mm of Hg using a standardized office BP measurement. But certain groups, we could be little lenient, like advanced CKD, diabetic kidney disease patient who are aged and who are frail. So this is all about the target. Now, we all know that ACE inhibitor and ARB have shown renal protection in several trials. But how many of our patients of CKD are getting this ACE inhibitor and ARB? This is one data from US, which shows that only 25% of the candidate patients are getting ACE inhibitor and ARBs. So this is the pathetic condition. We are not prescribing our patient ACE inhibitor and ARB. And it has shown that if we are stopping ACE inhibitor and ARB in our CKD patient, then we are increasing the death and end-stage kidney disease in our patient. So KDIGO recommend that treatment with ACE inhibitor or ARB be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications be titrated to the highest group dose that is tolerated, which is Dr. P.K. Sinha sir is saying in the early morning. Again, for patient with diabetes, albuminuria, and normal blood pressure, treatment with an ACE inhibitor or ARB may be considered. Only we have to do this, we should check blood pressure, serum creatinine, and serum potassium within 2 to 4 weeks of initiation, and continue ACE inhibitor and ARB if creatinine rise by more than 30% within 4 weeks following initiation of treatment or increase in dose. So we should always check creatinine. If it is increased by only 30%, then we can continue with that and advise contraception in female patient. Again, hyperkalemia is the dreaded thing which can occur with ACE inhibitor and ARB. So we should not always stop this. First, we should reduce serum potassium level by using other maneuver, like we should see other drugs, or we should see the food what our patient is consuming. And then if it is not working, then we should stop our ACE inhibitor and ARB. So glycemic monitoring targets and agents in diabetic kidney disease. So for targeting, we have these three: fructosamine, glycated albumin, and HbA1c. But HbA1c is the preferred choice still, and we should be individualized treatment. We should be individualized target in CKD patient. If patient is frail, older, advanced CKD, then we should be little lenient target should be less than 8% of HbA1c. While our patient is young, he is having no comorbidity, then we should have target of HbA1c less than 6.5%. So individualization is the key as far as HbA1c is concerned. And we should go for this continuous glucose monitoring in advanced CKD patient. This is coming up. So what should be the agent? If agent should be efficacious, delay the progression of CKD, have favorable outcomes. And metformin is the first drug which should be given in these patients because it has got anti-diabetic and renoprotective effect by these mechanisms. I am not mentioning it. So how will you give metformin to a diabetic kidney disease patient? With less than 30, you should not start. With 30 to 44, if EGFR is 30 to 44, you should start with half dose, then see for EGFR every 3 to 6 months. If EGFR is maintaining between 30 to 44, continue the drug. If EGFR is 45 to 59, you can start with 500 to 850 mg in a week. In a week, you can increase by 500 mg. Then you monitor patient at least annually. And if EGFR is maintaining between that, then you can continue with that. Only thing is that you have to monitor vitamin B12 level annually if metformin has been given for more than 4 years. Now coming to the SGLT2 inhibitor, which has shown renal cardioprotection in many of the trials. I am not mentioning this. These are the various trials, including the recent trials, DAPA, CKD, and IMPERA trials, all these. These are the 3 trials which have renal outcomes, and they all have shown the benefit. I am not going in this. So the fear is that SGLT2 inhibitors will cause AKI, but this trial have shown that initially GFR will dip like in S inhibitor, but it is not a sign of injury. So we can, if the GFR is decreased by 30%, you can continue with SGLT2 inhibitor. But before giving SGLT2 inhibitor, you should see that your patient is hydrated, your patient is not taking heavy diuretics. It should be seen in our patients. So these are the risk mitigation strategies. We should see for genital mycotic infection, volume depletion, DKA, amputation, and hypoglycemia in our patient on SGLT2 inhibitor. And KDIGO recommend that kidney and cardiovascular protection with SGLT2 inhibitor is without doubt. So it is reasonable to withhold SGLT2 inhibitor during prolonged fasting, surgery, or critical medical illness. And it has been discussed by me, so I am mentioning. And reversible, this I have mentioned. So, so SGLT2 inhibitor should be given in all patients till EGFR 20. Till EGFR 20, you can give SGLT2 inhibitor to all your patients. And once you have started SGLT2 inhibitor, only stop once patient is on dialysis. Once you will start your patient on dialysis. So this is the main thing what I want to convey to you. So another one molecule is GLP-1 receptor agonist, and this work by indirect effect and direct effect. And the meta-analysis have shown that this is also a good molecule for kidney disease patient. And KDIGO recommend that in patient with type 2 diabetes, CKD, who have not achieved individualized glycemic targets despite use of metformin and SGLT2 treatment, or who are unable to use those medication, we recommend GLP-1 receptor agonist. Now, this is the new molecule, Finderon, which is coming in a big way. And this Fidelo-DKD and this Figaro trial have shown that this drug should be given in all patients of CKD, the diabetic kidney disease patient, if patient is on maximum tolerated dose of ACE inhibitor. Only thing is that we should see for hyperkalemia. And hyperkalemia is the major thing which we should see in our patient. So these are the drugs, newer anti-hyperkalemic drug like patriomar and sodium zirconium is coming on the way, and we can use it for the long. It has to be seen because there are trials which have seen that if it has been used for 1 year, it is quite safe and we can continue with ACE inhibitor and ARB with these agents, but this is still not recommended. Now coming to this new molecule, tirzepatide, which is a novel once weekly injectable glucose dependent insulinotropic polypeptide and glucagon-like peptide receptor agonist that integrate the action of GYP1 and GLP-1 incretins into a single molecule. And it has been shown in SURPASS trial that kidney function with this molecule is quite effective with in compared to insulin glargine. Again, this is again new molecule, imeglimin, which is a drug which work on mitochondria, which improve the mitochondrial dysfunction and also improve kidney function. But still, it is not recommended in diabetic kidney disease patient. So this is the holistic approach for improving outcome in patient with diabetes and chronic kidney disease. This is my final slide. So first is lifestyle modification with healthy diet, physical activity, smoking cessation, and weight management. First line drug is SGLT2 inhibitor. Initiate if GFR is more than 20. Continue until dialysis or transplant. Metformin if eGFR is more than 30. And again, addition, we can add GLP-1 receptor agonist if needed. Non-steroidal mineralocorticoid receptor can be added if needed. RAS inhibitor should be given in all patients. So this is all about the CKD. This is the final slide. Thank you very much.
Thank you, Dr. Mrityunjay Kumar Singh, for excellent talk. Mrityunjay Kumar Singh means MKS. MKS means marvelous kidney specialist or marvelous kidney speaker. For DKD or DNP is a clinical condition characterized by 3 P. First P, there is a progressive persistent albuminuria, more than 300 milligram per day. Second, pressure is increased, that is the blood pressure is increased. About 70% of the DKD patient, there is a hypertension. And third P is progressive decline in GFR, that is GFR is less than 60 ml per minute per 1.73 square meter. So this is the about DKD. Regarding cardinal manifestation, ABCDEFGH is the cardinal manifestation of DKD. A stands for anemia, acidosis, hysterexis. B stands for breathlessness, and this breathlessness is either due to metabolic acidosis or breathlessness is due to pulmonary edema. Next, C, there is a cardiovascular disease, which is more common in DKD patient, and this is due to MIA. MIA is the malnutrition, microalbuminuria, inflammation, and atherosclerosis. D is there is a dyslipidemia. 20% of the cases of DKD, there is a dyslipidemia. And next D is dystrophy. There is a renal osteodystrophy in which there is a osteomalacia, osteoporosis, and osteitis fibrosa. The osteomalacia is due to decreased calcium level, and osteoporosis and osteitis fibrosa is due to secondary hyperparathyroidism. Next E, there is a encephalopathy, which is common in DKD patient. And next F, there is a fluid overload, and this causes increased ABP, there is a pleural effusion, there is a ascites, there is a edema. And this H indicates hypertension. 70% of the cases, there is a hypertension, and there is a hyperkalemia, which is also more common in DKD patient. Regarding prevention, the to control tight glycemic control, and this is controlled by giving an oral hypoglycemic agent. Metformin is avoided. Insulin is the best choice. Second is the tight blood pressure control, and this blood pressure is controlled by ABCD. A stands for alpha blocker, B beta blocker, C calcium channel blocker, D diuretics. Potent diuretics is essential like furosemide and torsemide. Regarding calcium channel blocker, 4th generation calcium channel blocker is beneficial as that is cilnidipine, as this acts on both alpha afferent as well as efferent arterioles.
So can we cut it short, sir? We are running already.
So this is better. Next, BP should control, and the complication like anemia, hyperphosphatemia, hypocalcemia should control, and the lipids should also control low fat diet, low protein diet, low salt diet. And last point is education of the patient for dialysis or renal transplant.
Thank you, sir. May I request Dr. SNQ Nasser? Dr. Nasser, please come on the dais and present mementos to our chairpersons. Dr. ML Maheshwari ji. Dr. Bharat Bhushan ji. And Dr. O.P. Saha. And please honor our speaker, Dr. Mrityunjay Kumar Singh. And our speaker, Dr. Mrityunjay Kumar Singh. Thank you, sir. So now next section, to chair the session, I invite Dr. S.M. Ali. I think he's not here. Dr. Vandana Kumari. Dr. Vandana. Dr. Rajesh Kumar. Dr. M.N. Habib. Okay, Dr. Vandana and Dr. Rajesh are there, please. And I request our speaker for this session, Dr. K.K. Lohani, to present lipid concordance in diabetes. I'll be grateful if you can be fast and let's cut it short for 2 3 minutes.
आएगा माइक आएगा इसमें यही कौन सा ये बना ऊपर नीचे जी
Lipidology, as we know, is a science which is deals with the study of lipid metabolism in relation to healthy body and in disease conditions. Despite so many advances in the field of lipidology, still we are hearing a word conundrum, which means a puzzle, paheli. Now, let us see how our learned speaker, Dr. K.K. Lohani, solves this puzzle of or conundrum of lipid metabolism in relation to diabetes mellitus. Over to Dr. K. Lohani, sir.
Honorable chairpersons and dear colleagues. At the outset, I would like to thank the organizers of this midterm conference for inviting me to discuss a fascinating topic like lipid conundrum in diabetes. Neither diabetes nor lipid disorders need an introduction. Together, it is called atherogenic diabetic dyslipidemia. Honorable Chairperson has defined the word conundrum. There is one more definition of this word, sir. According to Cambridge Dictionary, conundrum means a problem which is difficult to deal with. And you said it is paheli, so almost same. Anyway, in a stipulated 20 minutes time, we will try to undo this conundrum. Dyslipidemia, as we all know, is managed according to international guidelines, which keep on changing from time to time. The most recent and widely accepted guideline in this regard is European guideline, which was published in 2019. So we also call it 2019 European guideline. According to this guideline, patients are classified, patients of dyslipidemia are classified into 4 groups: low risk, moderate risk, high risk, and very high risk, depending upon presence or absence of certain clinical conditions. And diabetes is one of those conditions. If a person does not have diabetes or any of the risk defining condition, it is called low risk. If diabetes is present, but for less than 10 years, a recently diagnosed diabetes without other risk factors, it is moderate risk. If diabetes is present for more than 10 years with at least one more risk factor without target organ damage, it is high risk. And if diabetes is present with 3 or more risk factors with target organ damage, we call it very high risk individuals. There is one more way of defining this risk, and that is through a computer generated formula, which is called a score. If this score is less than 1, low risk, between 1 to 5, moderate risk, between 5 to 10, high risk, and more than 10, very high risk. And for all the 4 categories, there is definite goal for LDL cholesterol. Low risk, LDL should be kept below 116, moderate risk below 100, high risk below 70, and very high risk 55 milligram per deciliter. The million-dollar question is how to achieve these LDL goals, 100 or 70 or 55. We achieve it with 2 modalities of treatment. Number 1, lifestyle modification, followed by lipid-lowering drug if required. Or number 2, lifestyle modification with concomitant lipid-lowering drug right from the beginning. Again, I emphasize very clearly that lifestyle modification is mandatory at every stage of dyslipidemia management. And after that, we think of lipid-lowering drug. If condition is very serious, very high risk and high risk, then only we can think of adding lipid-lowering drug right from the beginning, but with lifestyle modification. So I'm repeating this word lifestyle modification just to emphasize upon its importance. Now, let us come to the lipid-lowering drug. According to European guideline, and for that reason, American guideline, which was published in 2018, or Indian guideline, which was published in 2020, 3 drugs are mentioned in guideline for lipid-lowering purpose: statin, ezetimibe, and PCSK9 inhibitor. Statin is, of course, the primary drug, and if this is not enough, then we use add-on drug, that is ezetimibe and or PCSK9 inhibitor. It has been found and it is recommended that when we use moderate intensity statin, we can achieve more than 30% reduction in LDL cholesterol. If we use high intensity statin, we achieve more than 50% reduction. If we use moderate intensity with ezetimibe, it is as good as high intensity statin. And if we add ezetimibe in high intensity statin, we get 65% reduction. If PCSK9 inhibitor is added with high intensity statin and ezetimibe, we can get up to 85% reduction. So this is the recommendation. And when we use these drugs in different combinations as per required, there is absolute reduction in LDL cholesterol, and finally absolute reduction in baseline risk. And precisely that is what we look for while dealing with a patient of dyslipidemia. But then, as the saying goes, there are many slips between cup and the lips. In spite of all said and done, in majority of patients of very high risk category, the LDL goal is not achieved. It is very difficult to bring LDL below 50 or 55. Why? Either because we do not use maximum tolerated dose of statin, which is also known as high intensity statin. Or we never bothered to add ezetimibe into it, or we could not afford PCSK9 inhibitor, which is a very, very costly drug and given by subcutaneous injection every fortnight. As a consequence, the scientists developed two more molecules and added in our therapeutic armamentarium our extensive clinical trial. And these two new molecules are bempedoic acid and inclisiran. So as on date, we have 5 drugs to address LDL cholesterol. Bempedoic acid, like statin, inhibit the synthesis of cholesterol in the liver. Of course, the enzyme which they target is different. Statin, we all know, is HMG coenzyme A reductase inhibitor, but bempedoic acid inhibits the enzyme ATP citrate lyase. But both molecule has got same net result, and that is inhibition of synthesis of cholesterol. Ezetimibe, we all know, it delays the absorption of cholesterol from the gut. So ultimately, there is less LDL cholesterol in the blood. Inclisiran is a newer PCSK9 inhibitor. In fact, nowadays, the word inclisiran has become synonymous with PCSK9 inhibitor. And the PCSK9 inhibitor we used to know for last 5 years is nowadays called PCSK9 monoclonal antibody. Why? Because the traditional PCSK9 are monoclonal antibody and it neutralizes the enzyme PCSK9. And inclisiran inhibits the PCSK9 messenger RNA. So it is more PCSK9 inhibitor than PCSK9 monoclonal antibodies. Many authorities use the term PCSK9 inhibitor for both molecules. So, and what they do, they increase the excretion of LDL cholesterol from the blood by upregulating the LDL receptor on the liver surface. So that is precisely the mechanism of action, and that is precisely the options we have to address LDL cholesterol. And this is the summary of LDL cholesterol, different LDL cholesterol lowering drug. As I said earlier also, statin, ezetimibe, and PCSK9 inhibitors are already mentioned in different trials. It has been well tried in the past, then only included in this guideline. Recently introduced drug inclisiran and bempedoic acid are other options. To sum up one line, I can say that you start treatment with statin. If that is not enough, you are not getting your target, add oral drug, either ezetimibe or bempedoic acid. If that is not enough, then add injectable, that is PCSK9 inhibitor or inclisiran. One thing is good about inclisiran, that it is not given fortnightly. First dose, day 0, second dose, 3 months, third dose, 6 months. And after that, every 6 months, we have to give this molecule. Whereas PCSK9 monoclonal antibody, evolocumab, is given every fortnight. And needless to repeat, it is a costly drug. At this stage, anybody can ask me a very valid question. If management of dyslipidemia is so simple and straightforward, then why the organizers have used the word conundrum for diabetic dyslipidemia? And its answer is very explicit. The pattern of dyslipidemia in diabetic patient is different from dyslipidemia we see in general population. All of you must have seen this slide. It shows the characteristic of Asian Indian. And Asian Indian has got many peculiarities. Thin fat Indian, high visceral fat, higher insulin resistance, high inflammatory markers, high small dense LDL, low HDL, high triglyceride, early beta cell destruction, early onset of diabetes, higher risk for diabetes complication, and higher risk of CVD. In terms of dyslipidemia, if we want to conclude this slide, there are a different pattern of dyslipidemia in Indian patient. This slide I have taken from INDI-AB study, which was basically ICMR study, and chief investigator was none other than V. Mohan, the eminent diabetologist of this country. And see what it shows. 72.3% individuals in India have low HDL. That is the commonest dyslipidemia seen in our country. And about 30% have high triglyceride, about 14% has high cholesterol, and about 11.8% have high LDL. So that is the difference in the pattern of dyslipidemia from Western world to Indian subcontinent and from non-diabetic to diabetic patient. At this stage, I would like to mention the result of a cross-sectional study from India, which was published in Asian Journal of Medical Science in 2015, if I know correctly. The aim of this study was to identify pattern of dyslipidemia and prevalence of atherogenic diabetic dyslipidemia in treatment-naive diabetic patient. By ADD, we mean high triglyceride, high LDL, and low HDL. And see, what is the result? 34.2% patient in this study had atherogenic diabetic dyslipidemia. And 73.2% patient had glycosylated hemoglobin more than 8 in these patients. So, commonest dyslipidemia was ADD, and 73% patient had frank diabetes with glycosylated hemoglobin more than 8. So that is why I said pattern of dyslipidemia is different in India than Western world. ADD is commonly prevalent condition in 34%, and ADD have high level of glycosylated hemoglobin. But the story does not stop here. Though this was a very small study, which included only 120%, but its connotations were very high. The very next year, in 2020, an article was published in American Journal of Cardiology. And this was actually a review article based on BARI 2D study. I hope all of you must be knowing that BARI 2 study was actually planned to assess the efficacy of different modalities of treatment in patients of diabetes with atherosclerotic cardiovascular disease. A statistical analysis of this study was done. But before that, see, it included 2,300 patients. Mean baseline triglyceride was more than 180. Primary composite outcome was cardiovascular death, MI, stroke, which is also known as 0.3 MACE. And secondary outcome was cardiovascular death. Mean follow-up was more than 5 years. And what is the conclusion? Higher triglyceride is associated with higher cardiovascular risk in diabetes patients. This was the first conclusion. And number two, every 50 milligram increase in triglyceride level was associated with increase in cardiovascular death, myocardial infarction, stroke, or increase in cardiovascular death. So precisely after analyzing this BARI 2 study, which included more than 2,000 or 3,000 patients, this is the conclusion: high triglyceride, high cardiovascular risk in diabetic patient, and high primary and secondary outcome. The same year, another review article was published in Journal of American College of Cardiology. And this study was based on PREDIMET study. And again, PREDIMET study, I hope you all remember, was planned basically to assess the efficacy of Mediterranean diet in prevention of atherosclerotic cardiovascular disease, cancer, and many other diseases. So that is a different story, but see what it suggests. Remnant cholesterol and triglyceride are associated with incident cardiovascular disease, and atherogenic dyslipidemia is associated with 44% higher risk of cardiovascular event. By remnant cholesterol, we mean total cholesterol minus HDL cholesterol minus LDL cholesterol. In other words, it is VLDL and chylomicrons particle, etc. So by now we can say that we have enough evidence in literature to believe that triglyceride is a big concern in patients of diabetic dyslipidemia. And personally, I feel there is no problem in accepting this hypothesis. But the problem is where? Problem is that we do not have unanimity on its management. Let us see what European guideline has to say about the management of mixed dyslipidemia, where triglyceride is also high along with LDL and low HDL. They say in very high or high risk patient with triglyceride between 135 to 499 milligram per deciliter, despite statin treatment, omega-3 polysaturated and fatty acid or icosapent ethyl 2 gram twice daily should be considered in combination with statin. I explain it. If a patient has got high LDL and triglyceride is also high, start treatment with statin according to European guideline. And if after maximal tolerated dose of statin, triglyceride remain still high, and still high means between 135 to 499. Then add lipid lowering, triglyceride lowering drug, and the drug of choice is icosapent ethyl, which is a generic and synthetic substitute of omega-3 polyunsaturated fatty acid. Fortunately or unfortunately, this molecule is not available in India, or even if it is marketed in India, it is very costly. 1 month cost is 6,000 rupees. It means per day cost is 200 rupees. And 4 capsules is given daily. So it will be a very costly drug. If you prescribe this, patient might forget to buy statin. Anyway, so what options we have? For this situation, we have been using fibrates till date. But nowadays, the European and American guideline, they do not recommend combination of fibrate with statin because they say that muscle-related toxicity will be more. In India, another molecule has been introduced for this purpose, and it is called seroglitazar. In fact, it is there for last 10 years. In 2013, it was approved by the Drug Controller General of India. And as on date, we have 3 options: icosapent ethyl, fibrate, and seroglitazar. Seroglitazar is not available in Western market. It is not mentioned in any European or American guideline. Whether this is science or commerce, I don't know, but seroglitazar is not available there, and icosapent is not available here. So only some senior can comment on this, why it happens. But we have options to manage this condition, fibrate and seroglitazar. So let us have a quick look at the comparison between seroglitazar and fenofibrate. Without going into the intricacies of this slide, in one line I will say, the previous speaker had also said, seroglitazar is a dual PPAR agonist. It acts on both alpha and gamma receptor, whereas fenofibrate is only PPAR alpha agonist. And what does it mean? Dual action means alpha action takes care of dyslipidemia and gamma action takes care of insulin resistance. So this seroglitazar takes care of insulin resistance as well as triglyceride. The net result is 45 to 60% reduction in triglyceride, non-HDL reduction 21 to 36%, small dense LDL 20 to 20.3%, glycosylated hemoglobin is reduced by 0.7 to 1.6%, and liver enzyme ALT is reduced between 28 to 67%. That is why this molecule has been authorized by the Director General of India, Drug Control India, to be used in non-alcoholic fatty liver disease also. Why? Because in non-alcoholic fatty liver disease, excess of triglyceride is deposited due to insulin resistance. And this is one molecule which takes care of triglyceride as well as insulin resistance. So we have a very good option in our country, seroglitazar. So this is the last slide. Now let us have a look at RSSDI consensus recommendation for management of dyslipidemia and especially triglyceride. As I said, if LDL cholesterol is high and you are aiming to address it, the choice is statin, either moderate intensity or high intensity, depending upon how much reduction you need. And by high intensity statin, by now we all know that atorvastatin 40 to 20 milligram and rosuvastatin 20 to 40 milligram is high intensity. Every other statin is moderate intensity. even in lower dose, these two molecules. And if this is not enough, we have the option to add ezetimibe or PCSK9 inhibitor. And as I mentioned in the beginning, nowadays two more add-on drug we have at our disposal, bempedoic acid and inclisiran. So this is precisely the management of LDL cholesterol. If triglyceride is high, again, RSDI suggests that you start treatment with statin. And you can add fibrate or seroglitazar or omega-3 fatty acid when? If triglyceride is more than 200. So there is only one difference between European guideline and Indian guideline. They say that you start treatment with statin, and after maximal tolerated dose of statin, if triglyceride remain high, then think of adding a triglyceride lowering drug. Here they say that you start treatment with statin, but if triglyceride is more than 200, you can add a drug to reduce triglyceride right from the very beginning. So RSSDI recommend triglyceride lowering agent in Indian type 2 diabetic patient with triglyceride more than 200 milligram deciliter. So precisely there is slight difference between international guideline and our own guideline. And one thing I would definitely like to mention here, that none of the drug which we discuss for the treatment of LDL cholesterol is safe in pregnancy. And for last 5 to 6 years, this is the protocol. The only drug to address LDL cholesterol which is safe in pregnancy is cholestyramine. Neither statin, nor ezetimibe, nor PCSK9 inhibitor, nothing. And for triglyceride, the only drug which is safe is omega-3 polyunsaturated fatty acid. So if you want to address triglyceride in pregnancy, this is the choice. Well, dear colleagues, I would like to conclude my talk with a line which I have taken from internet, Google. The challenges of diabetes remind us that life is about resilience and adaptation, much like our body's response to lipids. What I mean to say is not very difficult to guess. As a treating physician of dyslipidemia, we should be flexible in our approach. Medicine is not mathematics where 2 + 2 is always 4. Sometimes 2 + 2 becomes 5, sometimes 2 + 2 becomes 3. That is perhaps the reason why medical science is called the best profession in the world. Thank you very much.
Thank you. Thank you, Dr. Lohani, for wonderful presentation. I don't think there any question is left to ask further. Thank you, sir.
If anybody has any query, they can ask individually. May I request Dr. D. Ram sir to kindly present memento to the chairpersons, and Dr. Lohani, please do that. To Dr. Vandana, Dr. M.N. Habib, Dr. S.M. Ali, Dr. S.M. Ali, and Dr. Rajesh. And to our honorable speaker, Dr. K.K. Lohani. Now, one of the most beautiful attraction of today's scientific program, Masters Speaks, truly masters, whom I'm going to invite. They are the pillars of the API in Bihar. May I ask Dr. B.N. Kumar, Dr. Umesh, Dr. I.D. Singh, and Dr. Ubaid Ali to chair the session, please. Dr. Umesh, Dr. B.N. Kumar, Dr. I.D. Singh, and Dr. Ubaid Ali. Dr. Ubaid Ali, is he here? No. Okay. And so the first master comes is Dr. Hemshankar Sharma, who will be speaking on management of hypertension, the bullet train.
Thank you very much. So, advance. Yeah.
This one is there, no? ठीक. वहां देखना पड़ेगा. नहीं, यहाँ देख. Good afternoon, friends. I am here to critically evaluate where we fail. Instead of what we are doing new in hypertension, I will ask you where have we been failing in the management of hypertension. And if you have an introspection for that, then you will automatically know that what is new in hypertension. One thing which we all know that we are complicated by this dreaded disease, you will say, or a lifestyle disease, you can say that hypertension is. We are going to discuss all these issues. By your simple third-year knowledge, what is hypertension? It is the pressure which is while flowing in the blood in the arteries, and the pressure generated on the lateral wall is the hypertension and the simple blood pressure. But this is a very simple talk or the inception in the mind of the first-year students. And when they come with their stethoscope, the first thing they try to show that they know how to record the blood pressure and how to auscultate the heart. And still, I as a teacher do not know exactly that how we should record the blood pressure and where we are failing. So every year you go to the American College of Cardiology or the European Society of Cardiology lectures, you will be getting knowledges on how to record the blood pressure. Simply. So be mesmerized that after 150 years of clinical practice and so still majority of us do not know how to record the blood pressure. What is the correct method? So this comes to a problem of hypertension, which is a lifestyle disease and not exactly a disease. It is a part and parcel of our life. Why it is important? The term hypertension control refers to the percentage of individual reaching the treatment targets. And how many of us are on the targets? As we all know, there are rules of half going since decades and decades. Half of us, we do not know where we are having hypertension. Majority of us who are sitting over here are probably hypertensive. Majority of us. And there was one fine morning when the American College of Cardiology and the American Heart Association, they said that beyond 120/80, you are hypertensive. There was a term which was coined, pre-hypertension. What is this nonsense? So everything, every time you just wake up in the morning and the guidelines have changed. I'll be just throwing some lights on these guidelines and why we are following these guidelines. Remember, the guidelines are not the rules, not the laws. They are just to help you out that you just go on this way. There had been a couple of trials, whether the trials, randomized controlled trials, are general standard trials or not. We all know that how the trials are being run and how the trials are being propagated from the Western world to the Indian world. And I tell you that in my practice, there are only less than 20% of the RCTs which are genuinely RCTs, and all other 80% are sitting in the library and make some records, take the data from last 20 years, and you can just do any formulation, what you so like with your mind. And the examples are the best speakers of our country. Once they will be speaking for metformin, and the next talk you go, they will be speaking against metformin. You see there, this vagaries. So these vagaries are like in hypertension as well. So gentlemen, although it is a significant disease which causes the risk of cardiovascular, brain disease and the kidney diseases, which we have been just listening from all the masters since morning. And one of my mentor and teacher, Dr. Ajay Kumar is here, who has taught me medicine, and Professor A.N. Rai and D.P. Singh and Dr. Deviram, who have guided me always in my life's career. Still, I am a learning student, like less than a third-year student. I feel like that I have just entered into the first year of my medical college. What are the barriers? There are many barriers in the diagnosis and management of the hypertension patient. Factors like poor patient compliance. And not only poor patient compliance, go into the compliance by the physicians. So it is the poor physicians compliance which takes an overview or probably better reflected than the patient's compliance. The physician hardly gives a time. In our practice and particularly in our state, what we record and what we measure, we are not quality of medicine, what we are dealing with the quantity of medicine. My friends ask me how many patients you had seen last day, and they are happy. Yaar, tumne 100 dekha, maine 150 dekha. If you're seeing 150 patients a day, how much time you are going to give your patients? 10 minutes, less than 2 minutes, and you think that sitting on over here and speaking from this dais, that you should do this and you should do that. Have an introspection. When we are not able to do this, why we should promote all these things? So have an introspection yourself. Go cut down your level of quantity, improve your level of qualities, and that becomes very, very important. A treating physician, which factors can modify the better management of the hypertension and early diagnosis. 1, prescribing medicines in the correct way by inculcating knowledge from ongoing studies
preventing complications, timely and proper follow-up of the patients after learning from such CMEs and all that. Once you go back, try to learn that where you faltered, and from these faulted compositions, we should know and try to assess that what is new. Updating oneself about the recent changes in the guidelines about the management of hypertension is of immense importance. Studies show several reasons for why we fail to manage hypertension effectively, and bringing appropriate changes in the management accordingly is inevitable. Focusing on the areas where we lack, this is more important, and adding information to our studies, to our own self, that where we have been lacking, try to improve upon ourselves, and only then you can become a perfect family physician and not a consultant physician. I want India and countries like India, they need family physicians who can guide you for everything in the problems and in the family. That is very, very important aspects. Guidelines, as we have been discussing, there are so many differences in the awareness, treatment, and control. You go by any guideline and you will see, you will be just surprised. The same figure is represented in one guideline in some different ways and another in the different ways. The guidelines differ from each other basically in different points. Diagnostic threshold is different. Staging of hypertension is different. Previously 3 stages, 4 stages, 5 stages. Now the current guidelines ESC, 8 stages of hypertension, different types of hypertension. I will be coming to those aspects. How you can remember the 8 stages and where you are going to classify those 8 stages. Recommendations for the cardiovascular risk. Go on the comorbid conditions. This is very, very important. Cardiovascular risks are very important. Home and ambulatory blood pressure monitoring. Everybody will say AVMP is very good. That is the best thing. Home blood pressure monitoring is very good. The machine, what you are going? क्या दे रहे हैं आप? Electronic BP instrument. अरे बॉस, जब आप एक बार रिकॉर्ड करते हो तो आता है 130, दूसरी बार करते हो तो आता है 170, तीसरी बार करते हो तो 110. और मैं बताऊं, when the actually the limbs are smaller girth, it records EE and high EE. आप EE क्या करते हो? You go for a sphygmomanometer by mercury. And other than that, whatever you say and do and perform and talk in the national or international level, you cannot replace that instrument. And that is the lifeline for all the physicians when they control and say that, yes, this should be the instrument which should be equated. And this is the ISI mark. So whatever about the pollution, how many of us have been polluted the countries and all the things? You see, this is one of the examples. The BP stages are same, 120, 122, 129, from go to more than 180. And see the classification. The AHA, ACC, ESC, ESH, ISH, CHL in India, everyone is just enumerating this differently, interpreting it differently. अगर glass आधा खाली है कि आधा भरा हुआ है, बस यही है. कोई कहेगा ये भरा है तो पूरा नहीं भरा है, ये भरा है तो 75% भरा है. The same guidelines I told you in the outset, that example, the best example was in the morning you got up and you found out कि साहब आपका guideline नया वाला आ गया. कितना आया? 120/80. Lot of discussions, hue and cry, and finally they had to take it back. So these are these things which are very, very important. JNC had created that problem, and it came with that only. The age of the patient, associated comorbidities, BP, choline, hypertension, always consider what is the comorbid condition which is associated with the patient. Whether the patient is obese, thinly, frail, suffering from CKD, suffering from pregnancy, hypertension, suffering from diabetes. So all our guidelines are different, but they are very simple to know, simple to understand. You ask a kidney expert, CKD, Mrityunjay was here. 130/80. Ask a gynecologist, 135/85. And they are all differently varying and weighing. Are you going to just record the blood pressure by 2 millimeter at a drop? कभी देखा है 2 millimeter drop करके पढ़ाते हैं, प्रोफेसर एन राय ने पढ़ाया था. It should go by 2 millimeter every time. Go down, slow. How many of us are recording the blood pressure? Majority of the consultant like me is not recording the blood pressure properly because we don't have time. Compounder देखता है बाहर में, वो जो लिख के दे देता है वो कर देते हैं. अगली बार गलती से अगर अजय कुमार सर ने खुद रिकॉर्ड किया, देखा पिछली बार कंपाउंडर ने 124 लिखा था, अभी 184 आ रहा है. अब क्या करे यार, सर पीटे अपना. Every time he cannot do it. He is overburdened. Everybody is overburdened. So the things are that you have to just take into consideration all these aspects. The guidelines, you imagine 120 to 140, beyond 140. 139, 140 की बात मत करिएगा, 1 मिलीमीटर का डिफरेंस हमेशा रहता है. 140. Now the current guideline is pressure is less than that, stage 1, and beyond 140/90, stage 2, and there is nothing like that. So, but this has been changed by the other guidelines. They don't accept it. Our newest this ESH guidelines. So what they have been doing, all the long series of hypertension and the different types of classifications you will find out. And I am telling you that every time, every year, a new classification will come. We just go on to move into the ESC and try to find out कि इस बार कौन सा guideline आया नया. अगली बार आप मरीज को बोले कि भाई पिछली बार 132 था, वो hypertension में था, इस बार आपका 132 सही है, because you have crossed 59 to 60 years. Now 160 में चले गए, black rest हो गए. One fine morning you were normal up to 160 by 90. Now you are not there. Every age is 140 by 90. So similar, the things are like this. These things are very, very important. You imagine 8 categories: optimal, normal, high normal, 5 categories: hypertension, grade 1, grade 2, grade 3, isolated systolic hypertension, diastolic hypertension. How many of you remember all these aspects? And multiple categories may complicate the implementation of this monitoring of the blood pressure and recording it. It's very, very important aspect. Diagnosis is average 2 to 3 accurately measured BP readings. Really remember that how to sit. It is all sitting blood pressure which is recorded currently, right? The foot on the ground flat, spine supported on the back. अरे कुर्सी भी नहीं हमारे पास जो spine support की कुर्सी हो. तो ये these things are once we are talking academically, but what practically we are doing. Patient आराम से ऐसे लेटा हुआ आप record कर लिया, right left कुछ पता ही नहीं है किधर का record हो रहा है, right? So these things should be taken into considerations, and after that only, if you are honest to confess and record it properly, only then you can say that yes, now I am happy that I have recorded it myself in the best possible proper way, and I do not know whether this will be coming into implementation or not. CVD risk, high or very high, established CVD or CKD risk, long lasting complicated diabetes, everything you have to look into. Hypertension mediated organ damage, you have to find out that what are the different damages, and accordingly you have to just change the guidelines or select the drugs that what is the level, why we are using these drugs. There are one example I will give you: ACE inhibitors. Whether ACE inhibitor is better or ARB is better, there has been a lot of discussion. Finally it comes that all are same, whether the ACE inhibitor should be given in a patient who is having a serum creatinine level of more than 5 or not, yes or no. Somebody will say yes, somebody will say no, right? So almost 20 to 30% will say no, we can continue. If there is a sudden decrease in next 6 weeks treatment, more than 30% fall in the serum creatinine level, then you should stop ACE inhibitor. Whether we should stop or no, again a discussion, no, yes or no, right? So you have to just readjust the doses or you have to stop the doses. Do you have to switch over to ARB? Which ARB is better? If you go to England, still they are using losartan. The maximum number of drugs they are using enalapril or this losartan group of. So these are the two. Lisinopril, enalapril still is in England, roaming in England. You go to America, they will throw it out. Tell me certain. So which one is better? We do not know. We don't know the answers. But I have read at one point in the old days when there was no Oxford textbook of medicine. It was the Price's textbook of medicine, and written into 35 pages of hypertension. The last lines of that hypertension concluding remarks were, to our learned, smart, I'm just changing some words, learned, smart doctors who are coming into practice recently, it may look like that the drugs which are being prescribed by someone else is old, outdated drugs. But remember, they know the effects, they know the side effects, they know how to monitor, they know when to use, and they also know when not to use. So don't be tempted by those drugs which are coming or flooding the markets every night. Every 2 weeks, 3 weeks, 5 weeks, 4 weeks, every new drug is coming. Don't be tempted by these all guidelines, right? Right now, my friend Dr. Luhani said from here, he named a couple of things over not available in India. So how to treat? हमको क्या लगता है हाइपर ट्राइग्लिसराइडेमिया ट्रीट करने के लिए यूके भेजना होगा, यूएसए भेजना होगा, पैसे कहाँ से आएंगे 6,000 रुपए? So not possible. So try to inculcate the lifestyle modifications. Try to inculcate those drugs which are readily available, are cheaper, and the patient can follow them up. So these are the things which are always to be kept in mind. Now, out of office BP or in office BP, these are very vagaries. These are very good things that whether white coat hypertension you are dealing or off white coat hypertension you are dealing, a reverse white coat hypertension. So all these things, they are almost literally theoretical. Be practical and find out what is the age of the patient, what are the comorbid conditions, and whether the blood pressure is less than 140/90 or more than 140/90. This is the one line you can take, and I think most of your problems will be over. That will be very much. ABPM, how many of us are using it? ABPM, I do not know. Go by the corporate cultures. Everybody is saying, I use karta hu. When I went to the Max Hospital and found out my friends, यार बाहर क्या प्रैक्टिस करते हो? कहा छोड़ ना यार, वहाँ टॉक देने के लिए बोलना पड़ता है ABPM, है ना? क्यों बोलना पड़ता है? सब लोग जानते हैं, राइट? कोई किसी कंपनी का लिखना है, कुछ करना है, खाना पीना करना है, वो छोड़ दो. लेकिन इनसाइड हम लोग क्या बात करते हैं? We are being guided by the European worlds. Why should we? Because we are culturally different, we are economically different, we are religion-wise different, our food habits are different, our lifestyle is different. So change into all those categories, right? There are very few physicians who are globalized, like Dr. Ajay Kumar, who is roaming today is here, tomorrow Denmark, then day after tomorrow in London, and we will be discussing all those issues of their aspects. We are here in Bihar, practicing in Bihar, Bengal, Jharkhand, Uttar Pradesh, Madhya Pradesh. So we have to talk in these terminologies till we go out and we have to change like girgits. Done? So that will be important. Lifestyle modification, we all know. We have been lot many discussions with my friends since morning. Lose weight, move often, eat healthy, less sodium in your diet, limit alcohol, stop smoking. मेरे मित्र जो यहाँ से भाषण दे रहे थे मिठाई पर, वो बाहर जाके 3 मिठाई खा लिए. तो ये भाषण क्या हुआ? भाग गया. अमित is here? नहीं है. अभी देखा था 3 मिठाई खाते हुए उसको. अरे चलता है सर, वो मैं भी वही करता हूँ, कहने की बात है. So don't take it otherwise. So initiation of high anti-hypertension. Select the drug which should be very proper. 18 to 80 एकदम सीधा याद रखिए. 18 या 79 वाला तो घूमता फिरता है. सिंपली याद रखिए कि 18 से 80, 18 to 80 with systolic blood pressure of more than or equal to 140 by 90. It is equal to or more than. Remember this, right? Adults more than 80 with SBP is 160. अब ये इसमें confusion है. Black race, white race. There are a lot many differences. Caucasians and niggers, they are differently being equated by certain guidelines. So I'm not going into the details of all the aspects. But if you are suffering from basically a comorbid condition like CVD, CKD, then please try to stick to the lowest possible range. So when and how it should be the control. There was a golden rule which has been in since decades. Keep the blood pressure as low as possible, as tolerated by the patient, but not below 100 by 60. But not below 100 by 60, because you will have a poor perfusion of all the target organs once you keep it below like that. You have to select the drugs. Start with a single or a double or triple drug combination. Whichever suits you and your patient, you select it. Whichever suits to you, your patient, select it. But for God's sake, if the patient is diabetic, go for ARB and ACE inhibitors. Go for ARB, ACE inhibitors. If there is impending failure, whether this is preserved heart failure or reduced, whichever it is, go by the ARNI, go by SGLT2 inhibitors. Incorporate in all drugs of your prescription of hypertension or cardiac problems. Inculcate or introduce and try to write SGLT2 inhibitor. That is a very, very important drug. That's a very important drug, I tell you. Right? And go for the ARNI if it is possible. It's not that costly. ARNI is not. You start ARNI, the drugs are only ARNI and SGLT2 inhibitor. That's all. At the most, you can add sometimes diuretics. So what is the cost? 3 drugs only. Why we are writing tonics and B complex and vitamin E and this and that? You are increasing the bolus of the prescriptions. Don't do that. Be generic. Be generic. Be very specific that these are the drugs which should be used and not unnecessary drugs. So these are all the profiles A, B, C, D. We have been reading all these aspects, that where to use, where not to use. Select a drug which is properly placed. The drugs should be proper dosing. And do not just decrease the dose. Do not take away the drug very quickly. उन्होंने ये लिखा, मेरे पास आया तो मेरा काम है पहला उसको हटा देना. क्यों? If the is right, then don't change it. These things are very, very important aspects. Treatment of BP targets. I have told you already told 140/90 is the usual thing, which should be kept below that, except in those conditions of CKD or gestational hypertension where it should be below 135/80/85. Right? These things are very, very important. Then what strategies? Strategies to improve BP guideline recommendations. Accurate, sir, PK Sinha sir, PK Sinha discuss कर लेंगे हमसे बाद में. Accurate and precise measurement of blood pressure. 1, including the use of clinically validated blood pressure instrument device, up to you. आप देखो कि कौन सा आपको अच्छा लगता है. Health promotions. This is not being done. That should be done. Education of the society is very, very important. Unless you don't do this, you will be just searching like pre-diabetes. कि आप टिप ऑफ द आइसबर्ग देख रहे हैं कि इतना है, 10% है, 90% तो नीचे है, right? This is the same thing. When you are not able to diagnose 50% of the patients, then you are calculating if 14% and 16% of the patients are suffering from hypertension. Gentlemen, double it up. At least double it up. When 50% you are not diagnosing, they are not coming to you for any problem, for no reason, you are going to just check them up. And it is not possible for any doctor to go into the community, move around, कि BP ले लो, BP ले लो, BP ले लो करके आप BP नपवा रहे. नहीं हो सकता है, not possible, right? So once you just take it into consideration that whenever possible, for whatever reason the patient has come to you, be very emphatic and precise to record the blood pressure yourself, and that becomes very important. So you have the easy access to the community at whichever level. The consultants have the penetration level of very few, but the general physicians have penetration to the highest point. Even the quacks can be trained by you. Quacks can be trained by you. I am not after them कि भाग जाओ, practice हटाओ. मैं आपको बताऊं, एवरेज इंडिया में एक क्वालिफाइड डॉक्टर पे 10 क्वैक है. आप उन 10 की ट्रेनिंग कर दो ना, आप उन 10 को समझा दो, उनके इंस्ट्रूमेंट देख लो, चेक कर लो, पढ़ा दो, बता दो, आप शायद कुछ भला करोगे उनका, इसका और जनता का. easy access to convenient community-based healthcare. These things are very, very important. Knowledgeable patient-centered healthcare system. I just, when Dr. Muruganathan just gifted us some of the electronic BP instruments, I just selected 10 of my patients जो लोग सोसाइटी में थे और जिनसे मैंने ये कहवाया कि आप 10 आदमी का नापोगे, वो उनको मैंने दे दिया 10 को, तो कम से कम 100 लोगों का बीपी तो चल रहा है, उनकी तो रिकॉर्डिंग हो रही है। तो आप लोग ये कर सकते हैं, उसका कोई कॉस्ट भी ज्यादा नहीं है। आपको बांटना है, वो हेल्थ केयर सिस्टम में जो आता है ना, अलग अलग हेल्थ कैंप लगा के उसमें गालियां सुनने के अलावा कुछ नहीं मिलता है। उस कैंप से अच्छा है कि उतना टाइम में प्रैक्टिस करो और 2-4-10 इंस्ट्रूमेंट बांट दो, लोगों को सिखा दो बैठा करके कैसे रिकॉर्ड किया था। दिस बिकम्स वेरी वेरी इंपॉर्टेंट. Use of simple evidence-based protocols for lifestyle counseling and antihypertensive drug treatment is a very, very important in all cases of uncomplicated hypertension. You have to target the uncomplicated hypertension. Once they are complicated, they will be landing in one of the corporate hospitals for multiple problems. The information system should be very disseminated one, and you have to just tell them everything. The key factors and the key features of the newer guidelines. The new guidelines cover the management of hypertension across all age groups, from children to very elderly, in pregnant women and high-risk individuals with comorbidities such as atrial fibrillation, diabetes, chronic kidney disease. We all know that all these things are different. I'm not going to discuss in the details. This means they have broad application for the practical management of a wide range of individuals with hypertension. Topics such as COVID has changed it radically. आपने देखा होगा COVID, sudden death. We still do not know what was the pathophysiology of COVID. You will find out that I have also suffered from COVID. Probably 50 of us might have suffered from COVID. Who have been working with the COVID patients might have suffered from the COVID. And after that, we feel like our diabetes, it was controlled. Now it is uncontrolled. Our blood pressure, it was very well controlled. It is now uncontrolled. We have developed arthritis. We have developed myalgia. We have developed depressions. We have developed lot many problems. You go and have an evaluation of your patients, that you just to try to find out, timer khatam ho gaya sir. Topic. So these things are very, very important. So pharmacological control of hypertension, I just took away. The sacubitril valsartan, I am a proponent for sacubitril valsartan. Whenever and whichever is possible, you must use this drug and the SGLT2 inhibitor. If you combine these two things, you have multiple benefits, all the kidney benefits and everything. Renal denervation, I'm not going to discuss 3 minutes. Renal denervation is I'm not going into detail, but the renal denervation has taken a big lap back. Right? It is coming, it has come back again. In select patients of renal denervation, particularly the trial which was started now in Japan, with the difference, the Radiance ST and Duo RCT trials, these are very, very important, but very select patients, very costly affair, and very few are benefited except the resistant hypertension. Nobody is going to be benefited into this one. This is not the usual treatment for this. So this is only for the academic importance that we are discussing about the renal denervation therapy and all that. Hypertension clinics, if you are not able to treat the patient, if your patient is not being controlled, send it to a person who is better than you, who knows better than you, or you take their help. It is not कि मैं अपना मरीज नहीं भेजूंगा, मेरा मरीज तो अजय कुमार सर रख लेंगे, वो नहीं रखने वाले हैं। मैं आपको बताता हूँ, नहीं रखने वाले हैं, है ना? उन्होंने आज तक नहीं रखा, हमेशा हमारा पेशेंट क्या भेज देते थे वापस, वहां दिखाओ, ये मैंने कर दिया, वहां जाओ. So go back like this. बीके सिंह भी है, एक कदम वो मत कर देना पूरा. So every hypertension clinic should have provide accurately validated BP monitors with 3 different cup sizes. I ask you, all of you, how many of you have seen that different 3 sizes of the cup? 1. And how many of you have used it properly? How many of you, 1 or 2 or 3 hand will come when I ask you to हाथ उठाओ. तुमने देखा है, रिकॉर्ड किया है, आप देखते हो, 9-10 साल के बच्चों को भी देखते हो. Although आप you are MD medicine, आप देखते हो 10 साल के बच्चों को. आपके पास शायद है भी नहीं वो इंस्ट्रूमेंट, शायद नहीं है. अरे ज्यादातर पेडियाट्रिशियन के पास नहीं है, तो आपके पास क्या होगा? तो ये चीज है ना, when you diagnose, how do you diagnose early glomerulonephritis in those patients? A child has come to you convulsions, आपने देखा ही नहीं बीपी उसका, भेजना पड़ेगा मृत्युंजय जी के पास कि जरा सा देख लीजिए, आपके पास तो इंस्ट्रूमेंट रखते हैं आप. So you see, these things are very, very important. So thank you. I'm not going to go. This is my last slide. So telehealth, we all know we have to help the patient, but telehealth, you remember one guideline. You remember, the Supreme Court is against you. The court is against you while doing a telecommunication. Remember this. So do not in private practice try to tell the patient, "Aap ye dawa le lo, wo dawa le lo." And you have gone, if you have not gone through the decisions of the Bombay High Court and the other high courts, try to remain ready. आपको वहां से जो punishment आएगा वो करोड़ों में आ रहा है, लाखों में नहीं आ रहा है. So telehealth में मेरा reservation बहुत ही blocked है. I am not going. I have stopped doing a tele except with COVID times when government has given us a free hand. I did consultation of more than 20,000 patients. कश्मीर से कन्याकुमारी तक, क्योंकि आई में सेंट्रल ने मेरा नाम दिल्ली में छाप दिया था कि इस नंबर पे बात करिए कोविड होने से. साला रात में आवे कोई संताली बोले, कोई कुछ बोले, समझ में नहीं आता था बोल क्या रहा है. Anyway, so these are the things. So summary is only one line. Hypertension is an emerging threat. It has already emerged. What is emerging? And it is increasing burden in healthcare system for which we are answerable to some extent. We are definitely answerable because you are not able to diagnose it. We are not able to promote it. We are not able to go with the patient's aptitude, attitudes, and the other things of the patient. We have to select the drugs which are cheaper, best, and will suit this patient properly. Thank you very much.
Thank you, sir. Thank you, sir, for your nice talk and opening the eye of the audience and doctors. Thank you, sir.
Very rightly and truly said. Now, the next master. May I request our organizing chairman, Dr. S.P. Singh, to please honor the chairpersons and the speaker. तीन दिन में to the speaker, Dr. And for the next section, I invite chairpersons, Dr. U.B. Singh, Dr. B.P. Saha, Dr. Ravi Anand, and Dr. Vani. Dr. U.B. Singh, Dr. B.P. Saha, Dr. Ravi Anand, and Dr. Vani, please be ready. Thank you, sir. May I request Dr. Dilip to chair the session, please? Dr. Dilip Kumar. Dr. Dilip, please. And another master, Dr. D.P. Singh, he will be speaking on OSA and diabetes.
Some few words about Dr. D.P. Singh. Dr. D.P. Singh, Emeritus Professors of Medicines, TB and chest from Bhagatpur Medical College, and giant pillar of medical fraternity of Bihar. He is a member of governing body API India, and he served as a president IMA also. He is a personality. He worked in TB and chest, and so many publications he has done. And Professor D.P. Singh, now still he is doing the service to the medical fraternity, and it's our proud moment, particularly at Purnia. His talk is very decent, and rather it is new for Indian, for Purnia, the obstructive sleep apnea with diabetes. You know, OSA is the loud snoring is known as OSA in rough. And of course, it is related to obesity, and diabetes is also related with obesity. Now, the giant person, Professor D.P. Singh, will teach us more about this OSA with diabetes. Dr. D.P. Singh, sir.
Thank you, Dr. U.B. Singh, for kind words. Honorable chairpersons and our teacher, Dr. A.N. Rai sir, our friends and senior brother, Dr. Devi Ram, Dr. Hemshankar Sharma, Dr. Ajay ji, Dr. B.K. Singh, and all friends present in this hall. Perhaps this is the last session, perhaps this last but one session. I'm thankful to the organizer, especially Dr. Ravi Modi, to give me this task to speak on OSA and diabetes. obstructive sleep apnea is a common condition. It is common, but usually we do not think about it. The diagnosis is underdiagnosed, and so it is undertreated. But my dear friends, it is a dangerous condition. If you think, if you diagnose and see the consequences, and next few minutes I will show you how it is related to diabetes. And diabetes, as you know, it is a cardiovascular disease. And the cardiovascular consequences is very high, and so many other dangerous effects of OSA is there. It is easily recognized, but unless you send the patient for sleep study, how will you know? So you have to suspect which one to suspect, how to do that sleep study, and then you can treat the patients and how it is correlated with diabetes mellitus. Sir, it is easily recognized and treatable disease. So this is sleep apnea. If you have got normal breathing, no problem. But once there is obstruction in the airway, it will have series of many effects. That's just only one thing is there is hypoxia. There is fragmentation of sleep. That sleep is disturbed. You will find out many effects apart from anxiety, depression, cardiac arrhythmia, coronary artery attacks, hypertension. Just now, my friends told about this hypertension, which is the greatest killer, greatest terrorist of India, we can say. 23 crores of people, Indians, are suffering from hypertension. One of the effects, side effects or consequences could be from the OSA. And then there are many pulmonary, arterial hypertension, so on and so forth. So again, Dr. Yobi Singh was talking about the triplet. The sleep apnea is related with diabetes. Sleep apnea and diabetes is caused by obesity. This triplet is very important. And as you know, there are three things there: diet, exercise, and sleep. These three things are very important in our life. If you do not sleep for 7 hours, 6 hours, 4 hours, once you have 4 hours or 5 hours of sleep, you are sure to develop heart attack or coronary artery disease. Lesser duration of sleep is very important. And if you have the lesser duration, again, you will eat more and you will develop more diabetes, more obesity. So sleep, nutrition, and exercise. If you do less of exercise, then again, obesity will be increased. Diabetes will be uncontrolled. And other this. So sleep, diet, and exercise, these three things, if you manage properly, the obesity will not come, diabetes will not come, OSA will not become. Just that triplet will be there. So this in sleep apnea, 23 times more likely to have a heart attack. This 3 times more likely to have the diabetic mellitus. And there are many more things that one can have. So some of the overview of the obstructive sleep apnea. Long back, Charles Dickens wrote one paper, Pickwick paper. And that time, this hypoventilation syndrome was known as Pickwickian syndrome. That famous boy, famous character was Joe. And what that character said? Sleep, said the old gentleman. He's always asleep and goes on errands, fast asleep, and snores as he waits at the table. Joe है character uska Charles Dickens ka. And he was the first patient of Pickwickian syndrome. And that is what we talked about the OSA just now. What is this OSA? It is a sleep disorders characterized by recurrent episodes of narrowing or collapse of pharyngeal airway. Normally, when we are awake, this pharyngeal wall activity is active. There is no narrowing. Once we sleep, there is collapse of there. And that collapse causes apnea, this apnea. That collapse of apnea causes the hypoxia, hyperdyspnea, and that series of events that we shall show you. Number of this cessation of airflow equal to or more than 10 seconds. That is called apnea index. Again, the decreased airflow is called hypopnea. This number of this apnea or hypopnea, there is index, and upon that we say that divide the severity, apnea, hypopnea index. If it is more than 5 or more, it is called mild. More than 15, it is moderate. And more than 30, it is called severe. So moderate to severe intensity of OSA is very, very important. And this can cause many of the cardiovascular, diabetes, and other consequences. And this is the change of events, starting from onset of sleep, loss of muscular compensation, decreased pharyngeal wall activity, airway collapses, apnea develops. Once apnea develops, hypopnea is there, CO2 is more, increased ventilatory activity, so you wakes up. Once you wakes up, again the pharyngeal activity comes on, and then the airway opens. You hyperventilate to correct the apnea and hypercapnia, and then again you lapse into sleep. So these series of events, and the more you have got number of apnea, more dangerous it is for you, but you don't know. But when you wake up in the morning, this sleep fragmentation, hypoxia and hypercapnia has got large number of CVD, diabetic and metabolic complication and more of mortality. Even if in the daytime you have got more accident because you are sleepy, you have got drowsiness, and that is very dangerous for us. And diagnosis, loud snoring, but not all cases of OSA snores. So that is very important. So even if the patient does not give you history that this patient is snoring, even they can be suffering from OSA. So you have to ask the bed partners whether your husband snores or not, or whether your wife snores or not, although it's more common in male. This automobile or work-related accident in the daytime can occur. Personality changes, cognitive problems, excessive daytime sleepiness, that is very, very important and often not recognized by the patients. The male are more commonly involved. Hypertension again. If any patient is taking more than 3 or more drugs, think about asking for the going to the sleep study. Resistant hypertension is one of the conditions in which you should or we should send the patient for sleep study to see whether the patient is suffering from OSA or not. And these are the different clinical features, especially the daytime sleepiness, this apnea, insomnia, memory loss, and there are many other associated conditions like hypertension, cardiovascular disease, stroke, cardiac arrhythmia, and other things are there. How to diagnose? That is one of these we stop bank questionnaire. Any patient you just put up on your prescription that snoring, if the patient snores, that is 1 point. Whether the patient feels tired, observed apnea, blood pressure again, if that is there, BMI is more than 35, age is again more than 50. That is the patient you can think about. Neck circumference is also important. Male gender is more commonly. So if the patient says yes in 3 or more, you can think about referring the patient for sleep study. That is called stop bank questionnaire. There are many other ways. And this is the diagnosis. You send for the sleep study, you do the polysomnograph, see the result in the morning. There is overnight polysomnography you can order. You can keep in your clinic, very small instrument that is, but you can charge 3,000, 5,000 or so. And in the morning, you get the results and you can label the patient, whether the patient is suffering from OSA or whether the patient has got mild, moderate to severe OSA. And what is the treatment? Apart from the lifestyle modification, that is very, very important, in the OSA. Lifestyle modification is very much important. The diet is very much important, but CPAP is the treatment of choice. And this CPAP, you have to put on while the patient is on sleep. This is the continuous positive airway pressure, but it is cumbersome. Daily you have to put with this machine. You have to sleep with this machine. So it's better to have that you don't suffer from this. How to prevent it, that is very important. So what is the connection in the diabetes and OSA? 72% of patients with type 2 diabetes suffer from OSA. You see, majority of the doctors here are diabetologists or cardiologists. See that number. Out of 172% of diabetics have got OSA, whether they have obese or they are snoring or not. So you can send almost 3/4 of the patients for sleep study. And 86% of obese diabetics, they have got OSA. So only 14% are left. So majority of the patients may have OSA. You have to think about it. You have to diagnose about it. You have to treat that. Only then the cardiovascular consequences, all-cause mortality, cardiovascular mortality, we can prevent. Second is OSA may have got a causal role. OSA, this apnea and hypoxia can cause the pathogenesis of diabetic mellitus. You shall see how that increases the inflammation or oxidative stress. OSA is also associated with insulin resistance. There are a lot of data, robust data are there. The obese patients with sleep apnea are more insulin resistant than the patients with simple obesity. Last line is that 30% of the patient presenting in a sleep clinic have got impaired glucose tolerance or diabetes, of which 40 are undiagnosed. So diagnosis, again, the patients have got underdiagnosis is very, very important. And these are these association. 35% of OSA is associated with hypertension. 49% have got atrial fibrillation. 59% has got pacemaker. 72% have got diabetes. CHF 76%. Obesity 77%. Drug-resistant hypertension 83%. I've told you 3 or more drugs, refer the patient for sleep study. Nighttime heart attack is 91%. So if one is suffering from OSA, one is more liable to suffer from the heart attack, that is nocturnal heart attack. You know that many of our friends even are dying for that. A prevalence of OSA, in some of the study, it may be 10%, but the maximum 86% patients of this OSA have got diabetes mellitus association, 86%. What is the mechanism? So if the patient has got sleep apnea, there are two things. One is hypoxia, intermittent hypoxia, intermittent apnea, and the sleep fragmentation. Sir, without waking up, if you have got the uninterrupted sleep for 6 hours, nothing will happen to you. But if there is interruption in the sleep, 6 hours of good sleep, that will make you healthy. In the morning at the 6 o'clock or 7 o'clock, if you wake up and you are feeling fresh, it means that you have got a good sleep. Otherwise, you will feel drowsy and not feeling well. So sleep, quality of sleep, uninterrupted sleep is very, very important. Otherwise, you see the result. Fragmented sleep will give rise to sympathetic activity. Sympathetic activity means catecholamines that will cause insulin resistance. Fragmented sleep means HPA excess alteration. You know, the cortisol level will go up. That will cause this insulin resistance. Oxidative stress, the hypoxia induced with factor, or there are many factors that will be liberated, that will again cause this insulin resistance. Again, the intermittent hypoxia will cause the pro-inflammatory mediators, all interleukins, 6 and TNF alpha, and there are many other pro-inflammatory mediators. Similarly, this adipocyte that we are talking about, that adipose tissue or obesity, there are adipokine profiles. That is also leptin will increase, and adiponectin, that is good, that is decreased. So that is also there because the adipocyte, large adipocyte has got very important site of action. And see this, if a body patient has got increased fat mass, so what will happen? This will cause the mechanical load on the narrow airway that will help in the narrowing of the airway and promoting the sleep apnea. Similarly, all these will cause, again, leptin resistance, insulin resistance, and hyperglycemia. All those just like I talked about this. So what will happen? What will be these dangerous consequences of OSA? Intermittent hypoxia means elevation of sympathetic nervous activity. Intermittent hypoxia means endothelial dysfunction. This intermittent hypoxia means pancreas, adipocyte, and other pancreatic cell dysfunction, insulin resistance, impaired insulin sensitivity, and diabetes mellitus, and all systemic hypertension. All these will cause cardiovascular mortality. So OSA will cause cardiovascular mortality and all-cause mortality. And that is the dangerous consequences of OSA. If you do not diagnose, if you do not put the patient on sleep study, if you do not treat early, the fate will be. So does OSA worsen the glucose metabolism in non-diabetic patients and predispose to developing diabetes? There are many data, there is a bit of controversy, there are many data that shows that yes, sleep heart health study that shows that disturbed sleep breathing can cause impaired fasting glucose, impaired glucose tolerance, and both fasting and impaired glucose tolerance, even occult diabetes. Similarly, 255 Chinese community-based OSA independently associated with metabolic syndrome. In this also, the 4-year follow-up, the Wisconsin, that's a famous sleep study that said the moderate to severe OSA was independently associated with impaired glucose tolerance, but causal relationship was not established. Again, this 16-year follow-up, the Sweden Sleep Clinic cohort study showed that the OSA increases the diabetes by 25%, and women, it may be 50%. As compared to the non-OSA patients. So there is relationship of the OSA and diabetes, very profound relationship. Again, the insulin resistance is also increased in the OSA patients. So does OSA worsen the glycemic control in diabetics? That is, the results are there. Yeah, Oxford, UK said no correlation. Hong Kong also says no correlation. But there are studies that shows that this HbA1c increases with OSA severity. So moderate to severe OSA, there is increase in HbA1c. This obstructive sleep apnea and metabolic syndrome, because the patient has got this triglyceride level high, diabetes is also high, HDL is low, that is there, the relationship is there. And the study shows the patients of OSA has got more of glucose level, more of triglyceride level, less of HDL level. That shows by the yellow shows the OSA and the green shows the non-OSA patients. Does OSA aggravate diabetic outcomes, vascular complications? Data says many of these hypertension is increased, the diabetic nephropathy, diabetic retinopathy, peripheral neuropathy, diabetic foot ulceration, that all are increased in patients of OSA. So, how to treat a patient of OSA plus diabetes? What is the model? A patient's early diagnosis is very, very important. Do the polysomnogram and treat with CPAP because you have to treat the OSA. But the CPAP adherence is very, very less. 1 साल के बाद सारे लोग छोड़ देते हैं. 1 साल तक मशीन के साथ सोना आसान नहीं होता. इसके बाद you have to educate the patient. This is very important. And then reassure the patient, reinforce the patient. Try to have the alternate therapy also and reconsider CPAP. That is one thing. But the modern day treatment is that you have to take the individualize the patient. You have the endotypes of the patient, genetic endotypes or endotypes of the patient, and the preference of the patient should also be taken into consideration. OSA treatment modalities. There are 4 types of modality that we are going to take about that. And the patient-centric approach should be there. And consider the targeted combination therapy. All those therapy we have to combine in patient therapy, not only the CPAP only. And whether the CPAP is important for reducing this diabetes, CPAP and weight loss is better than the CPAP alone, or even with the exercise. Metabolic surgery. Again, you see the in obesity, metabolic surgery or bariatric surgery has been shown to have very good effect in the selected patients. We go for it. There are many patients that we have sent and they have got good result. 83% the OSA was resolved. Impact of OSA in diabetes is still controversial. Presence of OSA worsen the glycemic control in diabetes, and effective treatment of OSA can ameliorate these detriments. And there are certain controversy in this. But these are the 4 modalities of treatment. Once the OSA is combined with diabetes, one is the diet. Again, I told you, repeated, diet is very important. You reduce the weight reducing diet, exercise, physical exercise, aerobic exercise, interval training, muscle training, all sort of we have talked in the morning that you have to take. You have to have the certain drugs. Bariatric surgery, we have already told you. This is the SGLT2 again. Whenever there is combination of OSA with this diabetes mellitus, this is a wonderful drug. In this Lancet September issue, there was editorial that this breakthrough of this SGLT2 plus this GLP-1 analogs, these 2 drugs, is a drugs which has revolutionized the treatment of not only the diabetes, but also this OSA treatment with diabetes. because both have got very much remarkable effect, not only upon the glucose lowering, but also upon the body weight of the patient. And this is a wonderful drug whenever the OSA is combined with this diabetes mellitus. So to sum up, friends, always suspect whenever you get a case of hypertension, whenever you get a case of diabetes, whenever you get a case of cardiovascular disease, whenever you get a case of obesity with snoring or without snoring, and send the patient to this sleep study, and high index of suspicion is needed to detect the coexistence of OSA and diabetes, metabolic screen in OSA for obese patients, just watch out OSA in diabetes and vice versa, and appropriate treatment of each of the two conditions should be there: weight loss, behavioral modification, drug treatment like SGLT2 and others, bariatric surgery whenever you are needed. Thank you very much for your patient hearing. So before we close, see the pictures of sleep apnea with the CPAP, good sleeping. If otherwise snore and this will happen to you, you will throttle the wife's throat or sleep alone. Sir, Bappi Lahiri, our this music king, what would you say? He said to die of the OSA with coronary artery death. So remember that the greatest musician died of it. So be aware of OSA. Please refer the patient to obesity or other diabetic patient to sleep study. Thank you very much.
Thank you very much, Professor D.P. Singh, sir. OSA, of course, a new subject for us, and how it plays the important role in comorbid conditions. Rather, 91% patient had got the night heart attack, and more than 75% patient has got insulin resistant, and diabetes is one of the most correlated factor with OSA. And of course, if the hypertension is resistant hypertension, we should sleep study is one of the indication to do in the resistant hypertension. Chances of the OSA is more probable, and these are all the very nice message to us. Thank you very much. My one question only, the CPAP therapy should be given to which age of the patient of OSA?
You can take up this moderate to severe, this severity, moderate to severe severity, not mild cases you don't have. And
age.
Sir, all this OSA age is more than 50, you know. So some of my friends are taking, some of the friends, even at Bhagalpur, they are sleeping with this CPAP. Yes. But his age is 60.
Thank you, sir. May I
Sir.
ask Dr. Ajay to kindly present the memento to the chairpersons? And to our speaker, Dr. D.P. Singh, sir. So we had poster presentation upstairs. The list which has come to me, we would like to give them the appreciation certificates. First of all, from Kishanganj, I invite Ayush, Priyank Kumar Shah, Balkrishna Kumar, and Pratyush Garg. Please come on the stage. Ayush Kumar, Priyank Kumar Shah, Balkrishna Kumar, Pratyush Garg. कोई है कि नहीं इनमें? They have left. Okay. Abhi, Pankaj, give the mementos, 4 mementos to this. I'm from Bhagalpur, Varsha Kaushik, Shubhan Kumar Sangya, Shiv Kumar Yadav, and Devojit Paul. Please come forward. Dr. Ravi, please honor them. Dr. Ajay, please assist him. Dr. Varsha Kaushik. Dr. Varsha को दिलवा. Dr. Shubhan. Dr. Shubhan. Dr. Shiv Kumar. Shubham, acha, okay, sorry. Dr. Shiv Kumar. Dr. Devojit. प्लीज आप खड़े रहें, कटिहार वालों को भी आप ही के लोग कर दें. From Katiyar, Dr. Akash Sharma, Dr. Samiq Ahmed, Dr. Halal Khan, and Dr. Jisan Ali. They too have left? No? Okay, then you take on their behalf and hand over. Char de do unko. Thank you, sir.
There is one more announcement, and we must honor our master of ceremony, and I request Dr. Deviram sir to, and Dr. A.N. Rai to felicitate our most dynamic young elder brother, Dr. Vinod Dharewal sir. Please come.
Now program is nearing its end, but the last session is going to be excellent, I am pretty sure. We have a symposia whose moderator is going to be our most effective speaker, Dr. Ajay ji, and panelists will be Dr. B.K. Singh, Dr. Rajkamal Chaudhary, Dr. Anand Shakkar, and Dr. Gagan Gunjan. Panelists, please come on the stage. And Abhishek आ जाएं फिर, राजकमल जी नहीं है. Dr. Abhishek, please join. Dr. B.K. Singh, Dr. Abhishek, Dr. Anand Shankar, and Dr. Gagan. Anand Shankar भी नहीं है. Ravi, तुम बैठ जाओ. Now I hand over to Dr. Ajay ji.
A very good evening, dear colleagues. This is a session which is dedicated to some new molecules which has just come in the market within last 1 year. And we would like to have a perspective on those molecules from our expert panel. Dr. Modi has given me a long list of questions. In the interest of time, I will not read out every question, but I will certainly do justice with the topics. And I give liberty of all our panelists to speak. I will not point out any question to anybody. Whichever you question feel like taking, you can take it. The first drug in class that we are going to discuss is imeglimin, which is a very novel molecule because it has got a very peculiar mechanism of action, which is very different from all the anti-diabetic medications which are available that we have been using for last several decades. And obviously, if we have got a new molecule with a new mechanism of action, it is incumbent upon us that we understand the entire science behind it. So let me throw up this question about imeglimin that whichever any panelist would like to come up and tell us what is so novel about the mechanism of action of this molecule.
First of all, I want to take this question. According to this imeglimin, it's a dual mode of action. One is the glucose-dependent insulin secretion.
Just 1 second. Is Dr. B.K. Singh audible to all of you? Okay.
It is glucose-dependent insulin secretions like an incretin effect, and another is it takes care of the insulin resistance also by the decreasing this glucose output from the liver and enhancing the insulin signaling from the adipose tissue and the muscles.
Excellent. Yes. Would you, anybody like to add anything about it?
To add on this, I would like to point out that it is also a mitochondrial dysfunction regulator, which is an important mechanism of cell energy system, and it is very helpful in diabetic kidney disease, and preventing its role has been very well established in that case also.
Right. Yes. So what did we listen? What we heard about imeglimin is that this is a novel class of molecule which has got a dual mode of action. It will improve the insulin secretion from the beta cell in a glucose-dependent manner, and at the same time will improve the insulin sensitivity. And what was added was a very new concept that we are talking about, improves the mitochondrial dysfunction. Now, from anybody in the audience, would you like to tell me that do you really think this is new? You never heard about this particular mechanism of action with respect to any of the oral anti-diabetic drugs in the past? Particularly, it has got a lot of similarity with metformin. How do you see a difference between metformin and imeglimin in this context of mechanism of action? Before the panelists, let me throw this question to the audience. Do you have any idea about this? What is so very different about mitochondrial dysfunction? We never heard about a drug causing action on mitochondrial dysfunction in treatment of diabetes. Did we earlier? No. Metformin has got some action. Yes, excellent. Right. So let me get back to the panelists. Would you like to throw some action on that?
Sir, it has a mechanism of action of drugs may be similar or maybe earlier, or as we all know that metformin was there. But when we are talking right now is overall perspective of imeglimin as a role in type 2 DM.
Right.
That is the point to be noticed. Metformin has got certain side effects which imeglimin does not have. So it is superior to that metformin in comparison to those. So it already adds to the benefits of metformin plus new benefits to the diabetic patients.
I want to say that the mitochondrial dysfunction means what it affects the ATP generation, and as I remember correctly that imeglimin is a 20 points a channel that can level it that will create this mitochondrial function. And imeglimin, this first channel cytochrome 1 and 3 that will effective on that particular channel. But mitochondrial is, we still don't know which part of this mitochondrial respiration it acts. I don't know.
Excellent. So now we have got additional information on this, that when we talk of mitochondrial dysfunction within the cell, first we have to understand what goes wrong in type 2 diabetes. In type 2 diabetes, there is lipid accumulation within the pancreatic beta cell, and that makes it dysfunctional. And when you say dysfunctional, the entire process of metabolism is affected. The amount of insulin which has to be secreted, the amount of electron transfer that has to take place in terms of production of ATP, which is energy for any cell, all that is affected in type 2 diabetes. Imeglimin is the first molecule in its class which will improve this channel transfer of electrons. And as B.K. Singh said, that there are two types of them, 1 and 3. These are the electron transfer systems. And imeglimin is the first molecule which can suppress the channel 1 transfer, which metformin also does. But metformin does not improve the channel 3 function. But imeglimin suppresses channel 1 and improves the function of channel 3, both of them increase the ATP generation and cells become more potent in terms of insulin production, number one. And at the same time, because of this improvement in the mitochondrial dysfunction, there is more production of NADP. You know the NADP enzyme system. And because NADP is produced more in abundant because of the use of imeglimin, again, it is likely to cause more glucose-dependent insulin secretion. And these are the reasons as to why this is supposedly better than metformin in its class. And number two, it very rightly said by the panelists that it improves the insulin sensitivity. And at the same time, when you look at the clinical data, which is now very important, if you have conceptually a molecule which is good, then you have to corroborate this science with the clinical data. So next question to the panelists, what is the clinical data? What is the average HbA1c reduction by imeglimin shown in the various trials? There are so many trials, phase 3 trial, which lead to the approval of a molecule. That is the gold standard trial. So please let the audience know what is the amount of A1C reduction.
All the trials that have been done have shown significant reduction in HbA1c by almost 0.5 to 0.6% in the cases.
Right. So can anybody tell me, particularly the postgraduates, अगर मेथी खाओगे, एक्सरसाइज करोगे या कुछ भी करोगे तो कितना परसेंट HbA1c रिडक्शन हो सकता है? करेला खाने से, सदाबहार का पत्ता खाने से, ये सब से कितना हो सकता है HbA1c रिडक्शन? सबसे होता है. अच्छा, I will rephrase this question. कितना परसेंट रिडक्शन होगा तो हम उसको ड्रग के कैटेगरी में मान लेंगे? International regulatory agencies, the drug approval bodies, give and classify a particular thing as a drug if it leads to 0.4% or more reduction in the HbA1c. So methi karela sadabahar ka patta will do less than 0.4% reduction. So anything which causes more than 0.4% comes under the category of drug. Now imeglimin leads to 0.6 to 0.9% reduction in the HbA1c, right? And most of the other anti-diabetic molecules, except sulfonylureas and insulin and GLP-1 receptor agonists, they also cause 0.5 to 1% reduction in the HbA1c. So it fulfills the criteria of being a good drug. And the other advantages that we talked about was about the dual mode of action, preventing the long-term function of the beta cell. So obviously, it is not the efficacy which matters, but the durability of action will improve because beta cell survival will be prolonged. But at this stage, because this is a new drug, we don't have long-term data. Only when we will have 5 years follow-up data, then we will know that whether this is actually true, what we are saying in terms of mechanism of action. Next question. Yes, Pramodi. First thing, it's not said that it should not be used. At this point of time, imeglimin approval data has also compared it with placebo because you cannot do any study unless you have compared it with placebo, right? So when you have compared it with the placebo and you have demonstrated 0.9% reduction in the HbA1c, it's not that you cannot use it singly, but because it's a new molecule and FDA has not approved, it is only the Japanese regulatory agency which has approved and Indian regulatory agencies have approved it, right? So at this point in time, because of the paucity of data, lack of data, it is said that it is safer that it uses conjunction with other anti-diabetic drugs. But it's not that they don't have data. They have the data that it has been compared with placebo and has shown more than 0.4% reduction in the HbA. This is a political question. Let's not go into this, right? This is a heavy political question. But my next scientific question is, what is the usual dose of imeglimin which was used in the randomized controlled trials? And obviously that translates into how are we going to use it in our clinical practice?
Those trials that have been done with the dosing of 1000 milligram BD, 1500 milligram BD, and 2000 also. But the ideal dose that has been recommended overall, keeping the side effects and other all our safety profiles, is 1000 milligram BD that
Right.
is recommended to them.
So 1 gram BD, which is also generally the dose of metformin, that is the usual dose of imeglimin, but 500 milligram BD can be also used in selected group of patients. And the next question, yes, you want to add something?
Exactly, I want to add at this juncture, the one more important role of this mitochondrial dysfunction related to this. Because mitochondria is related to the cell death also, and it acts on the mitochondrial dysfunction. So cell survival, beta cell survival is more in imeglimin also.
Absolutely, absolutely. Is it safe in renal dysfunction? Can we give it to patients who have got compromised renal function, mild, moderate, and severe renal dysfunction?
So far, safety trials are still pending with cardiovascular and renal outcomes, but in mild to moderate cases, it has been recommended that it is safe to be used.
Exactly. Beyond 30 eGFR, you can continue to use imeglimin, and that was the question, answer to your question, that the usual dose is 1 gram BD, but if the eGFR is less than 45, like metformin, then you can use it in 500 milligram BD doses, right? And the last question about imeglimin is that when you compare with metformin as an add-on drug to insulin, has there been any trial with imeglimin where it has been combined with insulin? And if yes, what was the outcome? How does it help to our patients and physicians?
Trials have been done with imeglimin with metformin and imeglimin with insulin. And in both cases, it was found that on adding imeglimin to either of these drugs had a better outcome in comparison to patient output.
Right. But can you actually put better word for this, better outcome? Better outcome in what sense?
Better, better safety profile, keeping in mind the adverse effects, HbA1c target achievement, and glucose
So
targeted
it
dose
basically
approach.
translates into the fact that if somebody is taking 46 units of insulin, along with 1 or 2 more oral anti-diabetic drugs, and you can see that every week the patient is coming and the blood sugar is not getting controlled and the physician is doomed to increase the dose of the insulin. If at that time you add imeglimin, then suddenly the blood sugar will start responding. And so it has got an insulin sparing effect. You would never like to have a patient to have very high dose of insulin because of the weight gain, possibility of malignancy, and so on and so forth. So if somebody can stop or check the requirement of insulin, that's always welcome in clinical practice. And that is one thing which has been found in the imeglimin plus insulin trial, that it has got an insulin sparing effect. So I will stop the discussion about imeglimin here. Yes, sir. Yes, excellent question. Metformin and imeglimin are absolutely different, even though they have got some similarity in action, and therefore imeglimin can be combined with metformin. Whether you will like to do it or not, that's entirely your individual decision, but it can be combined with all oral anti-diabetic agents and insulin which are available today. Clear? Any confusion, please ask a question. Otherwise, now I will move to oral semaglutide. That is the next drug. This is one drug which has completely revolutionized the management of type 2 diabetes, because I said in the morning, oral semaglutide is a drug which is the first GLP-1 receptor agonist in a tablet form. We had the injectable GLP-1 receptors since 2009. The first availability of liraglutide, exenatide, followed by liraglutide, and there's so many GLP-1 receptor agonists. But for the first time, I talked during my lecture how oral semaglutide scientific innovation was done. Now, I would like to ask the panelists that what is so very special about oral semaglutide? Why do I say that it has revolutionized the management of type 2 diabetes?
We already had injectable semaglutide, and now we are moving towards the oral semaglutide. We know that injectable semaglutide patients discomfort, so patients don't want to take injections and better. So coming to this part, oral semaglutide is a better alternative as compared on the patient part. On our physician part, it is also easy for us to achieve the targeted approach. Since, as you said in the morning, you saw how it bypass the GI mechanism with a snack mechanism and cross. So it is going to be a revolutionary pill for the coming diabetes patients.
No, but Then somebody can say that we can use insulin. Why use 330 rupees? Do you know the cost of oral semaglutide? 330 rupees per tablet. So if it is only very efficacious, then this is nothing big.
It
What
is,
is so special about it?
it is special about is that the weight reduction also.
Yes.
That is, one is the main, it reduces the weight very well. Even the trial has been there, the 50 milligram of semaglutide, and it was found it is around the 7 to 10% of the body weight reduction.
Right.
That is one of the fundamental part. If you reduce the body weight in 7%, you decreases the chances of getting complication of CAD by 57%.
Very nice. So for the first time, you see, we had only two classes of drug, insulin and sulfonylurea, which could give you 1.5% or more reduction in the HbA1c. But both of them were associated with weight gain and hypoglycemia. Now we have an oral molecule, which gives you 1.5% or more reduction in the HbA1c, does not cause hypoglycemia, does not lead to weight gain, in fact, leads to 5% to 10% weight reduction. Next question. Does it have cardiorenal benefits?
Yes.
Does it reduce the cardiovascular events? Does it reduce the progression of renal disease?
Yes, definitely yes, sir.
Where is the data?
One data I just forgotten that one pioneer trial.
Pioneer 6
plus
trial.
6
Pioneer
trials.
6 trial.
Pioneer
What was the result of Pioneer 6 trial?
Exact, I am not remembering the Pioneer 6 trial, but it is found that it has a markedly reduced cardiac benefit
Okay.
in this.
Anybody else would like to take up this question? So I will quickly summarize the results of the Pioneer group of trials. There were Pioneer 1 to Pioneer 9 trials. Don't go into the details. Pioneer 6 trial was the dedicated cardiovascular safety trial for oral semaglutide. Remember the word, cardiovascular safety trial. So in a safety trial, what do? You select 200, 300 or 400 patients and follow them up for a certain period of time, 2 years or 3 years time, and show as compared with placebo that they do not increase the risk of heart disease as happened with rosiglitazone. Remember? So this Pioneer 6 trial demonstrated what? That it is safe. It is cardiovascular safe. It did not increase the risk of cardiovascular disease. But it did not decrease the risk of cardiovascular disease. So it proved cardiovascular safety, but not cardiovascular superiority. Are you with me? Okay. Which class of drug have showed cardiovascular superiority before? SGLT2 inhibitors and injectable GLP-1 receptor agonist. This is oral GLP-1 receptor agonist. Then the next question to the panelist. Why did it not show superiority? Because the trial was not designed for that. Very simple. Yes, these are the nuances that you must understand. When you have a small number of patients, followed for a small period of time, you can only demonstrate safety. But for demonstrating superiority, you have to recruit large number of patients and you have to follow them for a longer length of time. And for that, from Pioneer 6, we have moved to SOUL trial. SOUL trial is a dedicated cardiovascular superiority trial with semaglutide. The recruitment process is complete. 3 years have gone. Next year, the results will come. And then we will know that it is cardiovascular superior. But let's go back to Pioneer 6 study, which Dr. B.K. Singh was mentioning. In cardiovascular safety or superiority trial, what do we see? We see 3-point MACE. What is 3-point MACE? Cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. What happened in this? There was 21% reduction in the 3-point MACE, but it was beyond the line of unity. So it did not reach a statistical significance. What was the outcome with liraglutide, exenatide, dulaglutide, etc.? 9%, 13%, 14%, but that reached a statistical significance. So even though oral semaglutide caused more reduction numerically, but it did not reach a statistical significance because of less duration of time and less number of patients. SOUL trial is expected to bring you that. When you look at the 3 components of 3-point MACE, CV death had a resounding 30% reduction in the Pioneer 6 trial, which was statistically significant. but non-fatal myocardial infarction and non-fatal stroke had 9% or 7% reduction and did not reach a statistical significance. So that's why this is almost, you can make a conclusion that in SOUL trial, we are likely to get cardiovascular superiority. And similarly, another dedicated trial is there to look at the renal outcomes. But again, in the Pioneer 6 studies and the other studies of the semaglutide trial, all the indications are there that it is preventing the progression of kidney disease also. So therefore, it is likely to be cardio-renal safe drug. Next practical question. Suppose your patient comes to you and you say कि भैया एक बहुत नई दवाई है लेकिन बहुत महंगी है क्या आप उसका and if the patient agrees नहीं डॉक्टर साहब हमारे लिए money is not a problem आपको दीजिए. How will you prescribe semaglutide? Semaglutide comes in 3 strengths: 3 milligram, 7 milligram, and 14 milligram. Please throw light on this.
As per, I have not used semaglutide till now, but what literature we have read, first you have to start with the 3 milligram and 7 milligram and go up to the 14 milligram according to the this response to the patient.
Yes. Anybody from the panel who have got personal experience of using semaglutide?
We should start from the lower dose from 3 and then we should move on.
Yeah.
If
Tell the audience
patient-
why.
if the
Why
patient-
from 3 milligram? Why not from 14 milligram?
Because it totally acts in the stomach. I mean, it goes there. It has to work against the acidic pH. So lot many gastrointestinal
Obviously.
problem, dyspepsia.
So you start with 3 milligram only to reduce the possibility of gastrointestinal side effect, particularly nausea, right? Okay. So how do you start? You start with 3 milligram? Yes, only 3,740. I will come to the other part of the semaglutide, which possibly you are hinting at later. Yes, exactly. If you directly put on 7 milligram, that yes, if you directly put on 7 milligram, there will be a lot of problem.
Sir,
You have to start with 3 milligram.
I want to add something.
Yes.
Before you start semaglutide, oral semaglutide to a patient, first you must rule out any previous history of dyspepsia. For that, you do a H. pylori test. If there is presence of H. pylori, first you eradicate that. Then you start semaglutide in proper way.
Okay, so now I will summarize how do you administer semaglutide. You convince the patient is convinced that I will take it. You tell them कि 3 मिलीग्राम का टैबलेट से आपको स्टार्ट करना है. तीनों स्ट्रेंथ का दाम करीब करीब बराबर ही है, 15-20 रुपए का फर्क है. सुबह सो के उठेंगे और उस गोली को अपने बगल वाले डेस्क पे रखेंगे और आधा ग्लास पानी के साथ उसको खा लेंगे. आधा ग्लास से ज्यादा भी पानी नहीं होना चाहिए, आधा ग्लास से कम भी नहीं होना चाहिए. ग्लास का साइज अलग अलग हो सकता है, तो साइंटिफिक आंसर है 120 ml. दारू का 2 पैक, 60 ml का 2 पैक, ठीक है ना. 120 ml water के साथ 1 tablet of semaglutide 3 milligram should be taken first thing in the morning. And most important, for next 30 minutes, the patient should not take anything. No food, no drink, no water, no tea, nothing. If you do that, that small area of high pH, alkalinity that I was showing in the cartoon that I was showing during my lecture, that pH will not be achieved. And then the entire bioavailability will be 0. So it is absolutely imperative that the tablet should be taken first thing in the morning with 120 ml of water, which is half glass of water. And then for the next 30 minutes, nothing should go into your mouth. But you can move, you can do morning walk, you can go to toilet, you can do everything, but nothing should go inside your mouth. Simple. After half an hour, you can take your drugs, you can take your tea, you can take your food, you can do everything, right? So this is 3 milligram. For 28 days, you give 3 milligram and then increase to 7 milligram. And most effective dose is 7 milligram in terms of HbA1c control. Not every patient needs to go from 7 to 14 milligram, but there could be a small selected group of patients who are not controlled on 7 milligram. Then after another 28 days, you go to 14 milligram. But the amount of water, the method of taking will absolutely remain the same. Am I clear on this? Next question was drug interaction. That is what exactly I was going to ask. If there is so much complexity in taking this medicine, obviously it looks like it will interact with many other drugs that we use in our clinical practice, and particularly diabetics have got so many comorbid conditions that it is likely that they would already be taking so many other medicines. So do we have any specific important drug interaction about which the patient should be warned?
Normally, when we are talking about if we are taking up thyroxine in the morning, in that case, there is no significant drug interaction. Drug interaction has been observed of oral semaglutide with levothyroxine, warfarin, and other drugs, pantoprazole also, but clinically significant results have not been seen. So there is no harm in any such a serious drug interaction.
Brilliant. I think in one line he has summarized everything. 99% of the drugs do not have any significant interaction with semaglutide, and therefore it is absolutely safe. There are only two drugs which he mentioned. One is warfarin and the other is eltroxin, which have got some interaction. What kind of interaction? He already said, you have to be more observant. You have to keep an eye on the INR when you are patient prescribing, taking warfarin a little bit more frequently than what you used to do before. Because it increases the level of warfarin, it increases the level of thyroxine, but if this is the therapeutic window, the level of thyroxine will go from here to here, but it will not cross this. Are you with me on this? This is the therapeutic window of eltroxin, and suppose normal therapeutic concentration for this patient is here. By using semaglutide, it will go up to here, but it will not cross this. So still you are in the safe zone, but same thing, if the patient is taking thyroxine, more frequent TSH measurements should be done. If the patient is taking warfarin, more frequent measurements should be done.
One thing is that
No. Whatever you do, that concentration will go up. Now, this is a separate question. If I am taking thyroxine, then when should I take? Because thyroxine also needs to be taken half an hour before breakfast. So, panelists.
so it should be taken first, or you have to take this oral semaglutide, and
Absolutely.
after half an hour you can take eltroxin.
So
One
that
thing-
means the patient has to remain in fasting for 1 hour, which may be a little inconvenient to the patient. So what is the alternative? Take thyroxine in the evening.
After
Absolutely, before dinner.
before dinner.
So semaglutide first thing in the morning, thyroxine half an hour before dinner. That solves the problem. Yes, next question. What about proton pump inhibitors? Because semaglutide leads to GI intolerance, nausea, etc. And most of our patients are anyway gas, right? Everybody is taking PPIs. Do we have significant interaction? No, there is no significant interaction. In spite of reduction in the gastric motility and everything, there is no problem with the concentration of proton pump inhibitors.
Sir, one thing I want to add, one thing is that it increases the level of thyroxine by 33%.
Right. But doesn't go
Go
beyond the
beyond this,
therapeutic window.
33, so you can reduce the dose by 33%.
Exactly. No issue at all. So I will stop here with semaglutide, and next 2 minutes I will discuss a new SGLT2 inhibitor, which is called bexagliflozin. Any idea about bexagliflozin?
SGLT2 inhibitor, what is new regarding other SGLT2 inhibitor? I don't know.
I hunted the literature bexagliflozin. The only new thing is that this is a new SGLT2 inhibitor which has been approved. When I look at the results of the phase 3 trials, I didn't find any significant difference from the existing SGLT2 inhibitors. And so far as the long-term cardio-renal outcome trials are concerned, they are not there. And therefore, at this point of time, all that we can say that bexagliflozin is a drug which has been approved by FDA as SGLT2 inhibitor, but there is nothing special about this molecule, so we can stop the discussion here. With this, I would like to thank all my panelists.
इसका सर कार्डियो रिनल बेनिफिट भी अभी तक पता नहीं है इस पे कोई
But safety pata hai. That's why it has been approved.
Sir, one question from all panelists.
Yes.
That insulin we are talking in a session, non-injectable.
Yes.
Oral insulins are also in
I
pipeline.
think this is not necessary to discuss at all, because when we talk of oral insulin, the first significant outcome results that is expected is in 2010. This is the report I am telling you from the companies which are most advanced in their research on oral insulin. If you make oral insulin also the spray oral insulin, then we have more advanced results with that. Where like asthma medication, you spray the insulin into your buccal mucosa. That is in a much advanced stage, and that has shown significant result. And it acts like analog rapid acting insulins. You understand this? Oral inhalation insulin, it is not tablet, spray insulin, that has shown significant result in controlling the HbA1c, particularly the postprandial blood sugar, as would any rapid acting insulin analogs will do. But still it is not available for commercial use in the market. FDA has not approved, and therefore there is no point in discussing
Sir,
this.
one thing is in oral insulin that I have read, I exactly don't remember the name. It is a phase 3 trial with oral insulin, which will taken at the night. And it will act 24 hours for that. And Farmed 0801, as I remember, is the pill which is in advanced stage of phase 3 trial.
Yeah, but whatever advanced stage, the first results are expected in 2010.
Yeah, but nasal spray and buccal insulin having a
Sorry,
buccal spray insulin.
2030, right?
Yeah, but nasal spray insulin and buccal spray insulin have got positive effect, and pharma people are already in the process of marketing after.
Yes.
It will be in the market.
Yes, Lohani. In non-alcoholic fatty liver disease or in treatment of obesity, right now it is not approved. But looking at the mechanism of action, it looks like that this is going to be a blockbuster molecule to treat both obesity and to treat non-alcoholic fatty liver disease. And then combining your question and Dr. Deviram sir's question, 3, 7 and 14 milligram doses of semaglutide are for treating type 2 diabetes. Reduction in the body weight is an additional benefit. But now oral semaglutide has been subjected for treatment of obesity without diabetes. And there are 2 studies. One is the Pioneer Plus study, and the second is the Oasis study. Pioneer Plus study is diabetes plus obesity, and Oasis study is only obesity. Both have completed phase 3 trials. You will be amazed to know that in the Oasis trial, there is 15 to 20% reduction in the body weight. But it is not 3, 7 and 14 milligram. It is 25 and 50 milligram of oral semaglutide. Then you will say कि भैया 14 milligram तो tolerate ही नहीं होता है, 25 और 50 milligram कहाँ से tolerate होगा? Because that's a different drug. It is a new formulation. It is not this semaglutide. It is oral semaglutide. Technicalities are same to make it orally possible, but it is a separate molecule, and therefore the incidence of gastrointestinal side effect is not higher. In this year's ADA in San Diego in June, we heard all the data about Oasis trial, and it is definitely going to be approved by FDA because all the trials are complete. So that is 25 and 50 milligram purely for reduction of obesity. We don't know because it is not yet approved and it is not in the market. No, I'm sure it will change. We'll see. So with this, I think we are quite late. I would like to thank all my panelists and to all of you who have shown so much interest so late in knowing the science and the scientific developments. Thank you very much.
May I request Dr. D.P. Singh sir to please honor the panelists and the speaker. Moderator. So now I hand over the stage to Dr. Deviram, veteran, for valedictory function.
Dr. A.K. Pathak, Dr. S.P. Singh, Dr. R.K. Modi on the dais, please. अब बारात विदा होने का समय आ गया है और आप लोगों ने जो कोऑपरेशन किया एज ए फैकल्टी, एज ए डेलीगेट इन द पैनल डिस्कशन, वो जस्ट रिमार्केबल रहा। हमारी टीम ने जहां तक हो सका अच्छा से अच्छा परफॉर्मेंस करने की कोशिश की है और सबसे बड़ा हाईलाइट ये रहा कि आज के इस कॉन्फ्रेंस में दवाइयों के अलावे की बातों पर ज्यादा ध्यान दिया गया। ऐसा देखा गया है कि जो फिजिशियन बूढ़ा होता है या एल्डरली या सीनियर होता है, उसकी दवाई की मात्रा घटती जाती है और भाषण और डांट की बात बढ़ती जाती है। हमारे एक मरीज ने हमको पिछले सप्ताह ही कहा कि आप इतना बिगड़ते क्या है। हमले मेरा नाम है डॉक्टर डाटू राम है, इसलिए हमको तो डांटता ही है। थैंक यू वेरी मच इंडीड। हमारे बैकग्राउंड में काम करने वाले जो फार्मा के बॉयज हैं, कैटरिंग स्टाफ है तथा प्रेस और इलेक्ट्रॉनिक मीडिया है, इन्होंने भी काफी इसको हाईलाइट किया और काफी सपोर्ट किया। जब आप कोई प्रोग्राम करते हैं तो ऐसा संभव है कि छोटी बड़ी गलतियां जाने या अनजाने में हो गई हो, तो उसके लिए हम लोग आपसे क्षमा चाहते हैं और हम चाहेंगे कि आप उस गलतियों को यहाँ ही भूल के चले जाएं। और हमारे टीम के जो लोग हैं, अजय कहाँ गया? हाँ, जैसा मैंने उस समय कहा था कि कई वीक से ये लोग टायरलेसली काम करते रहे हैं और इतना इंथुजियाज्म, इतना जोश और सबसे बड़ी बात है कोहेजन। मैं प्राउडली कह सकता हूं कि हमारे पूर्णिया में हमारे फिजिशियनों के बीच में जितना कोहेजन है, आपके आशीर्वाद और भगवान की कृपा से ये बना रहे, तो यही हमारी सबसे बड़ी उपलब्धि होगी। अनलेस कि हमारे पैनल के लोग और कुछ कहना चाहें, लेट हो गया है, आप लोग सभी थक गए हैं और हमारे फिजिशियंस और उनकी फैमिली के लिए डिनर पार्टी आज ऑर्गेनाइज है विथ ऑर्केस्ट्रा एंड ऑल दैट। और पता नहीं मैं रिक्वेस्ट कर सकता हूं कि नहीं, हमारे जो बाहर से आए सम्मानित अतिथिगण हैं, अगर आप भी रुक जाएं तो सोने में सुहागा हो जाएगा। थैंक यू बोलना, थैंक यू, थैंक यू, थैंक यू।